On behalf of the Uveitis Society of India, I welcome you all to the annual meeting of the Uveitis Society of India between the 8th and 10th of October. You can look forward to basic sessions, challenging cases with meaningful discussions, free papers, and keynote lectures from our experts. Moreover, it will be nice to see everyone, at least virtually this year. Please register and participate in this meeting. Looking forward to seeing you all soon. Bye.
Hi. It's usually that time of the year when we all meet for Uveitis Society of India annual conference, but considering the situation, it's not going to be possible this time. But the academic feast is going to be there, although virtually. So looking forward to see you all virtually and part of the academic deliberations. Thank you.
So a very good morning to all of you and welcome to the third day of the USICON 2021 conference. I think we've had very fruitful past 2-day meetings and look forward to the sessions today. So our first session for the morning is therapies in uveitis. We've been talking of a lot of diagnostic dilemmas and management problems. So we look forward to the presenters today giving us some solutions. So I would now request Dr. Somshila Murthy, who is the chairperson of this session, Dr. Alok Sen, Dr. Debashish Das, and Dr. Avinash Gurbakshni. They are going to be the panelists for this interesting session today morning. A very good morning to all of you. And now I would go on to Dr. Sabyasachi Sen-Gupta, who is going to be speaking to us on clinical trial results from paper to practice.
Thank you so much to the Uveitis Society of India for this opportunity. So, because this is a session on therapies, and a lot of these therapies come from clinical trials. So I thought we'll discuss a little bit about how we actually translate practice. How do we adopt the therapies which are coming out of clinical trials and apply it to patients on a one-on-one basis. So I'm Dr. Sabyasachi Sen-Gupta, and I'm a practicing vitreoretinal surgeon in Mumbai. A quick trivia is, do you know which is the first formal clinical trial, randomized clinical trial that was done? So this was on use of streptomycin in tuberculosis in the year 1946, and this is an actual paper that was published as a result of this trial in 1948. So this is officially the first recognized randomized clinical trial, and this design has now been, of course, it has populated, and we are still using these methodologies. So how do you, have you ever wondered how do you really apply clinical trials to practice? And it's not really always easy because, you're one-on-one with the patient and there's a lot of data which is floating around in your mind. And, so if there was a template-based way of applying all of these to actually your patients on a one-on-one basis, it would really be helpful. And it's, like I said, not always easy. You want to see whether, the drug is safe, as in what were the phase 2 trial results, whether the drug is as effective as you think and as the patient hopes. So this was phase 3, which is generally the efficacy-based results. So it's not always easy to assimilate information from multiple trials and apply it to your patients. So, let's start and see a template-based approach on how you could do this. So there are basically 5 steps you need to consider and ask yourselves relatively quickly if you want to apply some of these trials. These are the 5 steps in a nutshell, and I'll discuss a little bit about each of these. So first thing is you need to look at the inclusion criteria of the trial. Then you need to look at the variability of the how similar your patient is to those in the trials. What were the interventions used? Then assess outcomes, and of course then look at your own data and see whether they're matching up to the trials or not. So first thing is the inclusion criteria. So does your patient fit the inclusion criteria that were used in the clinical trial? A good match, if your patient is a good match, and that they would actually have a good chance of getting enrolled into that trial, hypothetically, then you can expect results similar to the trials. But if your patients are quite far away from even the inclusion criteria of these trials, then you may not expect similar results. And let's also understand that these trials have very stringent inclusion criteria, and you will find that a lot of patients don't even fit into the inclusion criteria of these trials, and hence you may not get similar results to the trials. So, we'll keep populating this template, and at the end, we'll have a good idea of how to do this. So first, look at inclusion and exclusion criteria. The second thing is to look at variability from the trials and assess how your patients differ from those enrolled in the clinical trial. In other words, look at the baseline characteristics of those patients in the trial, and then see how your patients are different from those in the trial. And so if baseline characteristics are very different for your patient, then the results will be different. Say, for example, if the mean macular thickness was, say, 380 microns in a particular clinical trial, and your patient sitting in front of you has a macular thickness of, say, 700 microns, it's very far away from those in the trial. So then you may not expect similar results, but then if they are very similar, then you can have similar results. So, how do we really do this is you can establish the profile of an ideal patient who participated in the trial, and look at how different your patient is. And if there is more than 25% variability, of your patient from those in the trial at the baseline, then you may not expect similar results. So this is the second thing that we do. The next thing is that look at all the interventions in the trial and choose the arm of treatment from the from the clinical trial that shows the best outcome as far as possible for your patients. Say, for example, intravitreal injections. If you're looking at outcomes, then maybe if your patient is a pseudophakic patient and you're treating diabetic macular edema, even an intravitreal steroid might actually be a good choice for your patients, given affordability and other things. So try and choose the arm of the clinical trial which shows the best outcomes for your patients. There are a lot of different study designs that you should also think about when you're looking at these. Non-inferiority is a concept which we can't go into the details now for lack of time, but that is something that we also should be thinking about. And so there is a lot of data in terms of which is better, which is not better. This is slightly better, that is significantly better. So you need to sort of try and tease out which arm is probably the best for your patient. Like I said, there's a lot of data floating around, so you need to have some idea of what is happening and basic idea of how to interpret data. So try and choose the intervention which is best for your patient. Then, of course, assess outcomes. So judge whether outcomes mentioned in the trial are being replicated in your clinical environment. I think this is imperative, and most of us are of course, doing this. Also, remember that the results from the clinical trial, are generally far, far better than results from real world or real world evidence does not match up to clinical trials. And then in our own settings, these may even be even more inferior than papers which are published on real world evidence, right? So we have to try and see that this mismatch does not always happen. This is examples which show that over a period of time, even in the CAT trial. So this is on neovascular AMD. Vision keeps dropping despite when patients leave the clinical trial arms and go into the real world, the vision continues to drop. So like I said, this is going to happen, but we have to try and minimize differences between clinical trials and the real world. And finally, we need to collect our own data and analyze, publish our real world outcomes and show whether trial results are replicable in your own clinical settings or not. So this is generally the whole template that is good to follow if you are looking to apply clinical trials to your own practice. So in summary, look at inclusions, look at variability, and if it's more than 25% different, then you may not have great results from the direct application of the trials to your practice. Choose the best treatment arm as best possible. Think about non-inferiority and adhere to treatment protocols as best possible. Assess outcomes and collect your own data. Make it a practice to collect your own data after treating a good number of patients. Analyze how your results are obtained and how they differ from clinical trials. And you may sometimes find subgroups of patients that respond well and some who do not respond as well, given your own context. So, this is, I think, something which we really need to inculcate. And this is a quick example of how we do this, where this is from the protocol T for treatment of diabetic macular edema, where the inclusion criteria were, patients for more than 18 years old. They had predominantly, type 2 diabetes with vision of 6/9 to 4/60, and some other exclusion criteria such as renal disease and uncontrolled hypertension. But when you look at a particular patient in the trial, it was a 60-year-old white man or woman with type 2 diabetes for about 17 years with fair glycemic control, were hypertensive obese, and the average vision was 6/24 with a macular thickness of 450. Most of them had mild to moderate NPDR with some previous treatment in the form of lasers or even anti-VEGFs. And the intervention was aflibercept was slightly better in terms of, if the baseline vision was poor, aflibercept slightly better, and the loading doses were done, and there were multiple injections required for most patients, right? About 8 or 9 injections. So we need to discuss about affordability and discuss with patients. But most important is to look at this. So is your patient a 60-year-old with relatively good diabetes control and a macular edema 450 with a vision of around 6/24? So if yes, then you would expect similar results if you adopt a strategy of of a loading dose and then multiple injections. So this is essentially a direct application and an example for you to understand. How do you interpret a paper is also something which is very important. We need to use recommendations of a trial which is robust enough. So how do you really judge this is also something which is important. For that, you need to read the full text, read the methods of the paper, again, read the results and look at the p-values, 95% confidence intervals, read the discussion and the context of the results with literature, and critique the paper. That is, try and find faults. You can use checklists from the Equator network. But I think it's very important for us to also understand how to read these clinical trials. And so I have a lecture on which is there hosted on my YouTube channel, and you can take a look at this. And also there are some similar points with examples on applying clinical trials to practice on my channel if you want to take a look at that. And this is my website on teaching. So there are some lectures on understanding how to interpret published papers, and you can take a look at them as well. I'm happy to answer questions now or at the end. Thank you so much.
Thank you, Dr. Sabyasachi. I know it's a very vast topic, and this is the best you could have done in a small time as 10 minutes. We can surely make out the vast experience you have in clinical research because you've been running a very successful academy. And I'm sure for the young researchers, it's always a treat to visit your academy and learn much more from you. I would just request a quick comment from the panelists and from the chairperson if they have anything to add, which is going to help the attendees and the young researchers.
It's been a lovely talk, and Dr. Sabyasachi Sengupta has been working on individual clinical clinicians for their own studies, which we are aware of it. And I think many of our doctors have been helped by him in their clinical trials. Thank you, Dr. Sabyasachi.
Thank you, sir.
It's very important that I think as clinicians, we understand the clinical trials because patients now are getting more and more aware. They look online and they ask you, what is the evidence? What is the proof? And when you have a better understanding of how these trials are conducted, you can give them a more realistic idea of what to expect, why you're treating them. And so it's a better contract between you and the patient.
Yeah, I completely agree, Sabyasachi. It was a pleasure listening to your talk. The point that you made about real world scenario being very different from clinical trials. One point I had to add is because of the follow-ups also. In a trial setting, we are very intensive about follow-ups and compliance. And that's not going to happen in the real world. And that will also alter the results. So we have to, if you said 25% parameters do not match, you also have to look at if the follow-ups are going to be, also not matching. Maybe you can add a percentage to that. Then you have to discount that result that much more for your practice. But excellent. Thank you so much.
I have a question for you, Sabyasachi. Very often we have the fellows approaching us and saying that, with the limitations that they have, like when they're only focusing on their clinics and their ORs, what would be your tips when they are just plunging into doing clinical research? I mean, there would be something which they can start at the level of being a fellow.
I think that's a great question. And I think documentation is, first and foremost in terms of, it may help you later on. And, JB sir is one example who, we all learned from, and the way he documents, all his patients for the last 30 years. So document. I think that would be one, very good way of starting. If you have documentation, then you can actually put them all together in an Excel, analyze, write papers later on. But if you haven't documented, if you have not done that critical OCT at that critical juncture, you're not going to have enough data to start off. So I think that is the first and foremost that people should probably, it's a very relatively simple thing to do, but often forgotten.
Dr. Avinash, I just wanted to ask you, you worked in an Indian scenario and now you are at Moorfields. What is the difference that you find, and something that you would suggest that we can change in our clinics while practicing in India, which you found was an asset over there?
Yeah, I think because of the volume of patients in India, sometimes, we are compelled to go plow through the patients. And so, as Dr. Sabyasachi said, that, the documentation is not complete. So I think that reminding yourself that in the long run, it's much better to have the data available. And in spite of the high volume, you must keep a good record. So keeping that record of your patients, of the different diseases, etc., will really pay dividend later on. So don't be daunted by the high volume. Stick to what you need to keep. So that's very important.
Thank you. So I'll move on to the next talk now by Dr. Mudit Tyagi, and he would be speaking to us on real-world evidence of Ozotex in non-infectious uveitis. Dr. Mudit is a senior consultant at LV Prasad Institute, Hyderabad, and he has keen interest both in uveitis and retina. Over to you, Mudit.
Thank you so much, ma'am. Thank you so much. So first of all, I would thank USI for this wonderful opportunity, and thank you for this great conference. I know we are not able to meet physically, but this virtual conference is so amazing and so enriching in every sort of a way. So while Sabyasachi was speaking about clinical trials and how they can become a part of our practice, I would be speaking on evidence of Ozotex in non-infectious uveitis and how Ozotex has actually made quite a huge amount of difference in the way we approach some of our patients. Yeah. So we all know that corticosteroids essentially are a mainstay of treatment for all anatomical subtypes of non-infectious uveitis, in terms of whether they are oral steroids or topical or surgical implantation of what we used to do for retisert or periocular or intravitreal injections. And the fact is that steroids have always been one of our most important tools in armamentarium in our fight against uveitis. How do steroids act? We all know that they basically inhibit the inflammatory mediators. They also have an effect on VEGF, and through that they reduce the vasodilatation and leukostasis. And through all of these effects, whether it's on inflammation or macular edema, they are a boon to treatment of steroids. But the fact is that when we give systemic steroids, they come with their own gamut of side effects, whether it's hyperglycemia or aggravation of myopathy, secondary infections, impaired wound healing. We have had patients who have had a mental state change. We have had some of our patients who have developed a steroid-induced psychosis subsequently. Obviously, adrenal suppression, bone changes, osteoporosis. There are multiple side effects which systemic steroids bring into picture. So it's like a double-edged sword. While it's a boon for uveitis, it comes with its own plethora of side effects which can affect a patient. There have been studies which have shown the quality of life of patients who are on systemic steroids does get affected because of the use of systemic steroids. And that's where local administration of steroids comes into picture. So what are the advantages of intravitreal implants? They help in overcoming the blood-retinal barrier, allow drug delivery in a therapeutic level at a target site. They also give us the advantage of a prolonged drug delivery. And obviously, because of the fact that it's a local application of steroid at the target site, they reduce the complications of frequent or adverse systemic side effects, as well as because of a prolonged delivery, they reduce complication of frequent injections also. Now, one of the initial landmark trials was the multi-center uveitis study treatment trial, which evaluated the effect of fluocinolone acetonide for intermediate uveitis, posterior uveitis, and panuveitis, and it did show efficacy of fluocinolone in treatment of these diseases. However, obviously, there was a significant component of cataract and glaucoma in the implant group. Now, if you look at the implants which are available, the non-degradable ones are the retisert of the fluocinolone implant, and we also have a biodegradable Ozotex or a sustained release dexamethasone implant, which is injectable, significantly easy to use, has got 0.7 milligram of dexamethasone embedded into it, and is usually effective for something around 4 to 6 months. Now, while there are some studies which may say that the implant holds good for 6 months. Our real world evidence and our own clinical practices show that at least for 3 to 4 months, it does provide us a significant cover of steroids to tide over the inflammation in some of our patients. One of the earliest papers which we had was by Dr. Biswas and his group also, which showed the efficacy of Ozotex implant in treatment of non-infectious intermediate uveitis. And we have had quite a few papers and quite a few of literature which has been coming in on the efficacy of Ozotex implant in intraocular inflammation. One of the papers as early as 2012 had shown that they used this in 12 cases of recalcitrant edema, and uveitis activity decreased in all of the patients after the implant. Similarly, another series where they had used Ozotex implant for patients less than 16 years, again, it showed its significant efficacy and safety. There have been studies which have done a long-term evaluation of dexamethasone implant in non-vitrectomized as well as vitrectomized eyes, and again, all of them have shown favorable results with the use of the Ozotex implant. One of our papers, which came in 2016, showed where they evaluated in 15 patients. Again, these are some of the trials which I'm enumerating, which basically have all gone on to show how use of an Ozotex implant has been an effective adjunct and also in some cases an effective replacement to use of systemic steroids in non-infectious uveitis. Another paper where they tried to analyze the use of this, and they did a systemic analysis or a network meta-analysis of comparison of corticosteroid implants where they compared 0.18 milligram fluocinolone as well as dexamethasone implant, and they found that there were studies where the dexamethasone implant was associated with better results initially at 1 month to 3 months with a lesser frequency of development of cataracts. However, the fact is that compared to fluocinolone, though the dexamethasone implant has got a shorter duration of action, 4 months to 6 months probably, as compared to 12 months to even more than that than what fluocinolone does offer. But dexamethasone also has been effective in all of these cases. There was another recent very interesting paper which evaluated the result of this implant in pediatric age group also. And in those also they found significantly good results. So even in pediatric eyes, and we have actually tried it in some of our young patients. And this is a patient, I know that subsequently Dr. Dhanshi Ratra will be speaking on refractory uveitic macular edema in the next talk. So I'll not dwell much upon this. And I'll just show you a few of our cases where we use this. This was one of our patients who had been initially on systemic steroids as well as immunosuppression. Over a period of time went on to develop liver function impairment and increased glycemia, hyperglycemia, uncontrolled diabetes, and therefore we had to stop the systemic steroids as well as immunosuppression because the patient was developing a hepatic impairment. And we gave the patient an intravitreal Ozotex implant, and this is how the patient responded. The visual acuity also improved from 20/100 to 20/20, and the cystoid macular edema also completely regressed. Another two of our patients where we used dexamethasone implant in these unilateral cases with extremely good results. So these were three of our initial cases, and this is a case of a 25-year-old male patient. Again, with these changes, you can see a disc edema, cystoid macular edema, on FFA, perivascular leakage. This patient unfortunately went on to develop a steroid-induced psychosis, and therefore we had to discontinue systemic steroids, and the patient was given an intravitreal Ozotex implant. And post the implant, this is how the cystoid macular edema responded. The central foveal thickness reduced to 161, visual acuity improved to 20/25, and therefore this was one more patient where we could subsequently easily manage the uveitis just with the use of the implant. So my take-home message, I would just summate all of this and all of the things. We have actually, in fact, in two of our patients of VKH also tried Ozotex implant, and the reason was that there was patients who were absolutely not willing to take immunosuppression and systemic steroids, and they had sustained significant side effects. So tied over that crisis, we used a dexamethasone implant in two of our patients, and we are still having them under follow-up. But in a nutshell, sustained release dexamethasone implant can be a boon in refractive uveitis, non-infectious uveitis, specifically unilateral cases, and cases where systemic steroids and immunosuppression may be contraindicated. However, before I close, a word of caution: it is important to rule out infectious uveitis. No intraocular implant, no intraocular sustained release steroid implant should be given to any eye till that time you have absolutely ruled out an infectious uveitis. Using a long or sustained release implant in an infectious uveitis without an antimicrobial cover can be catastrophic. So while they can be a boon in these eyes where you have got a non-infectious uveitis, it's our role to first of all ensure that we are dealing with a non-infectious uveitis in the first case, because we have had some cases where we have had reactivation of ARN or toxo, where the patient was initially thought of as non-infectious but turned out to be ARN. So it's important for us to rule out infections before we go on to inject these implants. And with that, I would like to end my talk, and thank you so much, and I'm open for questions. Thank you so much.
Thank you, Mudit. And since the next talk is also on Ozotex, I think it would be good if we have the second talk, and then after that we take up the questions and have a brief discussion. So over to you, Dr. Dhanashree. So Dr. Dhanashree, she's a very senior vitreoretina consultant from Shankar Nethralaya, Chennai. And she has a vast experience in managing both medical retina, surgical retina, as well as cases of uveitis. So over to you, ma'am, and we look forward to your talk.
So at the outset, I would like to thank USI and Manisha for this opportunity. It gives me great pleasure to talk to you about dexamethasone intravitreal injection for refractory macular edema. And there will be some repetition from what Dr. Mudit has already spoken, so please bear with me. So just to give you a idea about the burden of disease that we face, non-infectious uveitis is the prevalence is found to be about 9.6%, and non-infectious uveitis is that uveitis which is related to all these systemic disorders. Now, a vast majority of these uveitis patients, nearly up to 20 to 70%, experience major vision loss, and about 10 to 15% will also become legally blind. So although there are many causes of vision loss in uveitis, macular edema forms the major chunk of these causes. And to again give you the perspective, nearly 40% of these non-infectious uveitis can develop macular edema. It can start in acute phase along with active uveitis, and it can go on to persist long after the active inflammation has subsided. And this has been termed by a few authors as refractory macular edema. Some authors have also defined it as that macular edema which does not respond to the usual topical or systemic medical treatment. And now nearly about 40% of macular edema can become refractory. So it is important to know how we can deal with this such type of refractory macular edema. So the general therapeutic considerations obviously remain the same, that you start with topical corticosteroids and systemic steroids, can add periocular steroids, then go on to systemic immunosuppressives or biologics. But all these treatments need to be continued for a very long time, because in uveitis, the macular edema can persist for months or years together. Now, I need not again elaborate on the systemic side effects of systemic steroids, and this audience is well aware of that effects. Also, the risks of periocular steroids such as globe rupture or muscle injury, subdermal fat atrophy, etc. So the best option here is the intravitreal steroid injection, and as Dr. Mudit has already highlighted, the advantages of intravitreal steroid is that the therapeutic agent is directly delivered to the target tissue, and the dose is much lower, and yet it can achieve a very high concentration. The action is rapid, and at the same time it is sustained for a very long time. And all these side effects of periocular and systemic steroids can be avoided. So the type of intravitreal steroids which are available to us in India are triamcinolone acetonide and dexamethasone implant. The fluocinolone has been evaluated but not available in India. Now, just to give you some information about triamcinolone, now this is the patient who has received triamcinolone injection, and this causes some vitreous hairs, so some amount of vision is disturbed initially after the injection. But however, triamcinolone is widely used as a 2 milligram or 4 milligram intravitreal injection. It has a half-life of 18.6 days in non-vitrectomized and about 3 days in vitrectomized eyes. But the desirable drug concentration can last up to 3 months. And in one study, it was seen that compared to systemic steroids, the triamcinolone injection led to earlier resolution of macular edema. So triamcinolone is highly effective. It can lead to improvement in nearly about 50 to 70% of patients, and in shorter duration of macular edema, less than 1 year, or in younger age and non-vitrectomized eyes, it has quite a favorable response. But the chances of cataract and intraocular pressure rise is quite high. Nearly 40 to 70% patients can develop cataract and glaucoma, and these risks are higher with repeated injections. So compared to that, Ozotex, which is a very elegant dexamethasone delivery system. This is a pen-like device which has a 22 gauge needle with a silicone sleeve, and it has a biodegradable implant which is contains 700 micrograms of dexamethasone. This can be injected into the vitreous cavity. It floats in the vitreous and does not lead to any visual obscuration, and it can last for nearly 4 to 6 months. So this was dexamethasone implant is being used since 2009 for various disorders such as diabetic macular edema or vein occlusion. In 2011, the Huron study reported it to be safe and effective in non-infectious uveitis. Thereafter, many studies have evaluated the Dexiplant, and Dr. Mudit very elegantly showed us a lot of studies. There would be some repetition, but please bear with me. This is our study which we published in 2018, where we looked at 42 eyes with refractory macular edema who were treated with dexamethasone injection. A few important points which I would like to highlight from our study is that we saw that there was rapid resolution of macular edema. Even though the macular edema was very long standing, nearly about 3 years, it resolved very quickly within 3 months. And the effect was maintained for a very long period, nearly 6 months, and some of the patients even for up to 18 months. None of the patients in this study required a repeat injection before 6 months. And the macular edema, even if it recurred, it was never more than the baseline. And the most important that it showed that it led to a drastic reduction in the need for concomitant systemic steroids and immunosuppressives. It nearly halved the need for systemic steroids, thus making the treatment much safer without less side effects. The incidence of cataract and increased IOP in this study was found to be low. Several authors have published their results in chronic macular edema, and this result by Kang et al. Have also reported nearly about 70 to 80% efficacy of dexamethasone in chronic macular edema. Sang et al. Also have again shown nearly about 70% efficacy, and the effect lasted for 6 months in their study as well. This is a study where treatment failure eyes were treated, and they did show good improvement with more than 2% visual improvement. And this was mentioned by Dr. Mudit also. This was in vitrectomized eyes. So there is a little concern of using it in vitrectomized eyes. But in vitrectomized eyes, even after vitrectomy, the macular edema can persist, and dexamethasone implant is a good option in such situation. They reported nearly 50% efficacy with very minor side effects. Pediatric uveitis is again a challenging situation because the macular edema can persist for a very long time, and it is difficult to treat these children. There is limited literature available, but they have shown good improvement in even pediatric cases. However, the risk of cataract progression is much higher in these pediatric eyes. And there are some isolated reports about treatment in sarcoidosis related uveitis, and there is one report from the PGI group about dexamethasone in TB related uveitis such as serpiginous choroiditis, etc. But again, I would also caution that infection must be ruled out, active infection must be ruled out before you can give intravitreal dexamethasone implant. A few prospective studies have also been reported with dexamethasone implant, and just to maybe highlight that most of the authors they have uniformly reported about 70 to 80% efficacy of dexamethasone implant, and most of them have shown that the effect lasts for nearly up to 6 months. So this is very much heartening because in diabetic macular edema the effect wanes very quickly, maybe about 3 to 4 months, but in uveitic macular edema it can be sustained for 6 months or even longer. Very recently, in just about May 2021, the multicenter uveitis steroid treatment trial reported the 7-year outcomes of uveitic macular edema. And to highlight their conclusions, they reported that nearly 94% of the eyes had resolution of macular edema at some point during the 7 years follow-up, but the relapse rate was much higher, nearly reaching 50%. So perseverance is the key here, and you need to continue to follow up such patients and continue to treat for a long time. However, in the presence of epiretinal membrane, the likelihood of macular resolution, macular edema resolution reduced, and this needs to be tackled differently. So this is a small algorithm published by Coronis et al., which shows you how to treat the macular edema, uveitic macular edema. So obviously in infectious cases, you need to treat the underlying cause and control the inflammation. For non-infectious uveitis, again, you need to start with controlling of the inflammation. In mild cases, you can probably just treat with topical steroids, topical NSAIDs, or sometimes supplemental steroids. But if you have in unilateral cases, again for mild, just use the periocular steroids. But for moderate to severe cases, intravitreal steroids is a good option. If the mild cases do not respond to periocular, then they can also be switched to intravitreal steroids. In case there is a vitreomacular traction or epiretinal membrane development, then vitrectomy can be a good option in such situation. But if the patient has uncontrolled glaucoma or if the patient has a bilateral disease, then the first line of treatment remains the systemic steroids. But sometimes intravitreal injection can be added to an eye which has got a better, worse situation of macular edema. And if uncontrolled, then you can go on to the immunosuppressives of the biologic. So thank you very much for your kind attention.
Thank you so much, Dr. Dhanshri. I think that was a very extensive talk on utilizing intravitreal Ozotex. I think there were quite a few questions which Dr. Mudit has already answered. But I was just wondering that what about pregnant females coming to our clinics with uveitis? I mean, where would you place? I think Ozotex offers a good alternative for managing these patients. So I would like a quick comment from all the panelists. And what other tricky situations of uveitis where you would make Ozotex stand over systemic therapy?
Yeah, with the pregnant females, it certainly is a very useful drug, and we've had many patients who have either fallen pregnant or planned pregnancy, and we can modulate their treatment over that short period with Ozotex. It's also useful, I think, with the around surgery. So whenever you're planning any surgery in uveitis, whether it's a cataract surgery or vitrectomy or even tube surgery, giving Ozotex either 1 or 2 weeks before or even during the surgery has I've found it hugely beneficial in preventing inflammation after the surgery. I'm sure that my colleagues have similar experience.
So if you've given an Ozotex about 2 weeks prior to a vitrectomy, would that not wash away the effect of the drug?
No, if you can retain the implant, so as long as you don't eat up the implant, it continues to work. So you can retain the implant. Or you can give it at the time of the surgery or even post-surgery. It's the one thing that lasts after vitrectomy.
Dr. Biswas, any comments from you, sir?
Instead of answering, many of my patients ask me that how many Ozotex injection you are going to give to me. So it's a recurrent cystoid macular edema. I don't know whether we have got answer. So can you say that this is the number which we maximum we can give?
Dr. Biswas, I've given several repeat Ozotex, sometimes even 2 monthly in some patients. But recently, last couple of years, anybody who's needed recurrent or repeat Ozotex, I've used the fluocinolone implant, and it works beautifully as well. Much better for uveitis than for diabetes. So the fluocinolone also is a great option. But repeat Ozotex has not been a problem, especially since it's biodegradable.
So how many is that the patient? C6, 5, or so yes, or there is no number.
There is no number.
Yeah.
We have seen patients who have received more than 6, 7 Ozotex implants. And sometimes when you see with indirect ophthalmoscope, you can see the previous implants which are partially degraded, but that the kind of that mold you can see remaining. But it has got, it does not have much problem, and you can continue to give repeat intravitreal Ozotex. So there is no problem in giving repeat, except that you may have to look at cataract progression or glaucoma, because with repeat injections, these risks will be a little bit higher.
Yes, Dr. Alok.
Just wanted to know from Dhanashri ma'am, that what is the threshold for repeat Ozotex, or and when do you decide to go for PPV, like recalcitrant edemas?
Yeah. So as I mentioned, the uveitic macular edema is actually shows better results than diabetic macular edema, and the result and the effect of this Ozotex implant can last much longer. So we can continue to follow up these patients for 6 months or even longer. And there have been patients who have been, resolved with just one Ozotex injection as well. So for the PPV is not it is not recommended so early in the course of uveitic macular edema as compared to the diabetic macular edema, where we think, because PPV itself is not the answer for resolution of macular edema. Sometimes the macular edema may persist even after the vitrectomy. But my indication of PPV would be, one would be to, of course, if there is vitreous haziness, then it would also help in clearing the vitreous haziness. If there are any interface abnormalities like vitreomacular traction or retinal membrane, then obviously that would also be beneficial. In such cases, you would do vitrectomy rather than giving repeat injections. And if you have a very recalcitrant, very persistent macular edema, which is simply not responding to multiple injections, say probably 2 or 3 injections, then you can plan for vitrectomy.
If I can just add, Manisha.
Yeah, please go ahead.
Yeah. So the excellent talks by both Mudit and then Dr. Dhanashree just pretty much covered the topic. So I'm talking more for the uveitis as a cause of the macular edema. So I think that in these cases, Ozotex plays more of a role of bridge therapy. So if I have a patient who needs 6-7 injections, I would relook and see why this is happening. And my go-to treatment would obviously be oral immunomodulation or systemic immunomodulation as a long term. So if a patient, only in the case of the instance of patient who cannot take any other form of medication, oral or whatever, and therefore in those cases we can probably keep repeating it. So either it's bridge therapy or it could be like a sort of an enhancement of whatever therapy is going on. But it can't be that every 2 months a patient comes with CME due to uveitis and then we give Ozotex. So it's not long term in any way. I don't know if there's any disagreement with what I'm saying.
No, I agree. It's a good adjuvant because, again, there's been in a few meetings, I've seen people using it for VKH. Now, this is a systemic disease, so it needs systemic treatment. So it's very good as an adjuvant, especially for macular edema. So you may be able to control the background inflammation, but for some reason, sometimes the macular edema doesn't resolve with the systemic treatment. And that's when the intravitreal treatment really helps, and they work together. So I totally agree that we have to treat the cause. But just going back on that previous question, is that would anyone preempt? So if you know that in your patient who has recurrent, needs an injection every, let's say, 5 months, would you at 4.5 months repeat the injection, or would you wait for the recurrence?
So Dr. Vaishali can take the answer.
Like Somshala said, we have to keep the background inflammation under control by giving systemic treatment most of the times, because the edema is coming from some peripheral leak or something which we are ignoring, and that is why it is recurrent. Edema is not going to recur on its own. So I would use Ozotex as a top-up therapy to take care of the acute episode of edema and to give the background immunosuppression to keep that leakage under check so that the edema does not recur. However, if at the end of 3 or 4 months, I see the edema coming back, at the earliest, I would top it up with Ozotex, not waiting for it to go full-blown, because that compromises the photoreceptors and each episode leaves behind some residual damage, permanent damage to the vision. But that's also a wake-up call to do a wide field angiography and to identify if the immunosuppression that you are giving needs to be revised. Because if that is under control, you should not need more than 2-3, uveitis cannot be endlessly managed with Ozotex. So if you need too many, like Somchila said, something is not right. So you need to look at why is it happening.
I'll take a last comment from Dr. Sabyasachi.
Thank you. Just a quick sort of caution is, so I've used it in all these different kind of indications, and I have seen when you have 4 or 5 repeat injections, and mostly I'm speaking from a diabetic macular edema perspective, some of my patients have developed CMV retinitis after multiple Ozotex injections. 2 patients had CMV retinitis, and one had a sudden acute hypertensive anterior uveitis, which turned out to be herpetic on PCR. So a little bit of caution if we are looking to use too many repeat injections can cause immune suppression to an extent where patients might have some amount of retinitis. Looks like a vein occlusion, and it's not sometimes easy to identify and differentiate. But just a quick caution to remember if we are using 4 or 5 or more injections.
Well, thank you. And I think we'll take up more questions at the end of the session. I'll move on to the next talk by Dr. Saurabh Luthra. And Dr. Saurabh, again, is a practicing vitreoretina consultant at Drishti Eye Institute, Dehradun, and has a keen interest both in uveitis and retina. And he would be speaking to us on anti-VEGFs in uveitis. Over to you, Saurabh.
Good morning, all, and thanks to Dr. Vishali, Dr. Manisha for this opportunity. So we all know that chronic intraocular inflammation leads to increased production of inflammatory cytokines. In patients with uveitis, aqueous humor VEGF levels are increased in CMO, also in CNV, and even in patients with retinal neovascularization. The treatment of uveitic CMO should be focused on controlling the underlying inflammation, and steroids or immunosuppressive agents are the gold standard at this time. It seems reasonable to consider intravitreal anti-VEGF therapy on a case-by-case basis in patients with refractory uveitic CMO. So this is a recent review by Dr. Biswas's group, and they said that although anti-VEGF agents may not be as effective as various steroid agents due to limited anti-inflammatory action, they are associated with significantly lower rate of cataract progression or rise in IOP, and thus can be an effective supplementary therapy in these patients. This is a case report of a CRVO in a TB-associated uveitis, which initially remitted by repeated intravitreal ranibizumab injections as an adjunct to ATT and systemic corticosteroids, but subsequently PRP laser was required for vitreous hemorrhage along with a vitrectomy. While the acute complication of CNV is being treated by anti-VEGF therapy, attention should be focused on underlying inflammatory disease. And this is a review by Dr. Foster's group. So retinal neovascularization and disc neovascularization can occur in uveitis secondary to peripheral retinal ischemia from occlusive vasculitis. The treatment of uveitic retinal neovascularization should focus on treatment of the underlying inflammatory disease, as well as laser photocoagulation to areas of ischemic retina. So the new thing which we have, which especially the PGI group is doing in India, is that granulomas or tuberculomas have been shown to respond to anti-VEGFs. Reduced oxygen tension in choroidal granulomas and increased expression of VEGF in the retinal pigment epithelium and photoreceptors has been demonstrated in animal models of ocular tuberculosis. Ollers et al. In their study suggested pharmacological inhibition of VEGF pathway, which may result in decreasing infection load, reducing angiogenesis in granuloma, as well as limiting the spread of infection. Also, there are case reports by the PGI group. And this is one of the first ones by Professor Amod Gupta. With highly vascular nature of the tuberculoma is evident clinically on FFA, and intravitreal bevacizumab in addition to systemic corticosteroids and ATT led to prompt regression of the granuloma and prevented visual loss. And repeated injections were given in this patient. This is how you can see the good resolution with anti-VEGF in the tuberculoma. Another report from PGI where ranibizumab monotherapy was led to complete regression of vascularized TB granulomas. And this is, seeing nice OCT pictures with the flattening of the tuberculoma after anti-VEGF therapy. So this is a nice paper which says that granulomas are morphologically similar to solid cancerous tumors. They contain hypoxic microenvironments and can be highly fibrotic. And they identified a novel therapeutic target for TB, the abnormal granuloma-associated vasculature that contributes to the abnormal granuloma microenvironment. And anti-VEGFs, antibodies for cancer and eye diseases, as we have been using them, is able to create more structurally and functionally normal granuloma vasculature and improve the delivery of a low molecular weight tracer. This suggests that vascular normalization in combination with ATT has the potential to enhance treatment in patients with TB. So I'll show you a few cases. So this is one case of a bilateral aggressive eels, left more than right, managed over 5 years with 5 courses of systemic steroids, 1 year of second-line ATT with a positive quantiferon TB gold test, and had 5 sittings of PRP laser. Very aggressive case. We've been managing this, and Dr. Biswas has helped me manage this, co-manage this case. Underwent left eye VR surgery, cataract surgery with SOR, and finally had a glaucoma valve put in the left eye for NVG. So this required a very persistent, and it was a very recalcitrant case. And anti-VEGFs came to our rescue, as you can see in these pictures. And at 5 years, the patient is finally maintained, and for the past 2 years has not been on systemic steroids. So this is a second case of an 18-year-old boy with serpiginous-like choroiditis with multiple recurrences who has received several courses of systemic corticosteroids, azathioprine, and 1 year of second-line ATT, and also has secondary glaucoma. And both eyes have undergone trabeculectomy. This was also co-managed with Shankar Netralaya, with Dr. Biswas and Dr. Vijaya. And you can see the very bad, choroiditis in the right eye with macular scarring. And in the left eye, it was threatening the fovea. And PCR was positive for MTB genome. And the patient was given ATT and also started on systemic steroids and azathioprine. Finally, the choroiditis healed, although the patient continued to have disc edema, as you can see in this picture. And finally, the patient developed a CNVM in the left eye, which was just inferior to the fovea. And after giving intravitreal eccentrics, this resolved, the CNVM resolved with the fluid also resolving. Somehow the disc edema persisted for unknown reasons in this case, as you can see at the last follow-up. This is a third case of bilateral recurrent serpiginoid choroiditis in a 35-year-old gentleman. You can see these deep lesions in the juxtapapillary region. And investigations, HRCT chest was done, and RPR TPHA was negative, and the HRCT chest showed apical fibrotic lesions and mediastinal lymph nodes with pleural thickening. And patient was put on ATT, and this is the OCT in the right eye and in the left eye. So patient continued to have multiple, episodes of inflammation with cystoid macular edema and neurosensory detachment. And this was the FFA ICG picture of the right eye and the left eye. And it was again a very recalcitrant case. Despite giving ATT and immunosuppressants, patient would come back with cystoid macular edema and neurosensory detachment, even with the tapering of topical steroids. And also he developed a steroid response, and he was having high IOPs for which he was on 4 medications. So finally, this patient presented to us with a CNVM in query CNVM in both eyes, because we could see some changes on the OCTA. And this patient received anti-VEGF injection in both eyes, and you can see nicely that the macular edema and NSD resolved. And currently, patient is stabilized on systemic methotrexate and topical anti-glaucoma medications. This is my last case. Actually, this is the same case which Professor Amod Gupta had published in 2013. This is a 44-year-old female. I saw this patient initially here in my city, and the patient was on ATT. And she had this lesion which showed, as we all know, as Professor Amod Gupta has nicely described, this chorioretinal anastomosis, or a type 3 neovascularization with a central hemorrhage in this lesion, and intense leakage on FFA. And the Montu was 30 by 30 millimeters. HRCT chest was normal. Quantiferon TB gold was positive. Patient was put on ATT and systemic steroids. Subsequently, patient was managed at PGI, where an intravitreal Avastin injection was given twice, and the SRF resolved. And post this Avastin injection, this is the picture of the OCT. And the PET CT showed hypermetabolic subcarinal right tracheobronchial and cervical lymph nodes. And on follow-up, the patient developed a large subretinal abscess in temporal macula. And subsequently, over the subsequent years, patient has been managed with second-line ATT with systemic steroid and multiple intravitreal anti-VEGF injections, SOS, for recurrent SRF. So it has proven to be a very nice adjunct to ATT and systemic immunosuppression. And these are the last pictures which I recently received. Again, patient is being followed up at PGI and receiving anti-VEGF injections for these recurrences of subretinal fluid. This is a nice review by Douglas Jabb's group, where they kind of summarize that VEGF plays an important role in the pathogenesis of uveitic complications such as CMO, CNV, and RNV. blockage of VEGF has not been shown to have an anti-inflammatory effect. Treatment of the underlying inflammatory disease should play a central role in the management of uveitic CMO, CNV, and RNB. A two-pronged treatment regimen that focuses on achieving disease quiescence through the use of corticosteroids and or immunosuppressive agents while treating complications that arise despite adequate disease quiescence with intravitreal anti-VEGF agents may be useful. Thank you.
Thank you, Saurabh, and for highlighting all the various indications for using anti-VEGF in patients of uveitis. I have a few questions posted. Since we are running short of time, I'll just take up these questions before we have any discussion. So Dr. Minija, she wants to know what would be the dose of moxifloxacin and duration of treatment as a second-line drug in ocular TB. Maybe Dr. Vishali can take up this question. Is Dr. Somshila, would you like to answer that? Yeah, Dr. Vishali is there.
This is role of Moxiflox as second-line therapy. Is that right?
Yes, ma'am.
I don't give second-line therapy myself. When I reach a stage that patient needs second-line therapies, my pulmonologist decides what to do. But levoflox is a part of it.
And there is one more question by Dr. Sunita that we keep saying that you must rule out an infectious etiology before we inject any kind of local steroids. So how would you go about making sure that you're not dealing with an infectious etiology?
You know, the kind of infectious etiology we need to rule out is the obvious infection, which I think we cannot really miss looking at the phenotype. Like, for example, if there is a kind of a granuloma, which you are not sure about, if there is a patch of retinitis, which you don't know the diagnosis, if there is vitreitis with some funny looking multi-retinitis lesion, which you are not sure of, those are the kind of infections we are talking about. When you are either talking about autoimmune disease process or a process which is a sequelae of infection, I don't think you actually need to look for NGS and other things to rule out infection before giving Ozotex. It's just the obvious infection you should not be, or something which you do not know what it is. Don't be in a hurry to inject Ozotex.
I think I totally agree with Vishali, because we had a case, I had seen the patient first. Somewhere else, Ozotex had been injected and the patient had an active tuberculosis lesion. And that I went into a disseminated tuberculosis and I was lost and was managed at PGI, but somehow it could not be salvaged. It was too late because the Ozotex had, done the damage till then. So we have to be very careful while injecting Ozotex and rule out, infectious cases of uveitis.
Yeah, but if I can just add one point, but this is like what Dr. Vishali said. Most of the times, these are clinical clues. You will be able to identify most of these clinical infections. Like what ma'am said, obvious retinitis, you will be able to probably detect a toxoplasmosis which is underlying, or those multiple miliary lesions which may point to probably an underlying syphilis or whatever. But in most of the cases, you will be able to rule out infections on the basis of a good clinical examination. And like what ma'am said, that is one of the most important. If in doubt, pause and don't be in a hurry. So those are the two messages which I think as a group we should pass on to the doctor who's asked the question.
Right.
And Saurabh, just one small comment, though I have been highlighting this, that we have been actually measuring the VEGF levels in TB granuloma patients. And to our utter surprise, we found that they were at least 5 to 6 times higher than what we find in AMD patients. And we actually measured it and we found it to be something in the range of 1500 picograms per ml in a tubercular granuloma, in comparison to what has been measured as about 200 in AMD CNVMs and about 180 in active TB cases, pulmonary TB cases. So I think it is quite, interesting, the concept of treating these granulomas with a local therapy of anti-VEGF. And, whatever few cases that we have treated, we found that the regression was, very fast. I do not second that we do not give ADT or systemic corticosteroids because we have to treat the underlying infection. but these patients have responded very fast. And when we compared it with those patients in whom we were just treating with ATT, we found that the scarring was also much lesser because the regression of the granulomas was much faster. But yes, it's a very limited experience, which I just wanted to share. And maybe, we can...
I totally agree with you. I have not measured the VEGF levels, but when I see vascularized TB granuloma, I don't wait for 4 weeks. I repeat injections at 2 weeks and it works. But mine is not as meticulously, it's more of a clinical acumen. But I agree the VEGF in inflammation is probably very, very high compared to AMD or other conditions.
So, ma'am, you would be surprised that we have been treating our granulomas with every week injection of an anti-VEGF.
Probably, yeah.
Yeah, because, it takes a long time for them to get them down from such a high level.
So like Dr. Biswas says, probably USI should take this up as a project because, this is something which will make difference in the practice patterns.
Absolutely.
I think we are on track right now.
So thank you so much. And I thank all the panelists and our chairperson, Dr. Somshila. We've had a very interesting session on some local therapies in uveitis. And let's move on to the last and the most awaited session of free papers. And I hand it over to Dr. Reema Bansal to take over as the moderator.
Thank you very much, Manisha.
Thank you.
Thank you.
Very good morning. Thank you, USI, and thank you, Dr. Vishali and Dr. Manisha. So we welcome all the uveitis enthusiasts to the most exciting session of this meeting as the free paper session. And it's my honor to invite the judges. We have a esteemed panel of judges for this session, Dr. Amod Gupta, Dr. Carl P. Herbert, and Dr. Monsef Khairala. I would like to just highlight that the timer would be displayed on the side of the gallery view for the speakers. There would not be any buzzer. We do not want to disturb you. But if you cross your time of 6 minutes, the slide share will be stopped by the technical team. So we start with the first presentation by Dr. Nitin Kumar, who will be talking on clinical profile of uveitis patients with Bloss syndrome and experience from a tertiary center in North India.
Good morning, all. So the title of my presentation is Clinical Profile of Uveitis Patients with Bloss Syndrome and Experience from Tertiary Care Center in North India. Bloss syndrome is a rare autoinflammatory disease which is characterized by autosomal dominant inheritance, and most of the cases occur in a familial or a sporadic form. The disease occurs due to gain of function mutation in NOD2 gene. The classical clinical triad which is seen in these patients is a granulomatous polyarthritis, uveitis, and dermatitis. The granulomatous polyarthritis is the most common manifestation and generally occurs by second year of life. It is a non-deforming symmetrical type of a polyarthritis. Dermatitis generally occurs in the form of an intermittent disease, which is a macular papular rash, and generally occurs by the third year of life. Granulomatous uveitis as such is the manifestation which increases morbidity and is refractory to treatment. However, the disease can be commonly misdiagnosed as a GIA or ocular tuberculosis, especially in the endemic setup. So the aim of our study was to report the clinical profile in a cohort of patients with genetically proven Bloss syndrome. As it is an enigmatic condition, it is important to highlight the clinical features, presentations, and long-term follow-up of these patients. So ours is a retrospective case series which was conducted in PGI Chandigarh. From the enrollment occurred from years 2005 to years 2020. All the patients who had a diagnosis of BS confirmed on genetic mutation analysis were included. Their demographic, clinical, immunological treatment profile was noted. So coming to the results, this is an exhaustive slide. I would like to highlight the important features. The 6 patients were included, 12 eyes of 6 patients were included in this study. There were 3 males and 3 females. Most of the patient had joint involvement in the form of a boggy swelling, which had prompted us to look for the diagnosis of Bloss syndrome. Skin involvement could be seen in 5 patients, in 1 patient only, and 5 patients did not have any signs of skin involvement. As far as the anterior segment findings were included, presence of BSK cells and complicated cataract was seen in 8 of our patients. One of the patient also presented with bilateral iris granulomas. As far as the posterior segment findings are concerned, multifocal choroiditis scars was seen in 10 eyes, and 2 eyes had a disc hyperemia with mild vitritis. Initial diagnosis was considered to be GIA in most of our patients, and only in one patient we could establish consider the diagnosis of BS from the early presentation only. As is highlighted in the chart, most of our the time of revision took to the diagnosis of BLAS was from almost 1 month to 10 years in our patients. Also, most of our patients required immunosuppression. This was either double immunosuppression or triple immunosuppression. Only one patient was maintained on methotrexate. As is highlighted, most of the patients maintained a good visual acuity, and at the follow-up, which ranged from 7 months to almost 20 years, most of the patients maintained quiescence at the end of the follow-up period. So to highlight, one of the major things which came out of this study was that age of initial presentation, age of developing arthritis, as well as the diagnosis of BLAS. The duration to establish a diagnosis of BLAS was slightly higher as compared to previous studies. These are the varied presentations. We can see BSK, presence of iris granulomas in one of the patient, the characteristic multifocal choroiditis scars in the periphery. Also, one of the patient presented with vitritis, and a different kind of presentation was this vasculitis in 2 eyes of one of the patients. Also, we can note that the pan-uveitis was the most common presentation, occurring in almost 90% of the patients. We could not see papillary nodules in any of our patients. Almost 7 eyes developed secondary glaucoma, and one of the patient also developed signs of systemic granulomatous inflammation in the form of kidney and liver involvement. So when we look back into the literature, most of the cases reported from Indian subcontinent are in the form of, especially from India, are in the form of case reports. And one of the largest case series from South India came up in 2020 by Babu et al. In most of these series, the initial diagnosis was JIA. So when we compare our series with the international registry as well as the series by Babu et al, we can see that pan-uveitis as well as multifocal choroiditis was seen in almost all of our patients. However, they have not been reported so commonly in the international registry by Sarens et al. Also, mean age of uveitis was slightly higher in our series and also from the South Indian series. However, the cystoid macular edema, which was documented in almost 11% of the patients in the international registry, is not documented in any of the Indian series. So to conclude, BLAS-associated uveitis has protein clinical manifestations. Childhood uveitis with joint involvement should not be considered synonymous with GIA, and we should always keep a differential of BS, especially when the patient has boggy swelling of the joints, has ANA negativity. So these diagnoses should be concerned. These patients require aggressive immunosuppression, and long-term follow-up is important to maintain systemic as well as ocular remission in these patients. These are my references, and I acknowledge my mentors at PGI for giving me this opportunity to present this paper. Thank you so much.
Well, thank you, Nitin, for a wonderful presentation. I invite the judges for the questions.
Well, good morning, Monsef and Carl. Nice to see you.
Good morning, Gabert. How are you?
Yeah, I am doing great. It's too early for Carl in specifically, very, very early morning, I believe.
Extremely early.
5 o'clock or 5:30. Oh my God. You're doing a great favor to USI for being up so early. So, Monsef, my question to Nitin, very nice presentation, 6 cases, it's a big number coming from a single institute. Since most of these cases are confused with JIA, would you give us quick cues when you start suspecting that this might be a BLAS syndrome and not the JIA? Especially because the BLAS is extremely rare and JIA is so common. So what cues would prompt you to to a genetic, heterozygous state for not to, gene in these
Yes,
patients?
Yes, sir. Good morning, sir. So the main clues which we can get is that GIA is mostly a non-granulomatous type of inflammation and generally involves the anterior segment. However, blouse causes more of the features which involve the whole of the uvea, causes pan-uveitis, and the inflammation is more in these kind of patients. We should continuously look for the posterior segment manifestations in our patients and look for signs of any multifocal choroiditis in these patients, which will not be common in patients of GIA. So a very important point is to keep on looking into the posterior segment, as these patients are generally younger. We might sometimes have difficulty in examining these patients, but it is very important to continuously have a look at the posterior segment and look for the manifestations in the back of the eye.
I think that you made a very nice point that you need to, you may not be able to dilate these people because of posterior synec and BSK. So it may be a challenge to do a posterior segment, but with current ultra-wide, non-magnetic cameras, you might be able to photograph these patients. The second point is how important is it to have the complete triad? Like you said, none of your patients perhaps had dermatitis, which is an essential component of Blow syndrome. And the swelling of the joints was forgotten, because 2 years is the average age where they would have that granulomatous swelling. And by the time they present to you, they might have forgotten what it was. How is the swelling or joint involvement in JIA different from Blow syndrome?
Sir, so mostly the joint involvement is in the proximal joints are involved in case of Blow syndrome, and a characteristic boggy type of swelling is seen, which is in the form of a synovial involvement, which is generally seen in Blows and
for the ophthalmologists, they may not be very familiar with what is proximal, what is distal, what is boggy, and what is synovial. So why don't you tell us how do you tell the difference?
So mostly in case
of polyarticular, quasi-articular, I mean, how do you decide? Is it polyarticular? What are the typical joints involvement in these children?
So
large joints?
Yes, sir. Yeah. The joints involved will be the large joints, the knees, the wrists. However, in case of also the arthritis will mostly a non-deforming kind of a uveitis arthritis in case of Blows.
It is JIA also. It is non-deforming, no?
Yes, yes, sir. Yes, sir.
Yeah. Well, thank you, Nitin.
Thank you so much.
Nice presentation. Yeah.
Thank you, sir.
Yes, we have a question from Dr. Karl, please.
Yes, how important is it to perform genetic tests in these patients to confirm the diagnosis?
So, sir, the diagnosis is it is important because otherwise these patients would be only considered as a GIL-like of manifestation, or in the endemic countries where the granulomatous uveitis is also seen in case of tuberculosis, we will keep on mistaking these patients for either GIA or tuberculosis. So it is important to get the genetic testing when we have clinical features like boggy swelling and this granulomatous inflammation of the eye.
And in these cases, you all the time have genetic confirmation in your cases?
Yes, sir. All these 6 patients were genetically confirmed to be have a NOD2 mutation.
Okay, thank you.
Thank you, sir.
Dr. Monsif?
I would like just to mention that sarcoidosis may be a differential diagnosis for this kind of uveitis. Maybe more frequently than GIA.
Yes.
And it is important to note that the diagnostic delay was so high. So I agree with Ahmad that it is important to pay attention to the clinical features, and to maybe to consider Blow syndrome, sarcoidosis, and other etiologies of pediatric uveitis However, it seems to me easy to differentiate Blow syndrome from GIA, and maybe the differential diagnosis with sarcoidosis could be harder than differential diagnosis with GIA.
So thank you, Dr. Monsef. So with this, we now move on to the next presentation of the session. Dr. Ankush Kavali will be presenting his next paper on topical interferon therapy in pseudophakic macular edema.
Good morning all. So I'll be presenting a case series of topical interferon therapy in pseudophakic macular edema. Pseudophakic macular edema is not an uncommon complication seen in clinical practice, and failure of conventional treatment is not a surprise. Although steroids are highly efficacious, the IOP and infections are the concern. And anti-VEGF therapy frequently declined by the patient due to the cost factor and invasive procedure. Systemic use of interferon in uveitis is well known. It has been used for uveitic macular edema as well as pseudophakic macular edema. But the flu-like symptoms, retinopathy, invasive procedure, and cost limited its use. Intravitreal as well as posterior subclavian injection with interferon has been given successfully in case of AMD as well as diabetic macular edema, but a recent report of perilesional interferon given for OSSN has shown to cause retinopathy. The very first use of topical interferon therapy has been done by Maliki et al. In their case of a refractory pseudophakic CME, and subsequently a randomized control trial with topical interferon therapy has been shown in has been conducted in diabetic macular edema, which has shown statistically insignificant decrease in CMT. So the aim of our study was to evaluate the efficacy of topical interferon in pseudophakic macular edema. This was a prospective interventional case study. The consecutive patients diagnosed with pseudophakic macular edema were included. Overlapping macular edema of other etiology were excluded. The patients were given two choices: the conventional treatment for the macular edema versus the novel treatment with interferon drops. Those drops were prepared from commercially available interferon alpha 2B injection, which comes as a pre-filled syringe for subcutaneous use, which was diluted with 2 cc of water for injection to make a 3 ml of interferon drops. The drops were handed over to the patient with the instruction to store in the refrigerator door and to carry with ice packs and use it 4 times a day. So this was the very first case. A 63-year-old presented with a history of 6 months ago. He underwent a cataract surgery, which was complicated with the PCR, underwent vitrectomy elsewhere, then received intravitreal antibiotics, and then topical and oral steroid for his macular edema, and subsequently IVTA twice. So at the presentation to us, he was off steroids since past 2 months, and the last IVTA was given 3 months ago, and he was only on bromphenic since past 4 months, and this was how the macular edema looked like. So after the consent, the patient was put on topical interferon therapy 4 times a day, and to our surprise, within a week, there was a significant improvement. The QID dose was continued for 6 weeks and then slowly tapered down over 6 months. And at the 7 weeks follow-up, the macula was completely flat. After stopping the interferon therapy, we had 16 months of the follow-up and no recurrence was noted in this case. So this table shows how the macular edema decreased at 2 weeks follow-up, at 1 month follow-up. But if you can see, there was one patient who had recurrence at 2 months follow-up, which affected the mean value. And this table shows the CMT decreased by how many microns. So as you can see, at 2 weeks and 1 month follow-up, there was significant improvement. We also had 4 cases who presented with macular edema more than 500 microns, and more than 30% of reduction was achieved at 2 to 4 weeks follow-up. So this table demonstrates what is the time duration taken for the resolution of the macular edema, as well as the follow-up and relapses. So here we can see the mean resolution occur at 5.3 weeks, and the mean follow-up with the interferon was 4.5 months. We had 5 patients who had relapses during the follow-up or after the stopping interferon therapy. But if you look at the reason for relapses, most of them were defaulters. In case 8, the occult uveitis manifested after 13 months of the presentation and 3 months after stopping the interferon therapy. All our patients had PCR except for case 8. So this table shows the prior medication given for CME, the medication at the enrollment, and the medication after the enrollment with IOP and best criteria visual acuity. So as you can see here, we had 2 patients who received no treatment before, but only topical interferon. In both the cases, macular edema resolved and without any recurrence. Only one case had a side effect in the form of papillary conjunctivitis, which resolve with a short course of fluoromethanol eye drops. So this series confirmed the effectiveness of the topical interferon therapy in pseudophakic macular edema. In contrast to Malik et al.'s case, our cases showed dramatic response within weeks, and we believe it could be because of the presence of PCR in most of our cases. The topical interferon is much more convenient and cost-effective as compared to the recommended doses of subcutaneous interferon therapy for pseudophakic macular edema. Topical interferon monotherapy can be a preferable option when we are hesitant to start steroids, or to avoid invasive procedure, or to avoid costly anti-VEGFs. In conclusion, topical interferon therapy can be a non-invasive, economical, and effective alternative option to the conventional treatment of macular edema, and its usefulness as well as adverse effect profile should be explored in a larger series with long-term follow-up with of pseudophakic macular edema as well as other forms of inflammatory CME. Thank you.
Well, thank you, Dr. Ankush, for a very nice presentation. So over to the judges, please.
Yeah, can I ask him a question, Rima?
Yes, sir, please.
Yeah, my question is, Ankush, I heard you say that you offered them a standard of care therapy. If you had compared, in fact, with the topical therapy, like Nipafenac or Bromfenac, you might have been able to see whether it's non-inferior or equally efficient in resolving macular edema. And second question is, I'm not sure if there is any pharmacokinetic data available about the penetration of interferon from topical application. If you mentioned that, I missed it perhaps, but I would like to be informed of that. And how practical is it? Because that is what you felt. 2 or 3 patients, they had recurrence because they couldn't prepare this. This is a homemade solution of interferon. I mean, is it a stable solution when you make it? What is the stability of this solution? I mean, when you want to recommend it as a routine use compared to standard therapies that are available, I'm not sure how far it is practical to prepare.
So to answer the first question, the most of our patients, they were already on treatment with this NSAIDs as well as topical oral steroids. Many of them, they also received IVTA once or twice. So all those conventional treatment were tried initially, except for the 2 patients who said they don't want anything. Actually, the trial was during the lockdown period and the pandemic. So those 2 patients who received only monotherapy, they refused the use of any steroids. So they preferred these drops, and most of the cases, almost 8 cases, they already on treatment with his NSAIDs drops and steroids, which has failed. So after stopping the steroid, the macular edema was recurring, and that time we preferred this to start offer the new treatment with the interferon drops. So yes, the preparation of the drop is well, the drops commercially not available in India, but they are available in other countries like Russia as well as in China. So the preparation is simple. The syringe comes as a subcutaneous injection of 3 million units, 1 ml syringe, which has to be diluted with the water for injection, and 3 ml of these drops has to be kept in a refrigerator door. So the cold chain has to be maintained at 4 degrees. So even if the patient want to carry it, they have to carry it along with the ice packs. So that thing is there.
We have a question.
What about the pharmacokinetic?
Yeah, pharmacokinetic, yes. So even I'm not aware of any penetration studies with this topical interferon, but there are few case reports of interferon which has been given intravitreally as well as a posterior supplements, but nobody has studied, to my knowledge, the penetration of the interferon in the vitreous cavity.
So don't you agree that first we have to know the pharmacokinetic and its penetration into the intraocular compartments before labeling that this is working like magic bullet, because spontaneous recovery of CME is well known. So unless you have a very well controlled trial and compare it with standard of care, because if you have a mishmash of oral steroids, intravitreal steroids, topical anti-inflammatory agents, you've tried them all, and then you add this and claim that this was because of this. And, you know, topical preparations for some of the countries you mentioned, and I would not like to even comment on some of them, you know.
So the randomized control trial with the topical interferon has been conducted for the diabetic macular edema. They had 50 patients, and looking at since the drug is very safe to use, I think it's a good option for the patient who have recurrent CME despite conventional drops and conventional treatment for the macular edema as a choice of treatment, because patient can develop steroid side effect in the form of glaucoma and infections. So I think it's a better option for the patient to offer.
Thank you, Ankush. We have a question from Dr. Karl.
Yeah, I have a quick question. Do you know the molecular weight of interferon alpha?
No, sorry, I'm not looking into that.
This is a follow-up to Amod's question, you know, whether this really penetrates, you know. Okay, thank you.
Dr. Monsif?
Just a comment regarding your patient. I think that all your patient had been treated with conventional therapy, so it is important also to look at the potential effect of this drug on treatment-naive patients. And I agree with Dr. Gupta that we need prospective studies to evaluate the efficacy of safety of this approach compared to standard of care, or we can also consider placebo-controlled studies. It is interesting to look at a new treatment for this complication of cataract surgery, and sometimes we have some problem with the prognosis and we need probably new approaches, and this is a new approach that requires more investigation.
Thank you, Dr. Monsif. So with this, we now move on to the next presenter. Before that, I would like to point out to all the speakers to note down the points that have been raised by the judges, because they're very critical and they help us a lot when we plan to write these presentations for publications. These are critical inputs which have a lot of value and improve our quality of paper for submission. So over to you, Dr. Abhinaya, who will be speaking on SARS-CoV-2 and conjunctival swabs, possibility of a delayed or persistent response in the eye as compared to the nasopharyngeal mucosa.
Good morning, everyone. Thank you for the opportunity. I'll be talking on novel coronavirus and conjunctival swabs, possibility of a delayed or a prolonged shedding on ocular surface than in nasopharyngeal secretions. So the background of our study was that ocular secretions do remain a potential source of respiratory viruses, including the SARS-CoV-2 virus, but the knowledge about the shedding or the role of the ocular tissue as an alternative mode of transmission needs further understanding. So the associations between COVID and eye are various. Ophthalmologists are at high risk, and the risk of transmission of the virus to the ocular secretions are by two hypotheses. One is the direct transmission, and other is the possibility of retrograde migration of the virus from the nasopharynx. With this basic understanding, we went ahead to detect the presence of SARS-CoV-2 RNA in conjunctival swabs of COVID-19 in patients and its viral RNA load as compared to the nasopharyngeal swabs. It was a cross-sectional study done including the COVID-19 patients hospitalized in PGIMER, Chandigarh, India, and the critically ill patients were not enrolled. All the patients underwent conjunctival swab collection, which was transported in the viral transport medium and stored in -80°C, following which the RNA was extracted with 140 microliters from the QAMP viral RNA minikit, and the detection of SARS-CoV-2 RNAs were done, and the following genes were assessed: the open reading frame ORF1 gene, the N gene, and the E gene. The values were interpreted as cycle threshold value less than 40 considered as positive. A subsequent or second nasopharyngeal specimen was collected based on the Ministry of Health guidelines at that point of time. So at the end of this, 93 COVID-19 patients were included who were nasopharyngeal swab positive, followed by a subsequent conjunctival swab collection, out of which 17 patients turned out to be positive in the conjunctival swabs. Details of 56 patients regarding the nasopharyngeal swab CT values were obtained. Statistical analysis were done using SPSS software at 5% level of significance. Coming to the results and discussion, the mean age of our group was 47 plus or minus 15 years with predominance of males, and majority included asymptomatic COVID illness patients. Coming to the clinical and demographic details between the conjunctival swab positive N17 and the swab negative group is as follows: the age, the gender, the COVID-19 disease severity, the systemic comorbidity, and the immunosuppressive therapy were comparable between the two groups. However, an interesting point to be noted was that the mortality rate in the COVID positive group, conjunctival swab positive group, was higher than that of the conjunctival swab negative group, though it was statistically insignificant. These findings raise the hypothesis of whether the detection of SARS-CoV-2 on the ocular surface has association with the disease course, outcome, or any prognostic value. Coming to the duration, the baseline nasopharyngeal swabs were collected with a mean of 3 days, conjunctival swabs with a mean of 9 days, and the time difference between the collection of the two swabs was around 6 days. And majority of the conjunctival swabs were collected in week 1. The inference from this was that the time difference between the collection of both the swabs was statistically significant. The other details regarding the demographic and clinical profile between the two groups were comparable. An interesting point to be noted was that majority of the conjunctival swab negative patients, the swab was collected during week 1, and the swab in the conjunctival swab positive patients, around 50% was collected in week 2. So whether these two findings indicate that the highest detection rate of SARS virus in conjunctival swabs during the mid phase, that is the second week of illness rather than the first week, is a new possibility to be explored. And this favors the theory of retrograde passage of the virus from the nasopharynx onto the ocular surface. These are a few studies which were published in 2020 regarding the coronavirus in ocular secretions. The positivity rate in conjunctival swabs in these studies were 3.5% and 2.78%, which was very less as compared to our study, 18.36%. This can be indicated because in these studies, the samples were taken either immediately along with the nasopharyngeal swab or within a median of 7 days, whereas in our study, majority of swabs were taken during week 2. This again favors that the viral replication may be increased in the ocular surface during the mid phase of illness. Comparing the CT values of N gene and ORF gene between the nasopharyngeal swabs and the conjunctival swabs, they were found to be comparable, even though there was a significant delay in the conjunctival swab collection compared to the nasopharyngeal swab collection. This again favors the mid-phase increase in the viral RNA replication in ocular surface. The pros of our study was that it was the largest series of conjunctival samples tested, and it is also the first to our knowledge to provide comparison of CT values. And the conjunctival swabs have been reported as the gold standard of tier collection for COVID-19 RT-PCR assay, which was done in our study. And our series also included a large chunk of asymptomatic patients as compared to established literature, which included more of moderate to more severe disease. So the scope from this study was that 4 of the 17 conjunctival swab positive patients were persistently positive in conjunctival swab, even when the nasopharyngeal swab turned out to be negative, which may indicate a persisting infection. So several important concerns of whether the conjunctival swab samples should be used as routine testing to improve diagnostic or prognostic accuracy, or they should be used in discharge policy of COVID-19 patients, is something to ponder upon. To conclude, there can be a delayed or prolonged shedding of the viral RNA on the ocular surface, and asymptomatic patients may also pose a significant threat to the spread of the virus apart from the active patients or past infection patients. So hence the use of protective eye shield and gloves is strongly encouraged, besides following a strict COVID appropriate behavior by every healthcare worker. Thank you.
So thank you, Abhinaya, for an elaborate presentation. Over to the judges.
Right. Now, I want to ask why there was delay in obtaining the conjunctival swabs. It might have been much better if you had collected the swabs simultaneously and repeated that at weekly intervals, or duration of the admission of the patient, because we don't know what was happening. You say that the delayed, you use the term shedding. I'm not sure we can use the term shedding of the virus in the tear fluid, because for that virus has to travel through the tissues. Here you are talking more like colonization from the nasopharynx into the via the tear ducts and via the nasolacrimal duct and the conjunctival swab into the sac, more as a contaminant or coming from the air surrounding the patient, because there would be an aerosol in these patients around, and it might be contaminating the tear fluid. So I'm not sure what would be the significance of doing this kind of testing from conjunctival swab. I mean, what does it really mean?
This is the limitation of one of the limitations of our study, sir. It was a cross-sectional study, so we could not get serial conjunctival swab samples, and there was a delay in the collection because these were referred patients. Most of them were referred patients once they were COVID nasopharyngeal swab positive from elsewhere. They had come to the tertiary care center, so that delay and the logistics played a role in this delay, sir. And
my question is very simple. When you were taking a conjunctival swab, you could as well have collected a nasopharyngeal swab. Whether they were positive earlier or not positive, it doesn't matter. If you are taken simultaneously, then we'll know at least the correlation between the two, positivity or negativity. We don't know. This is kind of an afterthought of a work rather than a prospective, well thought out study, to my mind.
So the patients were already. I didn't take it the same time, sir. Samples were not taken in the same time.
Yeah.
Thank you, Dr. Gupta. Dr. Khairala and Dr. Herbert.
Just a comment regarding the term prolonged and delayed. I think that we have to make there's maybe some difference between delayed and prolonged. And in your study, we have all patients had a positive. 17 patients with a positive, and of this 17, 4 I think still had a positive. So you have to use the term prolonged instead of delayed in such situation. What do you think about?
Yes.
Yes, Dr. Herbert, please.
Yeah, I can go along Ahmad's remarks. But nevertheless, these are interesting findings, but the way the study was done, of course, is not perfect, but it will probably lead to more specific studies, as Ahmad was pointing at. Thank you.
Thank you.
Thank you, Dr. Herbert. Thank you, Abhinaya.
Thank you. Thank you.
So our next speaker, Dr. Jangini Sudha, is not well, and she won't be able to make a presentation herself. In her place, Dr. Soumyava Basu will be presenting at the end of the session. I would like the judges to note this, and this paper would not be considered for the award-winning category. So now we move on to the next speaker, Dr. Rupesh Agarwal from Singapore, who will be talking on choroidal microvascular alterations in COVID-19 patients.
Thank you, Rima. This is and respected panel of judges. I'll be presenting my free paper on choroidal microvascular alterations in patients with COVID. I don't have any disclosure. So I would like to acknowledge the team effort which was put into for this project. It was a multidisciplinary team approach with the team of ophthalmologists, physicians, and also the image analyst and image acquisition people, and a team between India and Singapore. So why did we did this study? We do understand that choroid can get affected in various systemic health and various diseases in the body. We wanted to also understand, can choroid give us a little bit of more idea, more introspect about the COVID, which can affect probably the systemic vasculature. So as we understand, what does choroid composed of? The choroid is composed of luminal areas and the stromal area. And over a period of last 5 years, we have designed an index called as CVI, which stands for the vascular area divided by the total choroidal area, just to look into the choroidal microvasculature and also the bigger vessels of the choroid. Last 1 year, we have developed this platform called as COIN platform, which allows us to upload the images of the OCT as well as the fundus images. And this also allows us to also operate and analyze the images using automated software. So using the technology, using the clinical question, we wanted to analyze and evaluate the possible choroidal vascular changes in patients with COVID and understand whether there is any microvascular alterations within this the group of patients. So in our study, we did a clinical and ocular history after the informed consent and inter-institute agreements. The patients of the group A was the COVID positive, and then the second group was a controlled group patient. OCT was performed on both the groups, the positive, the patients with the COVID positive and healthy control. And eventually all these images underwent an automated segmentation protocol. Now, this is the video which demonstrate how these images were analyzed. So this is the software, which is accessible and open source software. And only just you need to register for use of this. You can upload a project. The project was uploaded here. And after the project was created and uploaded, the project, the images were analyzed like this. So there is an automated images. So this is not for particularly for this project. This is using some of the Heidelberg images, but you can see as a demo how you can segment and how you can fine tune the region of interest. So first is the region of interest, which was computed, and region of interest then can be fine tuned to get a final accurate value. And then once it is finalized, eventually the CVI was calculated, and you can see based on this image how a CVI can look like. So this is a region of interest which is demarcating the entire choroid. And after the image binarization technique, which has been described in some of the papers, you can see the choroidal vasculature index. So this is how a panel of the indices looks like. Here in this recently developed panel, which we can get a central choroidal vasculature index, we can get a nasal and as well as a temporal. So we are divided into 3 different zones. And also in all the regions, we can get a choroidal thickness also. So we are getting 3 CT values and then 3 CVI values. So the results of this study was for between the control and the cohort group, 61 patients and 56 patients from the study cohort. And overall, we did accounted for the control of the other eye. So we included both the eyes, and we put in some statistical computation analysis. And then we saw the choroidal thickness was quite significantly higher in patients with the COVID positive and statistically significantly different. And CVI value was reduced. So in discussion, why it is happening? What is happening here? The choroid was thicker, CVI was reduced, and because of the possible underlying inflammation of the choroid resulting in the stromal edema and resulting. Can we see it in a diagrammatic way? So let's understand what is happening within this choroid. So you can see the choroid can decrease in the value because either it is because of the loss of the choriocapillaries or decrease in the vessels or loss of larger choroidal vessels. So it can happen because of one of these things, and also it can happen because of the increased stromal edema. So the CVI allows us to be a simple non-invasive tool, a repeatable tool, also can be a quantitative tool and has been proven in different studies. And of course, it is available with the existing OCT machine. You don't have to buy a new OCT machine. And it has been used in various uveitis studies published till date, in pan-uveitis, in Vogt-Koenig-Harada disease, and also in other patients in follow-up of VKH disease. So to conclude, increased choroidal thickness with reduced choroidal vascularity index was noted in patients with COVID. Choroidal microvascular alteration could be representative of systemic, microvascular, inflammatory, and thrombotic changes in these patients. Further research can be helpful to understand the vascular alterations and variations in the course of the disease to unveil its clinical significance. Thank you very much for your patient listening. Thank you.
Thank you, Rupesh.
Very interesting study, Rupesh. I was wondering how soon after the onset of the disease, or how soon after the convalescence period was over, did you choose your COVID patients? Was it 3 months, 1 month, 1 week, 6 months, 1 year? I mean, when was the time of taking these measurements on your patients? And why did you compare them with the normal people? Why didn't you, choose some other group, say patients who have been into ICU and remained there for a week or 2 weeks, and then kind of compare them, those who survived the ICU stay, say at the same time period, it might be something to do with the stay in the ICU, because there's a lot of procedures done, the ventilation, the medications and so much before you ascribe all these changes to COVID.
Thank you, sir, for both the questions. So I'll answer the question number 1. So these patients were chosen between the 14 days of the COVID infection. The study was done in Mumbai, and whenever the patient was presented to Masina Hospital, the physician hospital in Mumbai, we were trying to take at the time of moment presentation. So that table is missing in my presentation, where I have shown from day 3 of presentation onwards till day 14, there were variable time interval. But we did a statistical analysis by dividing into the 4 different areas, range 3 to 7 days, 7 to 10 days, then 10 to 14 days, and anything more than 14 days. So we don't have any patient more than 14 days. But then between all the 3 groups, there were no statistical difference between the 3 groups. So this was done for the COVID patient itself. Now, the second question, yes, I will like to study the patients with the ICU and non-ICU. So within this group itself, we wanted to study between the severity of the COVID infection and less severe, moderate, severe, and all. So none of the patients were admitted in this patient in the group on the ICU. So all were moderate degree and which never had an ICU admission. But I take your suggestion, and I think in future study design, this can be a very interesting group to include.
There are a lot of comorbidities. These patients have a lot of comorbidities: diabetes, hypertension, renal changes, DIC, and so many things are happening to COVID patients. So I wonder if you can ascribe your CVI, reduce CVI to COVID per se, and not to the comorbidities.
Yeah, so we did analyze with certain variables, whatever was at our disposal, but not all the variables which could have been analyzed. So whatever the blood parameters were available, using the logistic regression analysis, we try to analyze whether any factors can be included. But again, it is not the study design in the ideal setting where we can definitely attribute that because of different systemic comorbid conditions, they can be attributed. But we did look for diabetes, we did look for hypertension and concurrent heart disease, and those were excluded from the study before we do that. But of course, there will be other comorbid factors which developed during the period of COVID or before the COVID also, which the study could not eliminate. Thank you, sir. It was a very interesting questions.
Thank you, sir. Dr. Herbert, Dr. Khairala?
I have a question to Rupesh. This is a wonderful presentation. What do you think about a previous study showing that there was a choroidal thickness, there is a reduced choroidal thickness, and a choroidal vascular index was unchanged? This is a publication in the Canadian Journal of Ophthalmology, recent publication. So I would like to have your opinion on that.
Yes, sir. That's again a very interesting report in Canadian Journal about the increased thickness. So thickness, we do understand why it can be thickened, and as we know that in acute patients with the weak age disease and a lot of other uveitis, choroid can be thickened. So that is definitely we know that, and over a period of time the thickness will reduce. Now, when it comes to no changes in the CVI, yes, it can also happen. It can be dependent on the technique used for binarization, but I do understand in the Canadian Journal of Ophthalmology, the paper published, they used the technique described by our group initially in 2015. So it will be again interesting to see whether the time frame which they were looking into it, because there is a choroidal remodeling which we have described in patients with VKH. So let's say between 7 to 10 days, there is initially increase in the CVI, but over a period of time, there can be the changes in the CVI where the CVI reduces first and there is a stromal remodeling resulting into the increased thickness persistent, but then increased CVI and then later on changes in the stromal increase, and then eventually the CT also decreases. So that might be one possible factor, but again, difficult to say. And then it's similar like diabetes where people have published different results. Again, in this group, why it would have happened, again, anyone's guess.
Yeah. This is a very nice study, but however, very difficult to cast conclusions on this study. It has to be considered as a preliminary. Now, what would be how to say, what would be the relevance of this in practical clinical situations?
Yeah, good question. Again, Carl, thanks for this thing. So I will say yes, it is not a specific biomarker, but a sensitive biomarker. So I will say, and that's what I've been speaking to my ID colleagues at my institute in Singapore. I said this can be one of the composite marker where they include many different markers in the body. You have all the different blood markers, you have different cardiac markers and all. And as we know that eye is the window of the body, this marker or probably retinal vascular changes, which we have also described in a separate paper, can be included as the surrogate markers, biomarker, along with the other markers. So let's say you have 9 biomarkers in the body. This can be the 10th marker. And along with this, when you put up all these 10 indexes together, you can come up with an index where it can probably predict which patient is going to get worsened, which patient is probably going to be stable. Can be used because right now we do see a lot of cardiac events, a lot of thrombotic events happening. And we do know that there is some microvascular changes happening. So we don't have any tools to analyze the systemic microvasculature. So here we have an opportunity to understand what is that happening in the patients who are dying and because of the thrombotic events. So can this give us a clue, or can the retinal microvasculature give us a clue about which patients are dying? So this can be a very useful screening tool along with the other markers, not by isolation. And probably that's the only tool, the useful thing about this application. Yeah.
Thank you. I will take over because our next presenter is our moderator, Dr. Reema Bansal, who will be talking about cytokine expression profile in tiers of COVID-19 patients.
Thank you, Dr. Vishali, and respected judges and my colleagues of the USI team. I'll be talking about our experience in cytokine expression profile in tiers of COVID-19 patients. We know that serum cytokines in COVID-19 have been studied extensively, and cytokines have been detected in tiers in several systemic and ocular diseases. So based on this, we hypothesized that the inflammatory mediators in COVID-19 could be detectable in tiers, and tier collection being the non-invasive method with the added advantage of repeatability, we conducted this study with the objective of assessing the local immune response to the SARS-CoV-2 by evaluating the cytokine expression profile in tiers of COVID-19 patients and to assess their correlation between tiers and serum in these patients. The study participants included patients of COVID-19 who were hospitalized in our institute last year between July to November. Following an IRB approval and strictly adhering to the COVID-19 protocol of the institute, we enrolled these patients. We collected their tear samples within 2 days of blood sample collection using Sherman strips, which was stored at -80 degrees Celsius till further use, reconstituted in PBS solution, and the conjunctival swabs of these patients were subjected to RT-PCR testing. We assessed the cytokines secreted by Th1, 2, and 17 cells, which included IL-2, 4, 6, 10, 17A, TNF, and interferon gamma, using the BD cytometric CBA kit, and data analysis was done using the BD EPSAP software. Statistical analysis included descriptive statistics, one-way ANOVA test, and Spearman's correlation coefficient. Coming to the results, when we compared the COVID-19 and healthy controls, the age of the healthy controls was significantly younger than the COVID-19. However, there was no difference between the gender in the two groups, There were 6 patients of conjunctival swab positivity by RT-PCR in COVID group and none in the control group. Now, when we looked at the serum profile of these patients, the blue bar represents the COVID group and the orange bar represents the normal group. We found that IL-2, IL-6, and TNF were significantly higher in COVID group when it came to sera analysis, and IL-4 and IL-17A were significantly reduced in COVID group as compared to the controls. In tears, IL-4 and TNF were significantly reduced in COVID patients as compared to the controls. Now, if you look at the parallel expression, which indicated significant values of the cytokine expression, IL-4 was significantly reduced both in the serum and tears of COVID-19 patients, and TNF was significantly increased in both the serum and the tears of these patients. Now, coming to the severity of disease as mild, moderate, and severe, the gray bar represents the group of severe COVID patients. We found that in serum, IL-6 was higher, though not significant, but in tears, IL-6 was significantly higher in severe COVID disease group. This just shows the peaks of the IL-6 levels in the tears of many of the severe patients as if you compare it with the other groups of mild, moderate, and normal. There was no difference in the cytokine expression levels of patients with conjunctival swab positivity or negativity. Considering the first day of systemic symptoms of COVID as day 0, we categorized the duration of illness as week 1, 2, and 3. And depending upon the duration of illness, we found that IL-2 was significantly higher in samples collected in week 1, and IL-4 was significantly lower in samples collected in week 1 in the serum of these patients. And in tears, IL-17A was significantly higher when the samples were collected in the early disease. Looking at the correlation between serum and tears, though significant, but we found a weak correlation among IL-2, TNF, and in the serum and tears of these patients as compared to the other 4 cytokines, which did not find any correlation between serum and tears. So before us, one study from Spain has published the cytokine expression profile last year. They included 62 moderate to severe cases of COVID with 27 pro-inflammatory cytokines. They found several cytokines were raised in tears and only one was decreased in the tears. IL-6 did not show any correlation and neither did they found it to be raised in severe patients. In our study, we found high TNF and low IL-4 in both tears and serum of COVID patients. Tear IL-6 was higher in the severe disease and tear IL-17A was higher in the early disease. We found significant but a weak correlation between serum and tears among IL-2, TNF, and interferon gamma. And the strength of our study is, this is the first study from India studying the cytokine expression level in COVID-19. Largest series of tear samples tested for cytokine expression bigger than the previous series I mentioned. We've included all grades of disease severity, including mild, moderate, and severe, and we've included all range of duration of illness as week 1, 2, and 3. We have certain limitations of having a cross-sectional study where we could not assess the longitudinal analysis of the cytokine expression. We tested a limited number of cytokines, did not correlate with the disease outcome. And of course, age of the control group was much younger because the volunteers being much younger. So to conclude that high TNF and low IL-4 in both tears and peripheral blood provide an opportunity to explore tears for their role as biomarkers in COVID-19. Elevated tear IL-17 in early disease and IL-6 in severe disease may indicate their increased local production, which may be influenced by the duration of the disease and severity of the disease, giving us an insight into the immune response of the ocular surface in COVID-19. And with this, I would like to acknowledge all the residents of our department who were posted in COVID-19 wards and who helped in collecting the samples of these patients. Thank you very much.
Thank you very much, Rima. Now we invite the judges for their comment, and I will begin with Carl. And Carl, it's truly an honor again to have you in USI, even though virtually. And for all our youngsters, Carl is kind of one of the earliest mentors of USI. Is he around? I can't see him. Okay, Mansif, we move on to you.
Thank you, Vishali. I have a question to Rima. Did you exclude the potential confounding factors such as pre-existing ocular surface disease in your patient? I think that meibomian gland dysfunction or previous conjunctivitis might play a role in your results. So, did you exclude any pre-existing previous ocular surface disease in the history of?
Yeah. So none of these patients were symptomatic for any ocular symptoms. So we ruled out conjunctivitis or any severe meibomian gland disease. And since these patients could not be tested in slit lamp, so an obvious ocular surface disease was not there in any of these patients.
Thank you.
Carl?
Yeah, can you hear me?
Yes, we can, and we thank you once again.
Okay, thank you for your nice words. I would like to congratulate these results, this study. You know, I think we are getting fantastic preliminary results on this horrible disease, and again, I'm amazed by the quality of all the presentation, including this one.
Thank you, Carl. Professor Gupta, sir. Sir, you are muted.
The question to Rima is, would you be able to confidently tell your colleagues in the ICU whether you could offer them tear cytokine analysis as a substitute for the blood studies?
Yes,
do you see any possibility of using tear cytokine analysis as a substitute for the blood workup they do for cytokines?
We could offer it because this was a preliminary study. And when we were conducting this, though we planned it as a very planned prospective study of collecting the samples at day 0, day 7, day...
That's okay, fine.
We found that we had certain lot of logistic issues and we could not. But if we go in a stepwise pattern and plan it prospectively, I'm sure we can offer the tears as a better substitute for blood to the ICU.
But you didn't show any linear correlation. I mean, one I find is that there is at least they were collected, the blood samples and tear samples are not collected simultaneously. So, and this disease, which can have, you know, the cytokine levels going up and down, depending upon the kind of treatment they receive, the steroids and intravenous corticosteroids or other immunomodulatory drugs, they could make a difference in 48 hours. And secondly, you need to show a linear correlation. Unless you can show that they are very well correlated, I think they are not going to be convinced about your offering a tear substitute. But as Carl said, it makes a lot of sense because it's much less invasive, you know, rather than draw a blood sample in the patient. Collecting a tear sample would be far easier.
Thank you. Thank you, sir. I'm sure Rima has noted down these suggestions and will work on them if we have, God forbid, another wave. So we move on to the next presenter, sight-threatening intraocular infection in COVID-19 patients in India by Dr. Sameera Naik, and now Rima will take it.
Hello, everyone. Systemic bacterial co-infection in hospitalized COVID-19 patients has been reported to be 7%, and it increased to 14% in presence of ICU admission. Systemic fungal co-infection in hospitalized COVID-19 patients are also not uncommon. There are anecdotal reports on presumed intraocular infections such as endophthalmitis in these patients. With this background, we did a study titled Sight-Threatening Intraocular Infection in COVID-19 Patients in India. The purpose was to describe the epidemiology and microbiological profile of intraocular infection in COVID-19 patients after their release from hospital. It was a retrospective chart review of prospectively collected COVID-19 patients' data between April 2020 to January 2021 at LB Prasad Eye Institute, Hyderabad and Vijayawada. All laboratory confirmed cases of SARS-CoV-2 infection who presented to us for endophthalmitis management within 12 weeks of discharge from the hospital were included in the study. The data included age, gender, associated comorbidities, time to onset of COVID-19 symptoms, time to onset of ophthalmic symptom, detail of COVID care, blood biochemistry, including inflammatory markers, and the culture of blood, urine tissue biopsy, and oxygen therapy were included. Undilated vitreous sample was subjected to gram staining, calcofluor white, Each patient received comprehensive eye examination, ocular ultrasound, slit lamp photography, and fundus photography were done whenever possible. Endophthalmitis was diagnosed clinically and managed as per institute protocol. Vitreous biopsy was subjected to gram staining and calcofluor white mount whenever possible. The sample was inoculated in all solid media as well as in the liquid media. The species identification was done using Vitek 2 compact system. PCR for Eubacteria, panfungus, and herpes virus were done whenever possible. Vitreous sample for RT-PCR under appropriate cold chain for SARS-CoV-2 detection was done whenever possible. We included 33 eyes of 24 patients. Cases of endogenous endophthalmitis coincided with the peak of COVID-19 in both the states. 16 had ICU admission, 2 had ventilator. Mean interval of COVID-19 systemic symptoms to ophthalmic symptoms was 15 days. Mean age at presentation was 53.6 years. There were 17 males, 90% had systemic comorbidities, 9 had bilateral affection. Majority had anemia, thrombocytopenia, lymphopenia, neutropenia with raised inflammatory biomarkers, C-reactive protein, IL-6, LDH, D-dimer, and serum ferritin. All had received azithromycin, doxycycline, 8 had received meropenem, 14 had received tocilizumab, 21 had received systemic corticosteroid. We included 32 eyes of endophthalmitis and 1 eye of panophthalmitis. The clinical picture ranged from preretinal and vitreous exudate to complete vitreous abscess and involvement of ocular coats and orbit. Mean presenting visual acuity was 0.0415. All had pen redness, blurring of vision at presentation. 14 had microbiologically positive vitreous sample, 11 had fungi, 2 had bacteria, 1 had virus. 11 had systemic focus of infection, 5 had candidemia, 3 had bacteremia, 1 had aspergillus, and 1 had mucormycosis. At a median follow-up of 90 days, 19 patients recovered and 5 patients deceased due to COVID-19 related complications. At the last follow-up visit, 13 eyes of 11 patients had severe visual impairment and 9 eyes of 8 patients had functionally improved vision. This is a 58-year gentleman with right eye involvement. The direct vitreous sample showed thin fungal filaments in calcofluor white mount, and the blood agar and blood agar and chocolate agar showing growth. The species was identified to be Candida tropicalis. This is another gentleman, right eye involvement. Ultrasound B scan showing exudative vitreous detachment, choroidal thickening, echodense vitreous cavity, direct vitreous sample showing septate filamentous fungal filaments in gram staining as well as in calcofluor white staining. The species was identified to be Fusarium equisetae. This is the bilateral involvement showing vitreous abscess. The direct vitreous sample showed septate filamentous fungus in Gomori-methenamine silver staining and Giemsa staining, and the species was identified to be Aspergillus flavus. Tertiary care referral nature of our practice could have skewed some of the clinical presentations. Lack of denominator of total hospitalized COVID-19 patients and their systemic comorbidities and interventions limits the conclusion drawn in our study. So, endophthalmitis is a rare but not uncommon occurrence in patients even after hospitalized care for COVID-19. It is associated with high mortality and blindness. we recommend the inclusion of a routine eye examination and estimation of vision as part of standard of care for hospitalized COVID patients. Thank you.
Well, thank you, Samira. Over to the judges. Dr. Khairala, please. We cannot see Dr. Khairala. Dr. Herbert, please. Dr. Herbert, you're muted.
Can you hear me now?
Yeah.
Yeah?
Yeah.
Okay, this is an impressive series of cases. What do you think is the trigger for all these endophthalmitis cases in COVID-19 patients? Is it the treatment, or what do you think is happening? Is the incidence bigger than in a normal population? Did you look at this aspect?
Thanks for the question. COVID-19 itself is a it's a altered immune status, number one. The second is the presence of hospitalization, ICU admission, intake of broad spectrum antibiotic, IL-6 inhibitor, and systemic use of corticosteroid. These three groups of drug probably have led to fungal infection.
It would be nice to compare to a normal population, to make a comparison.
We compare.
I mean, it's endophthalmitis is never a normal population, but what I mean is a non-COVID population.
We compared our data with the data that we published in previous year. And we realized that presence of elderly population, presence of systemic infection, culture positivity are more in this population in our series with COVID-19 patients.
Thank you.
Thank you, Dr. Herbert. Dr. Khairala, please.
Thank you very much for this nice presentation. Does the rate of fungal endophthalmitis compared to the bacterial endophthalmitis in your study reflect the respective rate of bacterial versus fungal in non-COVID indigenous endophthalmitis in non-COVID patients? Is there a high rate of fungal as well?
In this current study, we found 11 fungus, and which is all culture positive are fungal infection. Though we found there are 2 bacterial origin, but it was found in the microscopy, not in the culture. So definitely the fungal endophthalmitis rate is more in this current series.
Because a study from US recently showed that a much higher bacterial endophthalmitis in COVID patient than fungal endophthalmitis. So I think that the proportion of fungal versus bacterial is largely dependent on the area, the study area.
Yes.
Dr. Gupta, please.
Yeah, I would like to extend the same argument offered by Carl and Monsef. Samira, it's a very nice presentation, though it's a nice collection of data. But I would have, expected you to discuss what was happening to the rest of the world. As for the COVID patient, they were also admitted to ICU. They received tocilizumab and they received corticosteroids. They received antibiotics. They were much older age group, actually in Europe and probably US as well. And they also had similar kind of mortality. But I have not seen reports of endogenous endophthalmitis in the kind of numbers that you are reporting from India. So have you thought of what might be the possible reasons, how you could advise your physician friends what care they should take, or what would you advise to change their protocols to prevent this devastating complication in these patients who survive the COVID but not survive the infection in the eye?
Thanks for the question. We have one series published from Italy group. There are 3 eyes having endogenous endophthalmitis in COVID-19 patients, and all are of bacterial origin, and they had good visual improvement after treatment. And one also showed RT-PCR positive for SARS-CoV-2. And but in our series, majority are fungal endophthalmitis, probably due to use of corticosteroid. Usually in COVID-19 patients, they use corticosteroid as for recovery trial, and it should be dexamethasone, and most of our patients have received intravenous methylprednisolone with or without oral steroid. So that is different. That is one. And definitely the IL-6 inhibitor in experimental models, they have shown that it inhibits neutrophils and macrophages, which has led to candidemia in mice. That is one factor. So judicious use of IL-6 inhibitors as well as the corticosteroid, that is one thing. And the second thing is the measurement of inflammatory biomarkers. The serial measurement should be done at the time of admission as well as for the ICU protocol. But in our case, we got the report of inflammatory biomarkers at the time of admission, but majority did not receive serial inflammatory biomarkers, and as per the markers, their treatment might not have initiated. So that could be one of the causes of.
Do you have any information, Smira, on what kind of ICU facilities these patients came from? Were they institutional, where they followed standard protocols, or were they makeshift hospitals or makeshift ICUs where these patients were treated, or from what kind of referral hospitals? They were, primary hospital, secondary care, or makeshift, yes, because that was happening all over the country, So we have to be able to tell why it is happening.
Yes. We collected data. Out of 24 patients, only 3 had received COVID care in our tertiary care center, where all ICU protocol was being followed, and rest all had received COVID care in secondary and secondary level hospitals, where the blood culture, the bronchoalveolar lavage, urine, all those things were not followed routinely.
May I ask a question to the moderator, Dr. Rima Bansal, because they also managed maybe over 1,000 patients in their ICUs in PGI, the institutional care. How many cases of endogenous endophthalmitis came to their notice?
So from the ICU, we did not have many from the referrals, but
no, your own patients that were treated in the ICUs. The patients that came to PGI for management, how many of them actually developed endogenous endophthalmitis?
Not many, sir. We don't have this large series as we see elsewhere.
Because it's a very, very serious complication, which shows the difference in the level of care that is available to patients in India versus it's available to intensive care available in Europe and some of the US and other Americas.
We didn't come across many patients.
But it's a very nice data collection, I must say that. It's wonderful. Yeah.
Thank you.
Thank you, sir. Thank you, Samira. So we now move on to the next presenter, Dr. Sanjay, who will be presenting sight-threatening manifestations in post-COVID-19 era.
Thank you, Dr. Bansal. I'd like to share my presentation on sight-threatening manifestations in the post-COVID-19 era. All these cases we saw during the first COVID wave. I'd like to acknowledge my co-authors. I don't have any disclosures. This study was ethics approved through a virtual conference. Post-coronavirus manifestations have been reported, and we are fortunate to have been involved in reporting some of these cases. The purpose of this study was to report the sight-threatening ophthalmic manifestations in the post-COVID-19 infection era. This is a retrospective case series of 7 Asian Indian patients of 6 males and 1 female who had been diagnosed with coronavirus disease earlier, except one female patient whom we detected COVID-19 IgG antibodies. All the patients actually presented with severe pain, acute loss of vision, redness, and watering. This busy table actually gives an overview of the patients whom we diagnosed. We had 3 patients of endogenous endophthalmitis, 2 cases of panophthalmitis. Unfortunately, one of them was bilateral panophthalmitis. One of the patient was a thromboembolic incident having central retinal artery occlusion, panuveitis, and optic neuritis. Another with systemic and ocular vasculitis. So I'll be describing our cases. This is a 47-year-old male presented with features of hypopion, ciliary congestion, and pupillary block. And this is his B scan with pre-retinal exudates and vitreous exudates. And in addition, he had this HR on his nose and purpuric rashes on his nose and forehead. So he underwent pars plana vitrectomy. So this is the first immediate post-op picture. We can see emulsified exudate in the silicone oil, and this is 1 month post-op. And this is with the treatment with intravitreal antibiotics, systemic antibiotics, and oral steroids. So this is the second patient, a 37-year-old patient who presented with, again, endogenous endophthalmitis, and this is the corresponding V-scan picture. We have submitted this for publication, that is why the white mark below. And this is post-vitrectomy, and this is his fundus picture. And he was positive for pan-fungal PCR genome. Subsequently, he developed a complication of a central retinal vein occlusion following pars plana vitrectomy a month later. Now we are giving him anti-VEGF. This is a 56-year-old male who was treated elsewhere. This was a case of panophthalmitis. And this is his B-scan picture with thickening of the retinochoroidal complex. This is a 65-year-old female who came with redness, pain, and she had a hypopion. Her positive history was she was a case of advanced gastric carcinoma. In this patient, we actually did cytology also to rule out any malignant cells as one of the possible causes. And she was treated with intravitreal antibiotics and steroids. And subsequently, this is the resolution. Subsequently, she developed a retinal detachment. This is a very unfortunate case of a 55-year-old male who developed bilateral panophthalmitis. This patient had a history of previous non-Hodgkin's lymphoma of the rectum and was remission for 8 years. And he was also a known diabetic. His case, actually, he developed panophthalmitis within 2 days, and the symptoms actually worsened. He was diagnosed with COVID about 14 days earlier. And this is his B-scan picture showing vitreous debris and membranes with retinochoroidal thickening with subtenon's fluid, a similar picture in the left eye. Subsequently, he went on to develop scleral abscess in both eyes. And with the worsening abscess in the left eye, we had to eviscerate the left eye. The right eye subsequently recovered, and it's not icicle yet. This is a 66-year-old male who presented to us 14 days after discharge from the ward, and he developed with a central retinal artery occlusion with optic neuritis and bilateral panuveitis. We have subsequently published this paper. These are his OCT images showing involvement of the inner retina and posterior vitreous hyperreflectivity. Subsequently, he resolved. This is 2 weeks later picture, and this is his fundus fluorescent angiography showing areas of hypofluorescence, disc leak, and vascular leak. This is a case of a patient who developed the vasculitis kind of picture with rashes on his nose and also on his foot, shin, and all over blisters all over the body. And he also had purpuric rashes on the skin and the shin and ankle, and gangrene of the digits. This is one magnified view of the same. And he presented with hyphema in one eye. And these are his B-scan pictures showing vitreous hemorrhage in the right and the left eye. And this is after treatment with steroids, immunosuppression. This recovered. And we gave him AC wash, and the tap we sent was PCR negative for RT-PCR. And we did laser photocoagulation with anti-VEGF, and this is his final picture. Ocular investigations included reverse transcript RT-PCR for COVID-19, and all these patients were negative. In patients with infective intraocular inflammation, they were subsequently subjected to blood, ocular specimens, and urine culture. Urine culture revealed growth of bacteria in some patients, and these are the markers which we actually looked at, the systemic markers which will help show that patients who have ocular inflammation can have raised D-dimer levels, serum ferritin, LDH, in addition to the raised ESR and CRP when compared to the normal patients. So the investigations showed in the infective cases, U bacteria being positive in 3 patients. And sorry, my slides disappeared.
Yeah, your time is up, Dr. Sanjay. So we had announced in the beginning that the slides would be.
Okay, so I'll just conclude. So based on our series that we have a diverse cases of sight-threatening manifestations in the COVID era, which can be attributed to hypercoagulable and hyperinflammatory status. So this series illustrates this. Thank you.
Thank you, Dr. Sanjay. Over to the judges. Dr. Herbert, please. I can't see it, you, Dr. Herbert. Dr. Gupta, please. Yeah.
I've discussed enough in the last presentation, and I didn't see any culture positivity reports in Sanjay's presentation. He had some panophthalmitis and ophthalmitis cases. Was it fungal? And what's the rationale of doing PCR for fungal, pan-fungal? You know, he was doing something like that. Why did they not do a conventional cultures for some of these organisms?
Both all the specimens for intraocular infection are subjected to both bacterial and fungal culture. Unfortunately, fungal culture did not grow any organisms. Only PCR for pan-fungal genome came positive.
No, how about the bacterial? Did you culture any bacteria organism?
Yes. Bacterial culture was also negative. We could get only PCR positive in the bacterial specimens. Unfortunately, we didn't have any growth.
Thank you, Dr. Gupta. Dr. Khairala, Dr. Herbert.
Yeah, you had other confounding factors in your cases. You know, you talked about a case of lymphoma. So maybe this is a series which is not only caused by COVID-19 situation.
Thank you for your question, Dr. Herbert. So this non-Hodgkin's lymphoma was in remission for 8 years. I also sought the opinion of the oncologist. The oncologist said there was no reactivation, so it had nothing to do with the present status.
Thank you.
Thank you, Dr. Herbert. Dr. Khairala, please.
Thank you. Just a question about your case of vasculitis. What is your final diagnosis regarding vasculitis? Is it regional vasculitis, post-COVID regional vasculitis? It is vasculitis. Did you exclude tuberculosis? I think you have excluded this etiology. And please, a bit clarification about retinal vasculitis in this case.
I'm sorry, I could not complete the presentation. This patient with vasculitis had extensive workup, both for infective and vasculitic workup. ANA, ANCA, Behçet's, tuberculosis, sarcoidosis, everything was excluded. The infective etiology also did not show anything except the blood culture during his admission had Staphylococcus hominis, which they could not actually attribute to the present status. So he was, except COVID, there was no other significant contributing factor in this patient.
Thank you.
Thank you, Dr. Sanjay. Do we still have a question? We have a question from Dr. Herbert.
No question.
Thank you.
Thank you very much.
Thank you, Dr. Sanjay. So we move on to the next presentation by Dr. Snehal Bavaskar. We'll be talking on evaluation of serum ACE and lymphopenia in presumed sarcoid uveitis.
So good morning, everyone. Thank you for the opportunity. So in our study, today I'll be presenting which we evaluated the efficacy of diagnostic efficacy of serum angiotensin converting enzyme and lymphopenia singly and in combination with the probable sarcoid uveitis. So, as we all know, the sarcoidosis is a multisystemic inflammatory disorder with unknown etiology, affecting many organs, including the eye, and is characterized by non-caseating granulomas. So, the gold standard for diagnosis was histopathological diagnosis of non-caseating granulomas without any infectious agent. This disease involves not only the pulmonary system, which is accounting to 90%, but also other systems, and the eye involvement is around 50% in most of the cases. Although serum angiotensin ACE is the most commonly used biomarker for diagnosis, it has a sensitivity varying from 40 to 83%. Lymphopenia, which occurs because of the peripheral T cell depletion, has been noted in about more than 50% of the patients, sarcoid patients, and is associated with the chronic phase of the disease. So, the revised diagnostic criteria, which was given to the IWOS in 2019, was that the other granulomatous causes should be ruled out. Intraocular signs was the 7 intraocular signs, 8 systemic investigations, and they also classified the disease into definite ocular sarcoidosis, presumed sarcoidosis, and probable sarcoidosis. So these were the varied presentations of the sarcoidosis patients, where it showed the mutton fat granulomatous KPs, then the Basaka monoidus, copious nodules, multiple chorioretinal regions, the disc granuloma, the peripheral and on angiosity, and the chest X-ray showing bilateral hilateral lymphadenopathy. So we in our study was a retrospective monocentric study in which 755 patients, adult patients of uveitis were included, and it was evaluated by the single uveitis specialist from Jan 2019 to June 2020. And the exclusion criteria was patients who were less than 18 years of age, and the uveitis patients who were diagnosed only on ophthalmological examination. So we conducted a full ophthalmic examination of the patient and a systemic evaluation, including routine blood investigation like CBC, ASR, serum ACE, Mantoux test, quantiferon gold TB test, chest X-ray, HRCT, and the other investigations according to the anatomic distribution of the uveitis. So the IWS criteria of 2019 was used for the diagnosis of ocular sarcoidosis. ACTAP was done in patients where tubercular granuloma was mimicking the tubercular anterior uveitis mimicking the sarcoid uveitis. And so after that, we compared the data of 2 cohorts of probable sarcoid uveitis and presumed tubercular uveitis. Serum ACE levels were considered elevated if the mean reference value was about more than 52 international units per liter, and the lymphopenia was considered to be significant and the lymphocyte count was below the reference value of less than 1 into 10⁹ per liter. So coming to our results, we etiologically classified so we found that 50% of the 50 patients of probable, out of the cohort, 50 patients were probable sarcoid uveitis, 222 were the presumed tubercular uveitis, and 483 were the others uveitic entities. So mean age of presentation for the sarcoid patients and the tubercular uveitis patients were around 40 years of age. There was a equal predominance of males and females in both in sarcoid uveitis, whereas in tubercular female preponderance was noted. In both sarcoid and tubercular uveitis showed the bilateral presentation. According to the anatomical classification of uveitis by the classification by SUN classification, so the probable sarcoid uveitis was most commonly the intermediate uveitis, and the presumed tubercular uveitis presented as most commonly as the posterior uveitis. In high serum ACE, we also evaluated the serum ACE values in which we found that the probable sarcoid uveitis had a high serum ACE in 76% of the patients, while in presumed tubercular uveitis it was 46%. So the p-value was statistically significant. And in lymphopenia, when we compared the lymphopenia values in both the groups, it was not found to be statistically significant. So when we combine the both serum ACE and lymphocyte count, the group was showing high serum ACE and lymphopenia. In probable sarcoidosis, it was 17%, while in tubercular sarcoidosis, it was 11%, showing that it was statistically significant. So the other tests which were performed like Mantux and quantiferon, which were 80 to 85% positive in the presumed tubercular uveitis, while in sarcoid patients, it was coming to about 30 to 35%. The HRCT values, the HRCT showed bilateral hilar lymphadenopathy and pulmonary nodules and apical fibrosis. Bilateral hilar lymphadenopathy was seen in 37% and in the sarcoid patients as against 31% in the tubercular patients. Pulmonary nodules were seen in 26% of the sarcoid patients and against 22% in the tubercular. And apical fibrosis was more common in the tubercular uveitis. So coming to the review of literature, we found there are very few studies which showed the diagnostic efficacy of combined serum ACE and lymphopenia in ocular sarcoidosis. This is the review of literature which is quoted by the Cote et al., where the combination was studied in patients of uveitis, and they showed that it enhanced the specificity to 99% in diagnosis ocular sarcoidosis. In our study, we found the elevated serum ACE was noted in 76%, that is 38 out of 50 in probable sarcoidosis patients, and in 46, that is 103 out of 222 in presumed tubercular uveitis. And the combination definitely showed a higher percentage in 17% in probable sarcoidosis uveitis. Ma'am, my slides are not visible.
Yeah.
Getting stopped. Yeah.
The slides are being stopped when your time is up. So
okay.
You have to bear with that. You can complete your.
Okay, so the limitations of the study was it was a retrospective study, and so all the diagnostic investigations were not performed in all the cases, and all the patient, some patients had a long history of treatment. As being a tertiary center, they were all referred patients. Most of them were referred patients and were on oral steroids and immunosuppressant, and the patients were also on ACE inhibitors to treat the systemic hypertension. So those patients were not excluded. The conclusion, so combination of lymphopenia and elevated serum ACE can serve as a useful biomarker for diagnosing sarcoidosis, demonstrating a better overall diagnostic performance than solely that serum ACE or lymphopenia alone. Thank you.
So thank you, Snehal, for your presentation. Before we move on to the judges for the questions, just a gentle reminder for all the presenters. As I had announced in the beginning, the time allotted for presentation is 6 minutes. And please keep your view on the gallery view mode so that you can see the timer along with your presentation. And please, a request to stick to your time because your slides will be automatically shut off when the 6 minutes are over. So thank you. With this, we move on to the judges. Dr. Gupta, please, for your comments and inputs.
Yes, Snehal, I think you have a tremendous amount of data, humongous data, and I was looking forward to the discriminating value of lymphocytopenia and ACE levels, and compare them to the more conventional, like we've been using negative Montus and HRCT, hilar lymphadenopathy, usually to try to discriminate between sarcoid and tubercular etiology. But I'm not sure what you wish to tell, whether they can actually, because you are showing them, some of the patients with TB also have lymphocytopenia and have elevated ACE levels. I mean,
yes.
Why did you choose ACE over say lysozyme levels? Because ACE levels would get affected by corticosteroid therapy. So I'm not sure whether your patients were all naive patients, not receiving treatment, and
Sir, our patients, our study did have a limitation that the patients were mostly the referred patients, and they were on oral steroids and immunosuppressants also. So that was the.
Okay, Dr. Herbert.
Yes, we are not very happy with ACE levels. we have a very low sensitivity in a study we published at the beginning of this year. And as Ahmad said, a much better parameter would be lysozyme, where we have a good specificity and a good sensitivity. On top of that, many of our patients are treated by hypotensive drugs for systemic hypertension, which are ACE inhibitors and which confound the results. So we are very disillusioned with ACE testing.
Thank you, Dr. Herbert. And Dr. Khairala, please.
Thank you. I think I agree with Carl and Ahmad, and I think that lymphopenia is a useful parameter for the diagnosis, and we have to look for a combination of parameters, clinical features, other. And our diagnosis of ocular sarcoidosis is still challenging in a significant proportion of our patient, our everyday clinical practice.
Thank you, Dr. Khairala. So with this, we now move on to the next presenter. Dr. Ajay Arora will be presenting on suprachoroidal injection of triamcinolone with 30-gauge needle using novel suprachoroidal injection device and its long-term evaluation.
So good morning. Thank you, Dr. Rima and the judges. It gives me great pleasure to present my work, and thank you, USI, for the opportunity. I'll be presenting on suprachoroidal injection of triamcinolone with 30-gauge needle using novel suprachoroidal injection device, a long-term review. We know that these are the various methods which are used for delivering drugs to the posterior segment. The most commonly used is an intravitreal injection, but it has got its limitations. And hence, there have been trials for giving drugs in the suprachoroidal space, and can they work? It was studied, it was presented with this blue latex dye in an Argo paper, which said a single injection could cover 50% of the posterior segment. We know that suprachoroidal space is limited between oral cerulean and optic nerve, and hence the chances for causing an increase in intraocular pressure are pretty low. It is a blind procedure because it needs micro needle and a micro injector system. It's been shown conclusively by numerous studies, including the study on the rabbits done by Levin Chen et al., the Zelia study, and the Peachtree trial. The suprachoroidal triamcinolone works in case of uveitis. These are the various methods which are available: the Clearside group of microneedle microinjector system, the mid-one microcatheterization, the iTrack system, and a Jugaad, which was published with a 23-gauge and a 30-gauge needle. The problem with using a normal conventional needle is the long bevel length. So can it still be used? This was what our objectives of the study was: to construct an instrument, to do scanning electron microscopy of the available triamcinolone, to test the safety in animal eyes, to test in human eyes, and then to study in uveitis. These are my study places. And this was the scanning electron microscopy, which was done for Zubrata, Orocort, Corta, and Tricort. Please notice that there is quite a similarity between Zubrata and Orocort. When the particle size reduces, you cannot actually use the 30-gauge needle, you have to use the 26-gauge needle. When we inject anything vertically, the distance traveled is less, but if you go obliquely and if you increase the obliquity, the distance travels is more. Hence, if you travel obliquely, we could probably use the hypodermic needle, and hence we made a nomogram and the angular entry and the depth entered. So this is the device that was created after a lot of prototypes were tried, and an animal study was done. You can see here, I'll speed it up a little bit. Injection has been given, and then we did a dissection to show that there was drugs in the suprachoroidal space. We tested by UVM with methylcellulose, with Helon, and we could see that we could inject it in the suprachoroidal space. This is the human eye. I'll speed it up a little bit for paucity of time. You can see here that it's been beautifully injected. There is hardly anything visible. And this was a prototype study, pilot study we did on diabetic population, and we found that it is effective in reducing the macular edema. Then we decided, can we increase the duration of the effectivity? So I centrifuged the triamcinolone, and these are the various steps. And we took out 0.8 ml of the supernatant. Of the 0.2 ml, which contained 40 milligram, we injected 0.1 ml, which is 20 milligram, injected in the suprachoroidal space. So this was a study group which consisted of various types of non-infectious uveitis and 2 cases which had probable tuberculous uveitis, where there was associated macular edema. And all these patients were checked with best-corrected visual acuity, IOP, fundus violation, SD-OCT at day 1 to 7, 30, 90, and beyond. There were 3 eyes who had a repeat second injections, and there were 2 eyes where there was a repeat third injection. This is an example of a case who had a uveitis, who came to me. I had treated him earlier with systemic steroids. He refused to take systemic steroids or was refusing Ozotex because of the cost factor. We gave suprachoroidal triamcinolone. This is his initial presentation, and this is after SCITA visual acuity improved from 360 to 612 with the clearance of the media and both on ultrasound and on the OCT, the macular edema subsided. This is a non-infectious uveitis in the left eye of a patient where we gave non-centrifuge triamcinolone. The effect lasted for 4 months. And this is once we had centrifuged the triamcinolone. This was given on 13th of June, and the effect lasted for almost about 8 months. You can see the reduction of macular edema. And this was the second injection given on 10th of March. The patient is still doing well. In fact, I called her up yesterday. The effect is lasting for more than 7 months till now. So if you look at the cost of Ozotex versus SCITA in India, this is the number of injections which are given in the country. And this is the amount of expenditure which is done. And if we inject SCITA instead of Ozotex, this is the amount of money which India would be saving. Not only the money, but also there will be less utilization of plastic. These are the various uses of the suprachoroidal injection device. It's an oil drug device, autoclavable, can inject at varying depths by the pneumograms. You only have a recurring cost of 2 rupees of 1 needle. No scleral incision is required and can be used for scleral buckling. So in the end, to conclude, suprachoroidal injection of triamcinolone with SCIT is safe, effective, and cheap. It can become a promising treatment for cases of non-infectious uveitis requiring liquid steroids. Centrifugation has allowed us to extend the period of activity to almost 7 months. We need a larger institutional-based study because for me, it's a group practice, not a large institution. So I definitely need a support to do a larger study. Thank you for the kind attention.
Thank you, Dr. Ajay, for this novel concept. Over to the judges. Dr. Gupta, please.
Well, Ajay, when you're presenting preliminary reports, I would be looking at the safety data rather than the cost efficacy. So I would like to know when you're injecting at 3.75 millimeter from the limbus, and you are going tangentially, how do you assess how much sclera you have penetrated? And, as the patients come, right from myopes to hypermetropes, the scleral rigidity as well as the scleral, thickness would vary. So I would have loved to see your data on the animal studies and, various scleral thicknesses and, the establishing the instrument, I think, would have been the priority rather than to show the efficacy. I'm sure you give IVTA or you give into suprachoroidal space, both will work equally well. I mean, there's no dispute about the efficacy of triamcinolone acetonide in reducing inflammation. But here the challenge would be to establish efficacy and safety. Most important is the safety, because at 3.75, you might end up penetrating the retina once in a while,
So, so to answer your question, it has got two parts. One is the safety, the efficacy, which is known. So this is this study has earlier been done on diabetic patients, where we looked at the efficacy. But before that, we did animal studies. So in every patient, before we inject, we do an OCT to look at the thickness of the sclera. We measure the sclera at 12 o'clock in the upper nasal quadrant, in the lower nasal quadrant, in the lower temporal quadrant, and the upper temporal quadrant. We have found that injecting in the lower nasal or the lower temporal quadrant is the best, because that is where the scleral thickness is the most. We then made the nomograms for each quadrant, and we found out where the thickness is higher. And based upon the angulation, so we had four angulations. We had an angulation of 20 degrees, 30 degrees, 35 degrees, 40 degrees of the base plate. We found out, so because of paucity of time, I cannot share my nomograms here. This has already been presented earlier at a meeting where we showed our nomograms. We found out that by deciding based upon how much depth we have to go, we can choose a particular base plate, which means either we could choose 45 degrees or we could choose 30 degrees, and therefore the length of travel of the needle would vary based upon the nomogram. Based upon that, we know that so we precisely know before even starting that how much I'm going to enter into the sclera. Then what happens is that the moment you are in the sclera and you inject, there is a free flow of triamcinolone. If you are not in the supraparietal space, the triamcinolone will not go inside and will regurgitate. If you have entered in, so 3.75 or 4 millimeter was selected because it is the pars plana area, and as retina surgeons, we've been used to injecting at, operating at 4 millimeters. We know that even if I enter, the worst complication that can happen is giving an intravitreal triamcinolone. It will most unlikely penetrate into the retina, because when we do a pars plana vitrectomy, we are operating in 3.75 or 4 millimeters. We never encounter retina at this particular position. So this was done with prior pilot study where we had made very detailed nomograms of how to inject, and we always do an OCT of the scleral thickness before we decide in a particular patient. Once we have decided on a particular patient, then subsequent injections, I don't repeat the OCT.
Okay. So in your series, you never had any intraocular or intravitreal penetration?
No, I had intraocular. So I had intraocular penetration where we inject, where the triamcinolone would get. So in this 16 eyes, there were 2 eyes where triamcinolone did go into the vitreous cavity, but then we could immediately stop. We can even go to another site and inject. So triamcinolone crystals come out, or we can give it up and do it another day. If the triamcinolone is excess, then in one case I had to even wash off the triamcinolone from the anterior chamber. That was a pseudo-phakic patient.
Well, thank you, Dr. Ajay. Dr. Khairala, please.
Thank you very much. I think that this new local approach may be interesting, but I think the major issue is the safety, and this is why I think we need further improvement, as this presentation shows, further improvement in devices and technique to make it easier, and we can use it as first line or second line local therapy in our patient with non-infectious uveitis, non-infectious macular inflammatory edema. So I think that in our clinical practice, this technique appears to be difficult, and I have some doubt about its safety.
Thank you, sir. I think that's a point well taken, that any blind procedure for injecting into the suprachoroidal space will always be unsafe, irrespective of what device we use, whether it is the clear-side micro-injector system, because that also is a blind procedure. The only sure shot procedure is to do a sclerotomy, where we can see how deep we are and then doing a microcannulation. It's been shown by microcannulation, the incidence of choroidal hemorrhages are much higher. The clear-side biomedical device, which is a microinjector system, uses a microneedle which is 900 and 1100 micron. They presume that the eyes would either have 900 micron or 1100 micron. You can change the needle. So if you have a thicker sclera, you choose the 1100 micron. But there is no way any device anywhere in the world tells us that you could change the microneedle injector system. Ideally, we should have a device where we could micro manipulate the distance of a needle like a micrometer and choose it accordingly based upon the scleral thickness. Till we have that, we have to bear with the devices that are available.
Can you hear me?
Yes, sir.
Please.
Yeah, Monsef, as usual, you're very diplomatic, you know. In my medical studies, I was taught the first thing is you should not harm a patient. And the second thing, which is important for me, because I'm in private practice, is that we have to have means which are practical to use. And when I decide to do local subtenon injection of triamcinolone, you know, I can do it immediately. And this is very important. But the first thing is we should not harm our patients.
Extremely important, Dr. Herbert. Thank you very much for your comments, and thank you, Dr. Ajay. So with this now, yeah, we have a question from. Can I move to the next presentation, judges, please?
Sure, you move on. Next presentation.
Thank you, sir. So with this, I invite Dr. Nikita Gurram, who will be talking on role of multicolor imaging in post-fever retinitis involving posterior pole.
Good morning, all. My paper is on role of multicolor imaging in post-fever retinitis involving posterior pole. I had no financial disclosures. So let me introduce about post-fever retinitis and multicolor imaging before going to the paper. So retinitis following post-fever illness are generally multifocal cottonwool spot-like lesions localized in the posterior pole and around the optic disc and are usually associated with vitritis. These lesions have been reported in many infectious diseases like leptospirosis, chikungunya, dengue, rickettsia, typhoid, West Nile fever, and even in the Ebola disease. And multicolor imaging is a non-invasive retinal imaging technology which is available on Heidelberg Spectralis SDOCT. It simultaneously acquires three reflectance images of the retina using three different wavelengths, such as 488 nanometers of blue reflectance, 515 of green, and infrared 820 nanometers. And it then produces a composite image, thereby allowing analysis of changes at various levels within the retina. This is a multicolor image of normal fundus, where we can see the infrared, green, and blue reflectance as well. So in this study, our aim was to describe composite multicolor imaging features along with the monocolored fundus reflectance images in active and resolving stages of post-fever retinitis. So coming to the methodology, ours is a retrospective image analysis after taking institutional EC approval. We have included patients who were diagnosed with post-fever retinitis between January 2018 to June 2020 and who had undergone multimodal retinal imaging, such as fundus documentation was done using Optos, and OCT and multicolor imaging was performed using a Heidelberg Spectralis OCT. So we have diagnosis of active post-fever retinitis was defined as single or multiple focal cottonwool spot-like retinitis lesions located at the posterior pole or sometimes around the optic disc with vitritis was seen, and the presence of subretinal or intraretinal fluid or hard X-rays was noted on OCT examination in a patient who had a prior history of fever within 1 to 2 weeks. Resolving post-fever retinitis diagnosis was made when the retinitis lesion was reducing in size along with reduction in vitritis, SRF or IRF compared to the previous visit. Resolved retinitis diagnosis was made in the presence of complete resolution of retinitis lesion and vitritis on clinical examination, and there was no subretinal or intraretinal fluid on OCT. So this slide shows the image of an active retinitis. In the first image, you can see this is the Optos image, where we can see two retinitis lesions noted at the posterior pole corresponding to the OCT features. And the OCT features were posterior vitreous cells with retinal opacification, which is causing backshadowing of the underlying structures and the presence of intraretinal and fluorosensory detachment. In the same case, we have done multicolor imaging. In the composite multicolor image, we can see the retinitis patches as bright yellow in color, and extent of subretinal and intraretinal fluid is seen as green in color. And in the blue, retinitis lesions are seen as bright in color in blue, green, and infrared reflectance, whereas the extent of intraretinal or subretinal fluid is seen as bright in blue and green, whereas it is seen as dark on the infrared reflectance. So this slide shows different stages of post-fever retinitis. The first image shows the active stage of retinitis lesion along the superior artery, which is seen as bright white in color, corresponding to the OCT. And in the subsequent resolving and resolved stages, the retinitis patch is seen as dull gray in color. And the hard exudates are seen in resolving and resolved stage, which are seen as bright orange spots, as you can see in the second and third image here, corresponding to the OCT features. So coming to the results, we had 25 eyes of 18 patients. Our mean age group in our study was 30.63. And the ocular symptoms we have noted are most common is the blurred vision and followed by metamorphopsia and asymptomatic patients. And the best corrected visual acuity was more common between 20/40 to 20/200. And the cause of retinitis was more dengue followed by rickettsia and unknown cause. So we had 25 eyes of active retinitis where retinitis lesion and subretinal or intraretinal fluid are seen as described before, and which are all the features are comparable to the OCT features. And we had 17 eyes of resolving retinitis and 19 eyes of resolved retinitis, where we can see retinitis, subretinal fluid, and intraretinal fluid are comparable to the OCT features, but the hard exudates, which are seen only in resolving and resolved retinitis stages, are seen more prominently in multicolor blue and green reflectance when compared to the infrared reflectance. So here are limitations to my study. This study lacks the comparison between multicolor imaging findings and the findings seen on conventional optos images, and there is absence of subgroup analysis between etiology of retinitis and multicolor imaging features. So to conclude, the different stages of post-fever retinitis show different color on multicolor images and different reflectance patterns on individual color reflectance. Hence, multimode of fundus imaging with different fundus images can help in differentiation of activity in post-fever retinitis. Thank you.
Thank you, Dr. Nikita. So over to the judges. Dr. Herbert, please.
Yeah, can you hear me?
Yeah.
Well, I'm really flabbergasted by all this pioneering work which is done. But again here, I think this has to be stressed. This is, as many other presentations, very preliminary stuff, and photographing the fundus is not easy because there are a lot of parameters which can modify the colors. But I congratulate the authors of this study.
Thank you, sir.
Thank you, Dr. Herbert. Dr. Khairala, please.
Thank you for this nice presentation. I think that the imaging in this kind of retinitis, what we call post-fever retinitis, or there are other terms to describe such lesions like multifocal superficial retinitis or acute inner retinitis. And I think that the conventional color fundus photography is the best imaging modality to document lesions. And I think that, for example, for such lesions, maybe wide field imaging is not so appropriate to document superficial retinitis in the posterior pole or close the posterior pole. The second point is that OCT is very important, is highly useful to make the correct diagnosis of post-fever retinitis of inner retinitis in combination with conventional fundus photography. And I think that the multicolor imaging may also be used. However, I would favor the conventional fundus photography. There is another important point regarding the nosology of post-fever retinitis. I think that this is potpourri. This term may refer to a wide variety of infectious and non-infectious causes. And I think that in any patient with post-fever retinitis, we have to make an extensive workup to look for the exact cause of the retinitis. And the most common causes of post-fever retinitis in our experience is rickettsial disease. I think that cat scratch disease is also an important cause, but cat scratch disease is not so common in India. And chikungunya is a very important cause in your geographic area. And we also have to think about syphilis, masquerade, Q fever, and other infectious causes. And besides these infectious causes, we have to think about Behçet uveitis and Behçet retinitis that may present as post-fever retinitis. Thus, I think that it is important for us to have the final etiologic diagnosis in this kind of retinitis.
Thank you, Dr. Khairana.
May I add something?
Sure, please.
Yeah. Monsef, what you say is very true, but this does not concern this special study, although it does in the second degree. Yes, this is again a potpourri terminology, which is difficult to deal with, and I'm very dubitative of this category, and etiological diagnosis has to be sought for these kind of cases.
Thank you.
Thank you, Dr. Hobart. Dr. Gupta, please.
Yeah, I was lost, because I always thought that multicolor imaging is done to see better the depth of the lesion in the retina. Say blue reflectance and green and red reflectance images would show the presence of pathology in different layers of retina far more clearly than you have the white light image. So that was the purpose of multicolor imaging. And here you are seeking to see the change in the color of the lesions of post-fever retinitis. So I'm lost how change in the color of a lesion can be, if you were looking at the depth of the lesion, I would have agreed that you are looking at the outer retinitis or middle or superficial retinitis. I would have certainly appreciated your effort. But here you're looking at the superficial retinitis, and you are using the multicolor imaging and trying to tell us the change in the color. I mean, I couldn't fathom the objective of the study at all.
When there is active retinitis, as I told, there will be a presence of subretinal or intraretinal fluid. So compared to the normal surrounding retina, the retinitis lesion with the underlying intraretinal or subretinal fluid is more elevated, and that shows a more green, bright color. So when the intraretinal fluid or subretinal fluid decreases in the resolved or resolving stages, then the color goes down to dull gray in color.
Nikita, I think that will be oversimplification of technology, because green color and all that. I don't agree that you would be fascinated by looking at a green color and diagnose subretinal fluid. You would any day do an OCT to look for that. I mean, looking at the color of fundus picture, you want to diagnose presence of, but certainly you could, use multicolor imaging to look at the depth of the image, the depth of the lesion that is affecting, because now we have, number of entities like, acute macular neuropathy or AMN, or you have mutes and other lesions, which will appear at different layers of the retina. And that's where we best utilize this modality of using different color reflectance images. Good. Anyway, you presented well. Thank you.
Thank you, sir. Thank you, Dr. Nikita. So we now move on to the next presentation by Dr. Radha Annamalai, who will be talking on uveitis and extrapulmonary tuberculosis, its presence, progress, and prognosis.
Thank you, ma'am. Respected chairpersons, esteemed members, thank you for this opportunity to present today. So among patients with extrapulmonary tuberculosis, ocular manifestations have been reported, and in them concomitant pulmonary findings may or may not be present. This study is an attempt to identifying the spectrum of uveitis in patients with extrapulmonary tuberculosis. So the objective of my study is to determine the spectrum of uveitis, causes of visual loss, the role of investigations and outcome after treatment of extrapulmonary tuberculosis, and to identify the prevalence of uveitis in this group. So this is a retrospective study on 100 patients with ETB performed over 2 years with a minimum follow-up period of 6 months in all patients. An ethics committee approval was obtained. Systemic workup, apart from a complete blood count and an ESR, comprised of a Mantoux reaction, chest X-ray, high-resolution CT, and quantiferon TB gold test. Aqueous humor analysis was performed on a few patients by PCR analysis, nested PCR, or real-time PCR, depending on the indication and clinical characteristics in the patient. Ancillary investigations such as fundus fluorescent angiography, B-scan, and OCT were performed in all patients. So the results of my study was prevalence of uveitis in ETB was about 27%. And amongst this, posterior uveitis was the most common, seen in 87% of patients, which was statistically significant. Multifocal choroiditis occurred in 30%, choroidal tuberculoma in 26%, a serpiginous-like choroiditis in 20%, and vasculitis in 11%. Anterior uveitis was seen in 12, intermediate uveitis 3, and pan-uveitis in 1%. The pictures of patients with chronic uveitis in our. So this is posterior uveitis in our patients where there was multifocal choroiditis, mostly in the amphigenous pattern. The type of TB in uveitis was seen as 9 tubercular ETB patients who were HIV co-infected, and amongst the 27%, miliary TB was seen in 12, lymph node in 3, CNS TB in 5, dental abscess 2, abdominal TB in 2, and skeletal tuberculosis in 2, and breast abscess in 1 patient. So amongst this, 30 patients were classified as latent TB, those with that is those who had IGRA positivity and were asymptomatic, and 70 patients were considered active TB who had active symptoms and who were culture positive. So in our patients, in some of our patients with ETB, co-infections or due to rarer infections were present, such as Basidiobulus renerum and Enterococcus fecum, both of which caused choroidal disease, and in this set, both were negative for HIV. So this is the lactophenol cotton blue showing the Basidiobulus renerum, and the culture media SDA showing Basidiobulus renerum again, and Enterococcus fecum going on blood agar. So in our study, there was bilateral lesions were much more common, and it was predominantly seen in the 5th to 6th decades of life. There was no significant difference in gender. Mantoux test was positive in 31%. X-ray chest high resolution CT showed changes positive in 28%. Smear was positive in 72%. IGRA was positive in 78%. And of the total 21 patients on whom aqueous humor analysis was performed, 96% was PCR positive, of which 87% were infected with MTBD, Mycobacterium tuberculosis, and 9% with atypical mycobacteria. So aqueous humor analysis was done on 18, and vitreous humor analysis was done on 3 patients in our cohort. So collectively, chest X-ray, Mantoux, and IGRA were positive in 67% of patients, and a PCR that is inclusive of nested and RT-PCR on aqueous and vitreous samples were diagnostic in 96% of patients. ATT in isolation was used in 33% and combined with corticosteroids in 67%. Vision improved in 79% and worsened in 27%. Improvement was noted within 6 months only in 39% of patients, and ATT for longer than 10 months was associated with significant improvement in vision. Uveitis was found to be chronic in 67%. So again, one of our patients with multifocal choroiditis, a positive Mantoux and a positive PCR reaction. Uveitis was the initial manifestation of systemic TB in 60%. So posterior uveitis was one of the most common presentation, and even amongst this, 6% presented to us first before going to the medicine OP. Hypersensitivity to DNA antigen seems to play a primary role in the pathogenesis of ocular inflammation in ETB. Cultures were negative in few patients with positive PCR. This perhaps was due to a paucibacillary status or fewer bacilli in the sample that we sent, which could have been one of the limiting factors. Reactivation of uveitis is more common, and the uveitis is more difficult to control. The most common complications that we found were CME, CNVM, and ERM. So some more pictures of our patients. In summary, in ETB, posterior uveitis is more common, especially in the miliary and CNS type. CNS was seen in tuberculoma and meningitis TB. Onset of uveitis is later than systemic involvement, and chronic uveitis was the feature in the majority of patients. PCR on aqueous humor samples are reliable in the identification of MTB DNA, and it could be a good idea to use it in routine diagnosis of ETB where the conventional methods are limiting, and corticosteroids in combination have to be given for longer than 12 months. Thank you very much for your time.
Thank you, Dr. Radha. So over to the judges. Dr. Kairala, please.
Thank you, Rima. My question is, you have a very high rate of positive PCR in your patient. Would you recommend PCR in all patients with suspected as having tubercular uveitis?
Thank you for your question, sir. We did not perform PCR on all our patients. So those which had systemic positivity or where the clinical diagnosis was apparent and they were referred to us from the medical OP, we did not do an aqueous humor analysis because they had started them on ATT. So we performed PCR on 12 patients, and those were the situations where the clinical suspicion was high and systemic investigations were negative. So based on that, PCR positivity was very high.
Dr. Gupta, please.
Yeah, Dr. Annamalai, this is a study I was actually, of all the abstracts, this was the one I was looking forward to hearing from you. How did you collect these 100 cases of extrapulmonary TB? Because that's a major challenge. How you collect your cohort. Is it coming from the general physicians? Is it coming from gynecologists? Is it coming from, pulmonologists or dental or CNS, neurologists or gynecologists or surgeons? It's a very, very difficult to collect this, have some standard criteria for collecting this cohort of, extrapulmonary tuberculosis. It would have been wonderful if you had, chosen your patients, entry criteria would have been clear, and then look for the uveitis. So the only message I could get was that out of 100 patients, which you later said, well, there was no systemic evidence of tuberculosis. I thought when you're diagnosing extrapulmonary TB, there would be certain standard criteria, by which extrapulmonary TB is a disease. It's not a latent state. And out of those, whatever they were, 9 patients you had or 27% you had positivity out of 100. So I got totally confused by your data presentation. I'm sorry to say it, but this was the one which was I was looking forward to, and I felt let down, very badly.
Sir, thanks for your question, sir. I'll just clarify on this. So ours is a multi-speciality hospital where patients are referred for ophthalmic evaluation. So in the majority, the diagnosis of ETB is already made. If the patient came from orthopedics, they had perhaps a TB spine, or if they came from dental OP or dental abscess where biopsy was already done. So there were a very small percentage of patients who came directly to the ophthal OPD, and they were the ones that I mentioned had posterior uveitis, and we went on to investigate them further. So to
that's
answer
where, Dr. Anamlai, that's where the problem lies. Because you'll have very tough time publishing this, except maybe in a local journal, because your cohort is not clear. You should have said, well, these were the guys who were referred, all the extrapulmonary TB seen in your institute, what they seen over a limited duration or time frame, and you can't mixing them up, those who walked into your clinic on their own. So I think unless there was a clarification on that part, the interpretation of data would be extremely difficult. You mix up your patients, those who walked in with uveitis compared to those who were referred from, say, gynec or orthopedic surgery or surgeons or, physicians, will have tough time to analyze and put any, conclusion from this kind of data.
So our patients
Yeah, please go ahead.
Yeah. So our patients we saw over a 2-year period, sir. And over a 2-year period, patients who were referred to us from medical OP was the cohort. From the general medicine. The study itself was done in concurrence with our physician. So they was from the chest medicine. So they were sending us patients.
We have a question from Dr. Hubbard.
Here I am. Can you hear me?
Yes, sir.
Okay. I think you had a positivity rate of positive chest X-ray in something like 26% of cases.
Yes.
So is this still extrapulmonary tuberculosis?
So those which had pulmonary findings were actually not active TB, and those with chest X-rays suggestive of TB were not typically pulmonary TB. It was not primary. It was lymphadenitis that was commonly associated with this kind of a picture. So,
okay, now you have 9 cases of atypical mycobacteria.
Yes, sir.
Do you remember which kind of atypical mycobacteria there were?
Yes, sir. Yes, I do remember. So one is the Kansasi type, and the others is Crophylaceae.
So I wanted to know whether you have a Kansasi atypical TB.
Yes, there was a report from one.
And second question, did they behave or did they have a clinical picture which was different from the typical mycobacteria?
So the patient with Kansasi had actually a spinal tuberculosis, and ocular features wise, it was a posterior uveitis. Patient had vitritis with choroiditis, multifocal choroiditis. That's what we saw.
So you saw no difference?
Not really, sir. We didn't see anything.
As far as you can judge?
Yes.
Thank you.
Thank you, sir.
So thank you, Dr. Herbert. So with this, thank you, Dr. Radha.
Thank you.
For your presentation. And with this, we now move on to the next presenter. Dr. Akhila Sridharan will be talking on neovascular sequelae of immune complex retinitis.
At this outset, I would like to thank the USICON team for giving me this opportunity to present our work on neovascular sequelae of immune complex retinitis. There are multiple papers which have been published on epidemic retinitis, which is also known as post-pyrexial retinitis or post-fever retinitis, as per which it is stated this condition is termed as infectious or para-infectious uveitic entities, which occurs in days or weeks following the onset of febrile illness. The exact etiopathogenesis of this condition is still under study. There are multiple conditions which have been associated with the same, like the rickettsial infection, typhoid, dengue, West Nile fever, chikungunya fever, and Zika virus infection, and of course now the COVID virus as well. It presents as a focal or multifocal patches of retinitis, which can be unilateral or bilateral, with or without optic nerve involvement, macular edema in the form of macular star or neurosensory detachment, vascular torsosity, venous beading, retinal edema, and vascular sheathing as shown in this image. So the purpose of our study was to analyze the occurrence of neovascularization in cases with post-pyrexidal retinitis. We basically it was a retrospective analysis where we involved 10 cases of post-pyrexidal retinitis who presented to us in the past 1 year. All patients underwent detailed ophthalmic examination and relevant investigations, which included fundus fluorescein angiography, OCT, and also systemic workup to look for the etiology. These patients were started on systemic steroid and tapered based on the clinical response. We basically had 18 eyes of 10 patients, mean age being 38.2 years, mean duration of presentation from the onset of fever being about 4 weeks. We had 4 eyes of 3 patients who had developed neovascularization, about which we are going to concentrate on. There were various presentations with which they had come to us, and if you see NVE in 2 and NVD in 3 patients. I'll discuss in detail about the individual cases. First case being a 16-year-old boy who was otherwise healthy, came with sudden painless dimness of vision in the left eye since 2 days. He had febrile illness 2 weeks ago, which was high-grade fever. His best corrected visual acuity was counting here 0.5 meter, and the other eye was within normal limit. So this is the fundus picture where you can see that there is a cotton wool spot-like retinitis patch with a tuft of vessel which is seen along the superotemporal arcade, and also macular suggestive of macular edema. So this is the OCT show demonstrating neurosensory detachment, FFA showing tuft of vasculature at the superotemporal arcade, which leaks at later phase suggestive of neovascularization. So this was a left eye post-pyrexidal retinitis with vasculitis and neovascularization and neurosensory detachment. Etiological workup was negative. Oral prednisolone was started, and patient was given intravitreal bevacizumab. You can see that post-injection there was a resolution of neurosensory detachment and also visual improvement. A second case, a 44-year-old female. Male with febrile illness 1 month ago, sudden blurring of vision in both the eyes. There was retinitis with neurosensory detachment. Blood workup was negative for etiology. You can see that right eye 660 with posterior pole involvement of retinitis with resolved post-injection. And left eye had more severe disease as compared to right. And you can see during the follow-up, the patient developed epiretinal proliferation with temporal neovascularization. We planned vitrectomy with gas injection, and there was resolution. However, the vision did not improve much because of the sclerosed vessel and ischemia. Third case being a 37-year-old female with blurring of vision since 2 weeks. There was a past history of fever a month ago. Vision in right eye was 1/60 and left eye 636. Bilateral retinitis with neurosensory detachment was noted. At presentation, you can see that there is severe retinitis with macular edema. We had given bevacizumab and oral steroid. You can see that there is resolution post-injection. This is the OCT demonstrating the same. You can see that there is resolution of neurosensory detachment and retinitis post-injection with visual improvement. At 5th month follow-up, this patient developed neovascularization at the disc, which is well demonstrated on the FFA. However, you can see that the CNP is not very significant. If you compare the same with a patient with proliferative diabetic retinopathy, the amount of capillary non-perfusion is not very significant, indicating that this is inflammatory-induced neovascularization. So our take based on the observation from these patients where there is significant anterior and posterior segment inflammation with extensive hemorrhages and retinitis patches involving the posterior pole with macular edema at presentation. One patient had neovascularization at presentation, whereas 2 had late onset neovascularization. FF showed perivascular and disc leakage and staining without significant capillary non-perfusion, indicating that inflammation-induced neovascularization. We also saw that anti-VEGF resulted in rapid resolution of neurosensory detachment, faster visual recovery, and rapid resolution of neovascularization also. So to conclude, neovascularization in post-pyrexidal retinitis can be early and late manifestation. Careful long-term follow-up and control of inflammation is very essential in these cases. Neovascularization is not directly proportional to non-perfusion, but to the amount of inflammation, vasculitis, and ischemia in toto. Intravitreal anti-VEGF is a good alternative to address the inflammatory neovascularization. Thank you.
Thank you, Dr. Akhila. So over to the judges. Dr. Gupta, please.
So Akhila, it's a very nice presentation of 4 cases that you demonstrate, the development of neovascularization. Just 2 comments. You called it post-immune complex retinitis. So I'm not sure. You have not shown us any data on whether you did any studies on immune complexes or the biomarkers for immune complex disease. So this is something which I take strong issue with the use of nomenclature. The second is before saying that there was no significant capillary non-perfusion, you should have shown an ultra-wide fluorescent angiography to show that there was no peripheral capillary non-perfusion areas, because that would be the challenge you will face. And I'm sure inflammation can induce and does induce neovascularization, but in a resolved inflammation in a quiescent stage for patients to develop neovascularization would be highly unusual. So to that extent, your patients are quite remarkable, I must say, worth documenting. But I think it needs a little more workup that way.
Thank you for the comment, sir. First of all, we called it immune complex retinitis because these patients developed the condition 2 weeks post the onset of fever. There was no signs of infection at presentation. Secondly, we saw chirolysis plaque in our patients, which is been published earlier that this is an association of immune complex deposit.
I'm sorry to interrupt you, but immune complex, when you want to label, you need to show the presence of immune complexes in the circulation or by a variety of parameters that are available. You just can't say post-fever retinitis is post-immune complex retinitis. So I have issues with your nomenclature, not an issue with your documentation of the development of neovascularization. That's an excellent work done. But terminology you use, post-immune complex, nobody would agree with that, to my mind. Yeah.
And the second question that we saw that it was affection of the posterior pole exclusively. I should have displayed the wide field image also. However, there was no peripheral CNPs which were noted in my case. So sorry about not displaying the full field image.
Dr. Herbert, please.
Yes. Very nice cases. Thank you for presenting them. Of course, we know that inflammation is stimulating neovessels. But again, I'm very uncomfortable with this fever-related potpourri group, which you call immune complex retinitis, which is far from being proved. I think this is the problem with this denomination. It reminds me of something happened in '95, when somebody called the posterior choroiditis white dot syndromes. And I mean, this is now still in the literature where it has absolutely no meaning, no sense. So I'm very concerned with the terminology, with the nomenclature of this group of diseases. But your cases were very nice, yes.
Thank you, sir. We have actually collected the aqueous and blood sample of this patient when we injected. So we are doing a study on the markers in the same. So maybe in our next presentation, we will demonstrate the same. But yeah, I agree. I shouldn't have used that terminology before that.
Thank you.
Dr. Khairala, please.
Thank you. Congratulations for this very nice cases, and I agree with my colleagues and friends. I think that it is important in our clinical practice to be aware of retinal or optic disc neovascularization as a complication of posterior uveitis or intermediate uveitis of any cause. There are some causes, the etiologies that may induce more frequently new vessels. However, it is important to differentiate between, as you made, between early and late neovascularization, and fluorescein angiography is essential to look for ischemia, and new vessels may occur with or without associated capillary non-perfusion. It is important to differentiate between these two situations because laser photocoagulation may be needed for patients with ischemia and no laser in other in patient without ischemia. And we also have OCT angiography that may help us in the differential diagnosis and management of neovascularization associated with intraocular inflammation. And again, thank you for this nice cases.
So thank you, Dr. Khairala, and thank you, Dr. Akila. So with this, we now move on to the next presentation by Dr. Mamta Agarwal on infectious scleritis, clinical characteristics, causative factors, and treatment outcomes in an Indian population.
Good evening, good afternoon, everyone. I'll be talking about my study on infectious scleritis. And I have no financial disclosure for the study. Infectious scleritis, as we all know, it's a rare cause of scleritis, and the etiology being surgery or trauma, as has been described in the literature. The pathogenesis, we all know, it can be exogenous and endogenous, but there can be a direct invasion by the infective organism, and it's a hypersensitivity reaction to organisms too. The most common organism which have been described, it's post-surgical, we see Pseudomonas aeruginosa, and post-trauma, fungal infections are more common. And the purpose of my study was to see the inciting factors, clinical features, and the treatment outcomes in patients with scleritis, infectious scleritis. And it was a retrospective study between August 2012 to March 2021 at a tertiary care center in South India. So looking at the results of the study, there were 45 patients, all had unilateral presentation. The males predominated the study, and the age range was 15 to 88 years. Interestingly, 17 patients had more than 60 years of age. All patients were immunocompetent except for one HIV patient. Majority of the patients, they presented with redness, pain, and followed by decreased vision and swollen eyes. Duration of symptoms on an average was 3 months. And interestingly, patients who had history of injury had more duration of symptoms. The inciting factors, as we see, 15 eyes had a history of trauma, and 9 eyes, they were post-surgery, where it was vitrectomy in 6 eyes, cataract surgery 2, and 1 patient had a history of therapeutic keratoplasty. 14 patients were diabetic. Interestingly, 34 eyes out of 45, they were all treated with different forms of corticosteroids, including oral, topical, and peribulbar. 3 patients were also treated with immunosuppressives, including azathioprine and methotrexate. The visual acuity ranged from light perception to 6/6. When I look at the location, 44 patients were anterior and 1 patient had posterior scleritis. Multifocal lesions were commoner than unifocal and diffuse, and necrotizing and non-necrotizing lesions were same in both the groups. And there were patients, nearly 51% patients had associated uveitis, followed by keratitis, endophthalmitis, panophthalmitis, exudative detachment, and retinal abscess. So these were some of the clinical pictures. As we see here, unifocal lesion, which was a fungal infection. These were multifocal fungal infections. And this was a patient who had multifocal lesions and proven to be nocardia. And looking at the etiology, we had 24 eyes who were proven to be bacterial, and 16 eyes had fungal infections. 5 eyes were diagnosed to have presumed herpetic infections. And microbiological tests, 29 eyes had smears positive, 24 eyes had culture positive, and 11 patients, they had PCR positivity. Ancillary investigations, including PPD, ICRA, HRCT tests were done in the patients who were diagnosed to have tubercular scleritis. 2 patients had herpes zoster ophthalmicus prior to developing scleritis, and 1 patient had a history of herpetic facial nerve palsy in the past. So these were some of my patients who developed, this was a bacterial infection, Paecilomyces, Aspergillus fumigatus, and this was the Candida infection in an HIV positive patient. And these were some of the patients with multifocal nocardia ulcerative lesions. This was a patient with Pseudomonas aeruginosa, keratitis, and scleritis. And these were nodular nocardial lesions. So when I look at the results, the duration of symptoms, fungal lesions had a longer duration of symptoms. All the patients were treated with topical and oral antimicrobials, and surgical intervention was also done in 17 eyes. It included the debridement with wash, cyanoacrylate glue with bandage contact lens, therapeutic penetrating keratoplasty. 2 eyes underwent enucleation and 1 eye had to be eviscerated. Average duration of antimicrobials were nearly 3 months. Complete resolution of scleritis was seen in 39 hours. Healing was longer in than normal. The patients were followed up for 5 weeks to 4.5 years, and visual acuity post-treatment on average was 1.2 logMAR, and nearly 50% of the patients had less than 660 vision after resolution of scleritis. This was a patient, one of our study patients, who pre and post-treatment was diagnosed to have tubercular scleritis, but a biopsy revealed that it was a nocardia lesion. And this was one of our patients who was treated for fungal scleritis, and this is a few months later, fungal scleritis completely healed. And this was a patient who was treated with antibiotics, but then a repeat biopsy revealed that it was Burkholderia species. And it was treated with topical imipenem and fortified amikacin. This is 7 months post-treatment. And this was one of my patients we have recently published. It was a multi-drug resistant tubercular scleritis. However, patient did not respond to treatment and had to undergo enucleation. And this was one of my recent patients. Patient was treated locally with oral steroids for 3 months. But scleral biopsy revealed it was Mycobacterium abscessus, and the treatment was given with oral clarithromycin and intravenous amikacin, and a complete healing in 7 months. And this is one of my patients post-herpes zoster sclerokeratouveitis, who was treated with oral valsivir and prednisolone. So when I see the results, the causes of decreased vision included corneal scar, cataract, macular scar, phthisis bulbi, and 2 patients had glaucomatous optic atrophy. Poor visual outcome on a univariate analysis was depending on poor visual acuity at presentation, necrotizing scleritis, multifocal scleritis, associated keratitis, and uveitis. So in conclusion, I would say that infectious scleritis should be suspected in cases where there's a history of trauma, surgery, and more so that they are being treated with topical and oral steroids. It's often an elusive diagnosis, and repeat scraping and biopsy does help in clinching the diagnosis. Antimicrobial therapy should be started as soon as possible, and surgical debridement in selected cases is often helpful. And early diagnosis and antimicrobial treatment can result in complete resolution of infections, but the prognosis depends on our complications. Thank you so much.
Thank you, Mamta. So over to the judges. Dr. Herbert, please.
Well, there's nothing much to say. This is a very beautiful series, and thank you for the images and your conclusions. That's all.
Dr. Khairala, please.
Thanks, Dr.
Thank you for this very nice data. The delay in diagnosis, could you please comment on this point? And I have another question regarding the diagnosis of viral scleritis. And do you have a case of herpes simplex scleritis? And what were the criteria for diagnosis of herpes simplex scleritis?
Thank you for the question, Dr. Kerala. But I had 5 patients, and as we know that viral scleritis, there is no tissue diagnosis, and we cannot have a biopsy or something. So all 5 patients, they were associated. 4 patients had keratitis, out of which one was disciform keratouveitis, and another patient had only uveitis. And there were 2 patients with zoster. So all 5 patients, actually, it was a presumptive diagnosis based on the history of herpes zoster ophthalmicus and keratitis and uveitis association. And they responded well and with no recurrence on follow-up. So that was my criteria for these 5 patients with viral scleritis.
And how would you explain the delay in diagnosis? The diagnosis was very delayed. Is it the diagnosis of scleritis itself, or of the diagnosis of infectious scleritis? This is
the diagnosis. Yeah, thank you for your question. It's very interesting. The diagnosis of scleritis is not delayed in all these patients. Yes. So I became interested in the subject. Why? Because all of these patients majority were treated with steroids in different forms, and 3 also on immunosuppressive. So they had a longer interval of treatment. So the diagnosis was never missed. It was always treated as scleritis. But the important part is that the infection was missed. Hence, the diagnosis for infection reached a little late, on an average like 3 months. So that was the thing. So non-response to corticosteroid was the main reason that the patients were referred. We being tertiary care, that was the reason for the delay in the diagnosis. So because the symptoms especially if it's a non-ulcerative lesion, so the nodular lesions or a diffuse lesions are often mistaken as immune-related scleritis, and hence they are treated with corticosteroids in different forms. I'm not sure if I answer your question.
Thank you.
Thank you.
Dr. Gupta, please.
Yeah, Mamta, I think an excellent collection of cases. And to take forward Monser's question of delayed diagnosis. Now, if you were to see all these 45 patients primarily coming to you, how would you be able to behave differently, diagnosing them infectious scleritis vis-a-vis immune-mediated scleritis? I mean, what is the lesson for the audience, So
when I analyze all these patients, so what was the main reason that the diagnosis was missed? That there are two different manifestations how an infectious scleritis will present. So if I go back to the history, a patient who says that he's been on steroids for longer times and not responding and pain is always increasing, it's wincing and waning, it gives me this thing that it can be a fungal or it can be an atypical mycobacteria, which I saw in few of my patients where the patient had a longer duration of disease. And he says that when he takes steroids, he responds for some time and then it again recurs. Number two was the multifocality of the lesions with yellow spots. These were patients which I saw in my nocardia patients. So nocardia is known to present with multifocal nodular lesions. And these nodular lesions are often misdiagnosed as nodular scleritis. And if I see, there was no systemic associations. None of these 45 patients had any kind of collagen diseases. So that also gave me a clue that infectious scleritis and other, they were worked up by different people who had treated them, but they were all negative collagen workup. So that also gives a clue that infectious scleritis, a patient with not responding to steroids, and the clinical manifestation, they all point that we are missing something and the treatment should be reapproached. It should be like patient should be taken earlier for a biopsy. And one of my patients that even if the biopsy showed it was an MTR TB positive, so that can be a false positive reaction. So a PCR test may not be conclusive for the etiology of patients with scleritis. We have to be really careful to take them with a pinch of salt, unless it's a bacterial or fungal where it is matching with the clinical pictures.
So would you consider like half of your patients had history of trauma or surgery? Would in these patients the infectious scleritis be much higher on the card in differential diagnosis rather than immune-mediated uveitis?
Actually, it is the other way, sir. When I see the literature, the predisposing factor of surgery and trauma was a main factor. But interestingly, in my patients, nearly 47% did not have any inciting factor. And when I see the literature, surgery was a main cause, but we did not have even one patient who had a history with pterygium, which was a main thing which I see the literature that a lot of patients with pterygium surgery. I had only 6 patients with vitrectomy and 2 patients post-cataract surgery. Trauma was a main factor which had mainly fungal scleritis because these were population who were the laborers, farmers, and the history of dust and some kind of a rice or vegetable matter injury. So that a correlation I could find. But except for 24 patients, the other patients, they did not have any history of any inciting factor. So I would not say that surgery and trauma really form an important inciting factor for these patients. As per my...
No, I'm not saying the inciting factor. I'm saying when the patient comes to you and when the patient gives a history of trauma or surgery in the past, won't you consider infectious etiology more than the... And secondly, some of your patients got peribulbar corticosteroid, deposteroids. Was that given for scleritis or some other disease?
There were 3 patients who were treated with periocular steroids in this study prior to presentation to me, and they were
scleritis.
For scleritis.
Okay.
3 periocular subtenon depot was given.
And all these three were fungal or bacterial or what was?
Sir, I have to look into that. These three patients, I'm not
So
sure.
we found that in scleritis, at one point of time, it was a quite common or popular treatment, but in our experience, giving peribulbar corticosteroids, led to fungal endophthalmitis in these patients because the fungus is able to penetrate the scleral coat very nicely,
I can get back to this looking at the chart, sir. I offhand won't remember this, but there were 3 patients with periocular steroids and 3 patients were treated with azathioprine and methotrexate also.
Very nice collection of cases.
Thank you, sir.
Great.
Thank you, sir, and thank you, Dr. Mamta, for a nice presentation. So
Thanks,
with this,
Rima.
thank you. So with this, we now move on to the next presentation by Dr. Suchitra Biswal, who will be talking on predictors of visual outcome in post-fever retinitis, a retrospective analysis.
Good afternoon, one and all. My topic of presentation is factors predicting the final visual acuity in post-fever retinitis, a retrospective analysis. Coming to the brief introduction, post-fever retinitis is a term used to describe the ocular inflammatory manifestation following a febrile illness. It presents as a unifocal or multifocal retinitis, particularly involving the posterior pole and peripapillary region, as depicted here. The aim of the study was to identify the predictors of final visual outcome in the cases with the post-fever retinitis. It's a retrospective study. The patient diagnosed with a post-fever retinitis with a regular follow-up till resolution of retinitis with good quality of fundus image and OCT image were included in the study. And the patient presenting with the acute onset of unifocal or multifocal retinitis with or without vascular involvement following an episode of febrile illness within the last 6 weeks were included, and the resolution was defined as a complete absence of retinal whitening and subretinal fluid and intraretinal fluid. The medical records of the cases with post-fever retinitis were reviewed, and the best corrective visual acuity at presentation and final visit, fundus photograph and OCT image, investigations during the episodes of fever and treatment during course of retinitis were included. The color fundus photograph at presentation was analyzed for the area of retinitis and area of hard exudates using an image J, and this is the image showing the measurement of the area of retinitis, and the OCT parameters that is taken into consideration at presentation at the foveal contour, intraretinal cystoid spaces within 1000 microns from center of fovea, inner retinal hyperreflectivity distance from center of fovea, its presence within 500 and 1000 microns from center of fovea, and hyperreflective dot secondary to hard exudate within 500 and 1000 microns. Central macular thickness, subretinal fluid height at the fovea is maximum height, its horizontal extent and reflectivity, drill within 1000 microns from center of fovea, and the hyperreflectivity of papillomacular bundle. This is the image showing the measurement of the different OCT parameters at presentation. Measurement of inner retinal hyperreflectivity and hyperreflective dot, SRF height, and presence of hyperreflectivity of papillomacular bundle. The OCT parameters are final visit for the center macular thickness, drill within 1000 microns from center of fovea, the horizontal height and extent of subfoveal deposit, extent of VZ loss and disorganization of the papillomacular bundle. The same thing depicted here in the different OCT picture showing measurement of CMT and SFT height and extent of VZ loss. By univariate linear regression and multivariate linear regression, now we have assessed the correlation between the factors at the presentation and resolution with the final visual acuity separately. Coming to the results of the 24 eyes of 16 patients were included, and the mean age at presentation was 44.38 years. The mean interval between fever and onset of symptoms was 4.13 weeks with a median follow-up of duration of 17 weeks. After 16 patients, 12 had no systemic illness, and the median best corrected visual acuity was 6/60. The best corrected visual acuity less than 6/60 was seen in 13 eyes. The mean area of retinitis within the macula was 0.2 and the hard exudates was 0.01. The 50% were treated with steroids and 50% were treated with doxycycline. There was a significant correlation between the following OCT parameters as presentation with the final visual acuity that includes the intraretinal hyperreflectivity within 500 microns, maximum macular thickness, foveal thickness, maximum SRF height at fovea, indistinctness of retinal layers, indistinctness of papillomacular bundle, and the reflectivity of SRF. By multiple linear regression, for every 1 unit increase in height of SRF at fovea showed that there was a decrease of 0.001 unit of final visual acuity. And this is the OCT parameters at the final presentation that showed significant correlation with the final visual acuity. Those include the final loss of inner retinal layer within 1000 microns of fovea. Subfoveal deposit presence is high, its extent. So EZ loss is presence and its extent, and vitreomacular interface. And the multiple linear regression showed that 1 unit increase in EZ loss and subfoveal deposit height, there was a decrease of BCVA by 0.001 unit and 0.00 units respectively. Coming to the discussion, as a multiple linear regression have shown that there is increase in SRF height is associated with a decrease in final visual acuity. This can be explained due to the disruption or damage of photoreceptor due to activation of SRF as it deprives the metabolic support. And the final BCVA was poor in the cases with a higher subfoveal deposit resolution. This may be due to the hindrance of interaction between neurosensory retina with retinal pigment epithelium with the presence of subfoveal deposit, and the subfoveal deposit may have a toxic effect on photoreceptor. As we know that the ellipsoid zone integrity reflects the presence of healthy photoreceptor. The increase in the length of subfoveal EZ loss had a poorer final visual acuity. And this is a representative case in which a 32-year gentleman who presented with post-fever retinitis with a BCVA of 618 treated with steroids. His final visual acuity was 6/6. At presentation, there was a inner retinal hyperreflectivity away from fovea of more beyond 500 microns, and EZ loss away from the fovea. And this is another case of 19 years gentleman who presented with BCVA of 1/60. At the final presentation, his BCVA remained 1/60, and here the OCT showing the inner retinal hyperreflectivity within 500 microns to the fovea and the presence of subfoveal deposit with loss of EZ, and the hyperreflectivity of SRF. And to conclude, this study gives a better understanding of various factors predicting the visual outcomes in post-fever retinitis. As initial presentation, height of subfoveal fluid and its subretinal fluid and its reflectivity, inner retinal hyperreflectivity, presence of papillomacular bundle hyperreflectivity, presence of drill close to fovea had poor visual outcome. And at resolution, presence of drill close to fovea, presence of subfoveal deposit, and loss of EZ and its extent had a poorer visual outcome. The limitations include it's a retrospective study, smaller sample size, and the macular ischemia could be one of the cause for poorer visual outcome, which was not evaluated. Thank you.
So thank you for your nice presentation, Dr. Suchitra.
Thank you, ma'am.
Dr. Khairala, your questions, please.
Thank you. As I mentioned before, my major concern is about the term and the cause of this post-fever retinitis, as there is a wide variety of causes. It is important to differentiate, for example, between bacterial retinitis and non-bacterial retinitis, as this may have some important implication for treatment and prognosis. And this is very interesting data. However, I think that we have to pay attention in this patient, to pay attention to the presence of vasculitis, and some of them may have occlusive retinal vasculitis and branch retinal artery occlusion, and this may have implication for the final prognosis. The second point is the presence, and I think a high proportion of patients may have neuroretinitis, and some hyperreflective macular deposits may be caused by optic nerve involvement. So it is important to exclude neuroretinitis associated with this foci of retinitis.
Thank you, sir. Of the 16 patients, there were no neuroretinitis like picture, And we have worked up for the etiology too. Among them, only 3 patients the etiology could be established, and the rest the etiology could not be established. So.
Sorry, I would like to stress again the importance of excluding, for example, rickettsial retinitis, because and cat scratch disease in some other areas, because these conditions would need treatment with doxycycline. So we have to treat them with doxycycline and not with only corticosteroids. So it is important that in any patient with multifocal or unifocal superficial retinitis following fever, to exclude maybe rickettsial disease, given the application for treatment, for example. And this is very important, not to treat rickettsial retinitis with only corticosteroids, to give them doxycycline with or without corticosteroids.
So the point is taken, sir. Like here we had 3 patients who were diagnosed with dengue and typhoid. In our series, we didn't have any Will Felix positive, so of the 16 patients.
Okay, I congratulate you for this technically very well conducted study. However, we don't really know what we are talking about. And I think there is still a lot of work for this condition. And so I have some reservation on the relevance of this study. I think there is a lot of work to do, not by yourself, but I mean, to clarify this condition, and by these few words, I just sum up what Moncef said before me. But thank you for your study.
Thank you, sir.
Dr. Gupta, please.
Yeah, I think the purpose of the study is not very clear to me. And some of the parameters studied could be just incidental, like the height of fluid or the area of retinitis, because critical is the involvement of the fovea, the central 500 microns of the retina, and the disorganization of the intraretinal layers, the drill and the ellipsoid zone, rather than secondary effects like fluid or exudates, which will spontaneously resolve over a period of time once the retinitis is taken care of. So I think we need to be able to tell the difference between what are the structural damage and whether you can anticipate or diagnose structural damage in the central fovea at the time of presentation and predict from that the patient will have a poorer outcome, or looking at the height of fluid. We have seen massive fluid collection in patients who recovered 6/6 vision without any damage. So I don't think that can be a valid criteria. So they could be all confounders, in your cases. So anyway, it's a good attempt to try to analyze if you could predict. And yeah, sure.
Thank you.
So thank you, Dr. Gupta, and thank you, Dr. Suchitra. So we now move on to the next presentation. May I invite Dr. Uday Tekchandani, who will be talking on middle limiting membrane in tubercular serpiginous-like choroiditis, a semi-automated quantitative analysis using swept source OCT.
So good afternoon, everyone. So the topic of my paper today is middle limiting membrane in tubercular serpiginous-like choroiditis, a semi-automated quantitative analysis using SSOCT. I'd like to acknowledge all my co-authors as well as Advanced Eye Center and USICON for giving me the opportunity to present. So coming to a brief introduction, post our nil financial disclosures. TB-SLC is a very common phenotype of ocular tuberculosis in our country where TB is very endemic. It primarily involves the RPE and chorocapillaris, as we know. However, when we did serial OCT-B scans of our patients with TB-SLC, we found, interestingly, some changes in the outer plexiform layer. Going back in reading, we found that Feynman Zimmerman, back in 1962, had actually histologically divided the OPL into 3 layers, and the inner 2 acellular layers were described as a middle limiting membrane. So the purpose of our study was to analyze longitudinal changes in the OPL in patients with TB-SLC and compare it with healthy control population. So it was a retrospective study done at the Uveitis clinic at our institute. We included patients with newly diagnosed TB-SLC based on presence of a positive radiology in the form of a chest X-ray or a CT scan, clinical evidence of extraocular TB, and or microbiologically proven in the form of sputum positivity or biopsy, along with presence of any immunological test like a MON2 more than 10 by 10 or a positive interferon gamma release assay. All patients with any evidence of any other form of uveitis were excluded. Along with that, other inclusion criteria included patients with less than 6 months of follow-up, paradoxical worsening on ATT, those with media opacity, poor fixation, and those patients who received any intravitreal therapy during their treatment. So patients were evaluated at 3 visits, at baseline being M1, 3 months being M2, and 6 months being M3, and a complete ophthalmic evaluation with fundus photography and SSOCT was done at each of these 3 visits. And 3 OCT line scans were taken, 1 through the center of the fovea, 1 above and 1 below the fovea. So age and gender matched healthy controls were also imaged parallelly, and all image analysis and automation was done using the microJava capability within the ImageJ software. So the analysis was in 2 levels. First was the pre-processing of the manual stage, where the freehand tool of the ImageJ was used to crop out the ONL and the INL to isolate the outer plexiform layer. Following this, in the automated stage, these pre-processed images were converted into an 8-bit format, and a rectangular selection of 230 by 260 pixels was measured as the OPL area and analyzed. So this is a representative image of one such patient, where we can see, if you can see my pointer, that this was the outer plexiform layer, which was manually isolated out by removing the INL and the ONL. And this was further segment converted automatically using the ImageJ software and was analyzed in terms of area. So coming to our results, we had 16 patients and 32 eyes, 11 of which were male. The mean age at presentation was 32.9 years. The mean duration of symptoms was around 4 weeks. And the mean visual acuity at presentation was 0.38 logMAR units. We also used 14 individuals as controls, of which 10 were males, which were with the mean age being 31 years. Looking at the area of the OPL in pixels, we noticed that comparing from baseline to 6 months, there was a significant reduction in the area of the outer plexiform layer between month 1 and at 6-month follow-up. However, this was not seen between month 1 and month 3, as well as between month 3 and month 6. However, it was between baseline and the final follow-up. This is the image of one such patient, where we can see this was the outer plexiform layer on presentation. On 3 months follow-up, this layer had thinned out, and the band had now converted into a thin atrophic line, which was even thinner at 6 months. Comparing this with normal healthy controls, we saw that at baseline, the area of the outer plexiform layer was comparable. But at 3 months and 6 months follow-up, both through and below the fovea, there was a significant reduction in the OPL layer as compared to that of normal controls. Whereas in that above the fovea, there was a significant reduction at 6 months follow-up. So coming to our conclusion, TB-SLC can develop pathological atrophy of the OPL on treatment. So as we know that the OPL actually receives its vascular supply both from the retina and the choroid, compromised RPE and the choriocapillaris in TB-SLC can actually result in damage to the OPL and possibly beyond. Eventually, complete atrophy of the cellular structures of the OPL can result in its replacement with a hyperreflective line, presumably composed of remnant extracellular tissues like desmosomal proteins, which is the middle limiting membrane. Thus, we report a novel finding in TB-SLC, which represents permanent structural alterations which can lead to reduced functional acuity in the long term. I would like to thank Advanced Eye Center and USICON for giving me the opportunity to present at this forum.
Thank you, Dr. Uday. So over to the judges. Dr. Gupta, please.
Yeah, Uday, I couldn't understand the purpose of this study in the first place. You know, if you know the retina microstructure, The only layer which is kind of loose is the outer plexiform layer. The rest of the retina is totally tightly packed, and we don't expect much changes in the other layer. This is the one which will respond to any insult behind the retina or in front of the retina. So outer plexiform layer is the one which will keep on showing a response, whether getting thickened or getting thinning. So I don't know whether this will be exclusive to serpiginous like choroiditis, or it will happen in any choroiditis which affects the outer retina. So I don't know how you are going to use this information to either diagnose or prognose your patients with serpiginous like choroiditis. I mean, what's got to do with TB or serpiginous feature? It could be seen in any. So rather than control, you should have taken some patient with choroiditis, and you might have made a point, trying to differentiate choroiditis and chorioretinitis or retinochoroiditis or retinitis, and that could have been better controls for your study. So in the present form, I don't see it carries much conviction, the way it's done.
Thank you for your question, sir. These changes in the OPL, the middle limiting membrane, has been described in inner retinal diseases like CRAO and PAM. It's not actually been described in any choroiditis disease. Secondly, as we know, TB-SLC involves primarily the RP and the chorocapillaris. So to expect a secondary insult hitting all the way up to the OPL and probably beyond was a novel finding that we saw, that we actually did not think of theoretically, since the OPL has a dual blood supply. But yes, sir, your queries duly noted that we could compare these with patients with other morphological varieties of choroiditis and have a look whether this is isolated only to TB-SLC or to other forms of choroiditis as well.
Dr. Herbert, please.
If I can you hear me?
Yeah.
Okay. If I understand you well, these were early cases of serpiginous. Is that true?
Yes, sir. All of them had a history of symptoms of around 4 weeks, 4 to 6 weeks.
So tell me, what happened to the ISOS line or to the photoreceptor outer segments in these cases? Maybe I was not attentive to. Maybe you told it in your presentation.
Dr. Herbert, we haven't touched on that, but yes, there was definitely loss of the ISOS, the ellipsoid, and the myoid zone as well, as those are more proximal to the chorocapillaris and they receive their blood supply completely from the choroid. Those would still be expected, but for the insult to reach all the way up to the OPL was something novel for us to find.
Yeah, so it's very hard to believe that specifically OPL is damaged, by ischemia, and not the or not so much the ISOS line. This is very troubling.
Dr. Herbert, as we know that the ISOS, the ellipsoid, and the myoid, damage to them would be actually expected because of the ischemic insult. But we wanted to look only at the outer plexiform layer, as we were not expecting insult to that.
Yeah.
So yes, there was outer damage as well. But looking at them,
of course, but still, you have to compare what happens to the OPL to what happens to the ISOS line. Otherwise, it's very difficult to have conclusions about what you demonstrated. So I'm expecting, that maybe in the future work that you're showing this, because the lesion, I mean the impact of choriocapillaris non-perfusion is first on this layer. It may be more, of course, and this is interesting, but I think you should put it in perspective. And I thank you very much for your study.
Definitely. Thank you so much. We'll keep this in mind. Thank you so much.
Thank you, Dr. Herbert. Dr. Khairala, please.
Thank you for this nice presentation, and I agree with my friends and that maybe the next step would be a comparative study between serpiginous like choroiditis and other choroiditis entities to establish the potential value of this finding in the diagnosis of serpiginous like choroiditis, tubercular serpiginous like choroiditis. Thank you.
Can I just make a comment, Rima?
Sure, ma'am.
I think serpiginous like choroiditis was just an incidental thing because that was the part of the patient where we had very clean data. But to be honest, this paper was more about technicalities and segmentation and to be able to do OPL and had nothing to do with serpiginous as a disease or looking at that perspective. It was just like detecting basilar layer detachment. But I agree, and all of them did have CAL changes in the OS-IOS, which were documented, and changes in the OPL were secondary. Thank you, and sorry to barge in like this, sorry.
Thank you, ma'am. So any more questions from the judges? Okay. Thank you, Dr. Khairala. So with this, we now move on to the next presentation. I invite Dr. Atul Arora to present his work on subretinal hyperreflective material in posterior uveitis.
At the outset, I would like to thank the scientific committee USI for the opportunity. My study is on subretinal hyperreflective material in posterior uveitis. Subretinal hyperreflective material, or SHREM, is a morphological feature seen on OCT as hyperreflective material located external to neurosensory retina but internal to RPE. SHREM may be composed of neovascular tissue, hemorrhage, exudates, fibrosis, or vitelliform material. SHREM has been extensively studied and reported in pathological conditions like AMD, myopia, and pachychoroid. It is of special interest in AMD eyes, where it has been associated with poor gain in visual acuity and poor response to anti-VEGF. Coming to our study, the aim of our study was to analyze SHREM in posterior uveitis using swept source OCT and OCT angiography, and to analyze the role of anti-VEGF therapy in vascularized SHREM. This was a prospective, interventional, randomized control study where subjects with quiescent posterior uveitis presenting within the study period of January 2019 to March 2020 were enrolled. Swept source OCT and OCT angiography was used to characterize SHREM and identify intrinsic neovascular network inside the SHREM. We studied a number of quantitative and qualitative SHREM characters, the quantitative characters being SHREM height, width, and SHREM flow. Among the OCT line scans, the scan showing largest SHREM dimensions was chosen to calculate SHREM height and SHREM width, while a third-party software, ImageJ, was used to calculate the intrinsic flow inside SHREM. Coming to qualitative characteristics, the reflectivity of SHREM was compared as compared to nerve fiber layer, and if reflectivity was similar to nerve fiber layer, the SHREM was labeled to have high reflectivity, and if reflectivity was less, it was labeled to have low reflectivity. Transmission of OCT signal underneath the SHREM was studied to be either increased or decreased. Presence or absence of intra or subretinal fluid was noted, and pitchfork sign, which represents outward finger-like projections from the surface of SHREM to outer retina, was noted. All eyes with SHREM on OCT underwent OCT angiography to find presence or absence of neovascular complex. If neovascular complex was present, the SHREM was labeled as vascular SHREM, otherwise avascular SHREM. The eyes with vascular SHREM and presence of fluid on OCT at baseline received 3 monthly doses of intravitreal anti-VEGF followed by PRN. The eyes with vascular SHREM but no fluid on OCT were randomized to either treatment or observation arm. Treatment arm received treatment similar to group 1, while observation arm patients were kept on monthly follow-up for 6 months, with crossover criteria being drop in visual acuity, new onset metamorphopsia, or appearance of fluid on OCT. Coming to results, 42 eyes of 33 patients were enrolled with mean age of 29 years. Tubercular choroiditis, multifocal choroiditis, and punctate inner choroidopathy were important etiological diagnoses of the eyes enrolled in the study. Of the 42 eyes studied, 28 had vascular SHREM, while 14 had avascular SHREM. Of 28 eyes with vascular SHREM, 6 had presence of fluid at baseline and received anti-VEGF. Remainder 22 eyes were randomized in ratio 1:2 to treatment or observation arm. During the study period, 4 eyes in the observation arm had to be crossed over to treatment arm. Now, let us compare the baseline OCT characteristics between vascular and avascular SHREM. High reflectivity and increased transmission of OCT signal under the SREM was suggestive of avascular SREM, while pitchfork sign and presence of intra or subretinal fluid indicated vascular SREM. The eyes with vascular SREM and fluid on OCT upon treatment showed significant improvement in visual acuity and reduction in SREM parameters. Now, let us see to our groups of vascular SREM without fluid that we randomized. Both the groups were comparable in terms of demographic features and etiology. The eyes in treatment group had significant improvement in visual acuity and reduction in SREM height, width, and flow, while the eyes in observation group didn't show much change. It is important to see the eyes that crossover. At the time of crossover, the visual acuity dropped, while SREM height, width, and flow increased in these eyes. Let us go through this representative case of a patient with punctate inner choroidopathy that presented with metamorphopsia. Baseline OCT scan shows a SREM with low internal reflectivity and low OCT transmission, and corresponding OCT angiography shows a RAP lesion with flow on B scan. The patient was treated with anti-VEGF. The SREM resolved with disappearance of neovascular complex, and we can see that increased OCT transmission through it. To summarize, SREM is an important OCT finding in posterior uveitis. 2/3 of eyes in our cohort harbored intrinsic neovascular membrane. High reflectivity and increased OCT transmission through SREM indicates avascularity, while presence of pitchfork sign or intra or subretinal fluid may be markers of intrinsic neovascular complex. All SREMs with neovascular complex do not require treatment. However, these eyes need closer follow-up, as a quarter of these eyes during the study period developed symptoms and had to be crossover. Limitations of my study include small sample size and modest follow-up duration. Studies with larger sample size and longer follow-up will be useful. Thank you.
So thank you, Dr. Atul. So Dr. Herbert, for your questions, please.
Yes. This is an interesting study, as most of them. I congratulate all the presenters. Today, I'm a little bit bothered by the terminology you use. I think it's difficult to speak about posterior uveitis. This is a general term, and you can only use it as far as you give the, I wouldn't say the etiology, but the specific diagnosis of posterior uveitis. Is it multifocal choroiditis or what else? You know, we know that some of the posterior uveitis cases are more prone to produce neovascularization, and this is especially true in multifocal choroiditis. And applied to this specific diagnosis, I think your study is very appropriate, but I think you have to, as in many of these presentations, you know, the limits and the definition of the cases studied are a little bit blurry. But I congratulate you for the study.
Thank you, sir, for the comments. Actually, the purpose of this study was to see in background scarring. Like it is very difficult to pick up a small hemorrhage or a neovascular membrane developing up. In our study, we didn't specify a particular etiology like multifocal choroiditis or so. We took across the spectrum, like it included tubercular SLC as well as multifocal choroiditis, as well as PIC patients. The purpose was just to pick up the OCT as well as OCT biomarkers that point toward intrinsic neovascularization and use OCT angio to confirm that. The problem, because in such eyes, is that even the invasive modalities like angiographies also would not give much information about neovascularization due to background scarring, staining. Yes, because of it's a kind of pilot study also, and we use the whole cohort of patients with scarring. Further, if we have larger follow-up and longer studies to be planned, we can take etiology-wise or specific phenotype-wise, like in TB, SLC, and MFC differently.
Yeah, this is truly a way to go. Huh?
Yes.
Thank you, Dr. Herbert. Dr. Khairala, please.
Thank you very much for this very nice presentation. And my concern is not about your study. This is a very nice study. It's about the new terminology in the field of retina. And I think that the term vascular hyperreflective, subretinal hyperreflective material is a bit confusing as compared to the old term choroidal neovascularization. So the key point is for us as ophthalmologists and a patient for uveitis is to rule out or to exclude choroidal neovascularization. And I agree that clinical findings and OCT findings can help us in detecting choroidal new vessels. And I would add OCT angiography for that purpose to make sure there is no choroidal neovascularization because of the application for treatment with anti-VEGF. Thank you very much for this kind study.
Yes, sir. So the SHREM as a morphological description is relatively new to the uveitis group, while it has been used for some time in AMD eyes and in other spectrum. By looking at the similar picture, because on OCT you see some hyperreflectivity, but you don't know what is it. Is it a scar? Does it harbor intrinsic neovascularization, or it may be just exudation? So the purpose was just to pick up biomarkers. Like here we found that low reflectivity and decreased transmission was suggestive of that hyperreflective material harboring neovascularization, vis-a-vis if you have high reflectivity and otherwise that may indicate scarring. So it's a newer terminology in eyes with uveitis, but we just wanted to see because clinically it is very difficult to pick up.
Dr. Gupta, please.
Yeah, Uday, I think it's an excellent work that you've done, and congratulations for that. And old wine in a new glass, if I can say. And two questions: how many patients you had to screen to get these 42 odd cases of SHREM? And number two, are you aware of any histopathology of SHREM? So what does it consist of? What kind of material is this consists of? And three, did you do the sensitivity and specificity studies to find out if SSOCT was a sensitive tool or as sensitive as the OCT angiography, or if we have to stretch it, the ICG, which would be the gold standard for diagnosing the CNV. And if you could, by your analysis, show that SHREM and with the parameters you have described for neovascular and non-neovascular SHREM, you can diagnose with confidence, with high sensitivity and specificity compared to the gold standard ICG and OCT angiography, I think you would have made a remarkable point.
Thank you for the comment, sir. Regarding first question about how many patients did we had to screen to enroll these? Actually, we enrolled eyes with quiescent activity. At least 6 months of quiescence was required. This was because in inflammation, I just want
to know the frequency of SHREM in patients with choroiditis. 6 months is a later story. How often would you see in patients? You have to counsel a patient with choroiditis, and you have to tell him, look, buddy, you have 50% chance or 20% chance or 10% chance of developing a complication because of choroiditis in terms of developing a choroidal neovascular membrane, which will not be able to diagnose clinically, and you might go blind from that. So from that point of view, you will need to tell us how frequent is the SHRM, in SHREM in patients with choroiditis.
So I have not looked for the direct frequency, but by my experience of recruiting patients, approximately 1/3 of the patients with choroiditis would have that that hyperreflective material. That could be scar, that could be anything. That's another point. And so your second question regarding histopathology, while literature search or looking up for similar data, I could not find any report that has corroborated because it is very difficult to take a sample or any histopathological evaluation that has corroborated SREM and compared it to OCT data. Also, whether if you have like such kind of presentation, it may be a scar, or you have such, a low reflectivity, that may be an exudation. So histopathological studies, yes, sir, that would be confirmatory in such cases, but they are difficult to take samples, and
they're not available even for the ARMD cases.
Yes, sir. So for ARMD, they are present. And for SREM, no, specifically because it's an OCT terminology. But yes, they have compared the type of drusions, the neovascular complex, but direct corroboration with SREM and its characters, I'm not aware of such studies in AMD.
I think, Uday, you need to go back to literature of 60s when a lot of pathology of choroidal vascular membrane was described, and they were describing on histopathology all what we are seeing on OCT now. You know, so you go back to that era when there was nothing else but except doing pathology studies, and you would find any number of references on pathology, you know, of these eyes which harbored new vessels, and I'm sure they would have come across all the SRAM and whatever you see in these patients.
Yes, sir. That's a
Green
good
has
point.
done that work. Dr. William Richard Green has done it work in the John Hopkins Wilmara Institute. A lot of autopsy eyes.
Yeah, that's right.
Sir, and regarding last question about sensitivity and specificity of like specific parameters, the sample size was too small to calculate such a data, and if we would have tried also, we could have been statistically wrong in giving the numbers.
No, I don't think you have 42 patients. Uday, if you had done the ICG or even with OCTA, you have done in all, you know, you had just simply got to see whether it matched, you know, because there is likely to be a prejudice if you don't blind the analysis of SREM and neovascular SREM and non-neovascular SREM and OCT angiography, because if you are analyzing, you would say 100% accurate, but it has to be a blinded procedure. So I think, but anyway, it's an area which needs further exploration and evaluation in future. Good luck.
Yes, sir. We didn't include the invasive imaging to as a gold standard in our protocol, but that's a good idea to confirm and take out sensitivity data. Thank you, sir.
Thank you, sir, and thank you, Dr. Atul. So with this, we move on to the next presentation. The next presentation is the last among the competitive category, but we do have another presentation that will be in the non-competitive category because the original presenter is not with us. So I invite Dr. Vipin Rana to present his work on automated lesion segmentation and quantification for prediction of paradoxical worsening in patients with tubercular serpiginous-like choroiditis.
Good afternoon, everyone. I would like to acknowledge all my co-authors and my institution, and no financial disclosures. At the same time, I would also like to thank USICON for giving me this opportunity. Tubercular serpiginous-like choroiditis is an inflammatory disease which is thought to be an immune response to the mycobacterial tuberculosis, as we all know. And paradoxical worsening of TBSLC lesions may be seen on initiation of anti-tubercular therapy. Paradoxical worsening is a major concern in these cases as it may cause visual morbidity, and it requires high-dose corticosteroids along with adjunct intravitreal injections or immunosuppressive therapy to prevent permanent damage. However, there is a sparse literature which is available for prediction of outcomes upon initiation of therapy based on baseline imaging and clinical characteristics of choroidic lesions. So the purpose of our study was to develop and evaluate a fully automated pipeline that allows the fundus images in our patients with tubercular SLC for prediction of paradoxical worsening. It was a retrospective study, and patients with TB SLC with a follow-up of 9 months after initiation of ATT therapy were included. Eyes with medial opacity and poor fixation, precluding adequate imaging quality, were excluded. Based on the presence or absence of the paradoxical worsening, 134 patients which we included were divided into two categories. That is paradoxical worsening present, PW positive, or the paradoxical worsening absent, PW negative. And how to define paradoxical worsening? So in our study, we define paradoxical worsening as worsening of disease upon initiation of ATT within first 3 months, characterized by development of new choroiditis lesions or worsening of previous lesions with increased size or increasing number. So for this study, initially we did the pilot analysis, for which we use a third-party software, that is Image, and we did the pre-processing of the images, lesion segmentation, and then subsequently the quantitative analysis using the color fundus photography at baseline visit for 12 images as a pilot study. And this pilot study confirmed adequate repeatability agreement. After doing this pilot analysis, subsequently we analyzed all the images of the patients which we had included in our study. So the pre-processing included all images were imported and converted to the 8-bit. Image contrast was enhanced using the value of 0.3%, and the image intensities were normalized on a 256-step scale between 0 and 255 to remove disparities due to capture exposure differences. In our study, we also excluded the peripheral rim of the image equating to 5 to 8 degree field of view. Thus, approximately out of the 50 degree, the degree which we captured was approximately 45 degree. Segmentation of the images was done using the Schoenberg's threshold and the Lee threshold, and it delineated the lesion areas. In the quantitative analysis, we analyzed different matrices, that is mean pixel intensity, minimum pixel intensity, maximum pixel intensity, and the integrated pixel intensity, and the segmented lesion areas. So in the results, number of patients in the paradoxical worsening group were 44, whereas in the paradoxical negative group, we have 95 patients. And all these patients had almost similar characteristics at the baseline. That is, the baseline BCVA was 0.92 compared to the 0.87 in the PW negative group. On seeing the imaging biomarkers, that is the different matrices, that is the mean pixel intensity, maximum and the minimum pixel intensity, and the integrated pixel intensity. All these matrices had a statistically significant difference between the two groups, that is the paradoxical worsening positive and the negative, and showing higher values in the paradoxical worsening group. Also, when we compared the area of the lesion in both the groups, it was again statistically significant in the paradoxical positive worsening group. The derived quantitative matrices revealed that in the paradoxical worsening group, all these baseline images had higher segmented lesion area and the main pixel intensity values. So what are the advantages of our study? This fully automated pipeline can be deployed for rapid assessment of hundreds of images in few minutes and can predict eyes which are at the highest risk of developing paradoxical worsening. Clinicians can be forewarned regarding the risk of development of paradoxical worsening once ATT has been initiated, and also it is completely objective and does not require a trained uveitis specialist to grade the images. The image analysis can also be done remotely using telemedicine for guiding the treating ophthalmologists from a distant location. However, we have certain disadvantages also being a retrospective study design. And as we all know that the retrospective study design have the selection bias. So we had the selection bias, and thresholding algorithm may fail at several locations within a single image frame. So to conclude, automated calculation of choroiditis lesion matrices is a novel approach, and the repeatability in the is.
Your time was up, Vipin, so you can conclude anyways. Yeah.
So to conclude, the main pixel intensity and the segmental area in the cases where the paradoxical worsening was present was statistically significant higher as compared to the cases which showed no paradoxical worsening.
So thank you, Dr. Vipin, for a nice presentation. Dr. Khairala, for your comments, please.
Thank you very much for this very nice presentation. And I think this is a very important issue to have predictive parameter for paradoxical reaction in serpiginous like choroiditis. I think this is a very important challenge. And however, your study is just a preliminary study, so I hope the next step would be validation in a prospective study to provide us with objective parameter to predict this reaction after treatment of serpiginous like choroiditis. Thank you.
So in fact, we had our group also had a almost similar publication in American Journal of Ophthalmology, which was published in 2020. However, in that we showed that we used a subjective measurement, subjective idea, for which the classification subjective on the basis of subjective appearance of the images, we made a classification which was divided into 3 grades, and this was the objective method.
Vipin, what Dr. Khairala is saying that this is just a pilot thing, AI-based tool that needs validation. So that is the next step.
Right.
That's it.
So thank you, Dr. Khairala. Dr. Gupta, please.
Yeah, Vipin, it was nice presentation for an audience of artificial intelligence people. Ophthalmologists are not really sensitized as yet to artificial intelligence tools. So we have to look up the dictionary to look at what pipeline, what is automation, what is segmentation, and what is a pixel, and what is the mean and median and low and high, because all those terms you should have shown in your presentation. I would have valued it much more if you had introduced the technology rather than giving us the values. And serpiginous like choroiditis lesions, to my mind, are very, very, diverse in their intensity, in their pigmentation, in their quantum of pigmentation, which will affect the number of pixels if my interpretation of pixel is correct. And so I don't know, the study may have been, fine. It's as a technology demonstration, but as a practical value to the clinicians, I think it's still far away. So as a technology demonstration, fine. You should have demonstrated that rather than give us bare facts and figures, without explaining what it means to any one of us.
Right.
Can I say something?
Dr. please.
Can you hear me?
Yeah.
Yeah. Well, congratulations for your study.
Thank you so much.
Now, when you have a PW positive patient, what are you doing with such patients?
Sir,
I mean, what is going to be your management of such patients?
Sir, any patient with a paradoxical worsening, we have to increase the oral steroids in those patients. In fact, role of the Ozotex, it has also been shown in cases of the paradoxical worsening. So that is one thing. And secondly, from this study point of view, the treating clinician, he has to be very, very careful while treating these patients between 3 to 8 weeks in terms of tapering the oral steroids.
So I couldn't hear you very well. So you are you going to change your management, or what are you going to do?
Yes, sir.
Huh?
Yes,
so
sir.
in what way?
Sir, yeah. In terms of paradoxy, patient is having the paradoxical worsening.
Yeah.
We have to increase the dose of the corticosteroids. And our group has also shown the significance of using the Ozotex. If patient if it's a unilateral disease, the role of Ozotex in cases of the paradoxical worsening.
So if I understand you well, the patients you analyzed were also on corticosteroids.
Yes, sir.
Is that right? Huh?
Yeah. So from our study point of view, the message which we wanted to convey, one of the points is that clinicians have to be very, very careful while taping the oral steroids between 3 to the 8 weeks.
Yes. Thank you very much. But our attitude in these cases is quite different. Maybe it's an excessive attitude. We usually put these patients under triple immunosuppression since the beginning, because I mean the danger is exactly what you showed in your study, is that you can have a paradoxical worsening. So they are on quadruple anti-TB treatment and on at least triple immunosuppressive treatment. I mean, since the beginning, or since we see the patients, because usually they come to us much later. So it's a question of attitude, but nevertheless, if you have patients which are only on corticosteroids, I think what you're demonstrating in your study is maybe going to be useful. Thank you.
Thank you so much, sir.
Thank you, Dr. Herbert. So with this, we now move on to the last presentation of this session. Dr. Jangiri Sudha is not well, so she's not able to present her work. We'll be having Dr. Soumyava Pasu presenting the work in her place. And this presentation was scheduled initially at number 4. So over to you, Dr. Soumyava.
I hope I'm audible and the slides are visible. Thanks to Dr. Manisha and to you to let me present our research instead of Sudha. So I'm going to talk on the 2 phases of intraocular immune response in ocular tuberculosis, and we have called it the Janus effect after the 2-faced Roman god of doorways, one of the faces looking at the past and the other into the future. Let's see how it works. So we have demonstrated earlier that the immune response to ocular TB mainly consists of CD4 positive intraocular T cells, and these are highly pro-inflammatory, being multifunctional. And most importantly, the antigenic specificity of these cells is both to mycobacterial antigens as well as retinal self-antigens. So in this study, we wanted to ask, how does the immune phenotype in ocular tuberculosis vary in acute versus chronic or recurrent tuberculosis? Now, the origin of this idea comes from our clinical study in recurrent inflammation after completion of anti-TB therapy, where we found in our cohort of patients that although majority of the patients at presentation have posterior or pan-uveitis, and very few have anterior or intermediate uveitis, in those that have recurrences, majority have anterior or intermediate uveitis and relatively fewer numbers have posterior or pan-uveitis. Now, the ones that have anterior or intermediate also respond to local corticosteroid therapy alone and do not require a repeat of anti-TB therapy. Now, there can be several plausible explanations for non-mycobacterial mechanisms of inflammation in ocular TB, at least two of which are known to us. One is the role of dead bacteria or bacterial products, as has been shown in a rabbit model where injection of these dead bacteria could induce nearly all forms of uveitis. This was nearly a century ago, while more recently we have shown in our work that the intraocular T cells also have autoreactive cells, and these are more pro-inflammatory and resistant to the activation-induced cell death. So our study hypothesis was that the intraocular inflammation during chronic or recurrent ocular tuberculosis may be mediated by the autoreactive T cells. We included patients that were diagnosed as ocular tuberculosis based on clinical signs, ancillary tests, and exclusion of non-TB entities. Importantly, they had a vitritis of more than or equal to grade 2, and a written consent was taken from all. Chronic or recurrent TB was defined as those patients that had persistent or recurrent inflammation after completion of 6 months of anti-TB therapy. Now, we got the vitreous samples by parsplanar vitrectomy, isolated the T cells by commercially available kits, and these cells were activated by both the TB antigen ESAT6 as well as the retinal autoantigen IRBP. Importantly, we took samples only that had more than 2 times the cytokine response compared to the negative control. So we were sure that these were antigen-specific responses. Now, these cells were stained with different cytokines and analyzed by flow cytometry. We had 26 vitreous samples that would fit the inclusion criteria. Majority were pan-uveitis. We also had intermediate uveitis, retinal vasculitis, and serpiginous like choroiditis. 8 of these were classified as acute, while the remaining were either chronic or recurrent based on the definition that I mentioned earlier. Now, we noted that in chronic infection, the interferon gamma response was significantly higher for IRBP as compared to ESAT6, as can be shown in this figure. It was also higher for TNF-alpha and IL-17. However, it was not statistically significant. We also found that the interferon gamma response to IRBP was higher in chronic as compared to acute infection, though this was not statistically significant. Same applies to TNF-alpha and IRBP. Beyond this, we tested a few samples, we stained a few samples with HLA-DR, which is a marker for early activation of the activated T cells. And we found that the IRBP positive responsive T cells had at least 3 times higher percentage of HLA-DR as compared to ESAT6 or controls in the patients having recurrent inflammation. The same applies to the marker for proliferation, which is Ki67, and which we also found to be significantly higher. Of course, there's a single sample than either the TB specific or the control samples. Now, what could be the plausible mechanism for autoimmunity in ocular TB? We hypothesized that this could be because of the disruption of the blood-retinal barriers during intraocular inflammation and the encounter of the autoreactive T cells, which are naturally present in the circulation, to the cognate antigens in the eye, that is in the retina, and which leads to the proliferation and the activation. So to conclude, recurrent inflammation when it is presenting with vitritis alone following anti-TB therapy may be driven by autoreactive T cells. I say may be driven because I'm sure there are other mechanisms as well. And there is a lot of heterogeneity in our samples, which was the major limitation. In fact, we had actually tested much larger number of samples, but it's only to bring in a relative homogeneity that we are limited to only 26 samples in this particular study. So the autoreactive T cells do show signs of early activation and proliferation. And therefore, we believe that the intraocular immune response in ocular TB is probably Janus-phased, with one phase looking to the past, which was when the TB infection happened, and the other into the future, which is how the autoimmune response happens. I thank for your attention, acknowledge funding from the DBT Wellcome Trust Fund, and Gunjan Sharma, who did all the experiments that were highlighted here. Thank you very much.
Thank you, Dr. Basu. It's always a pleasure to look at your work and hear from you. So over to Professor Gupta for his comments.
Yeah, I think excellent work Dr. Basu and his group is doing in regards to TB uveitis, trying to unravel the pathogenesis of the phenotypes that we see. And limitation, as he said, is the sampling limitation, because you have to be able to do invasive procedures like vitreous surgery to be able to get many samples, and then you may not get adequate number of the cellular infiltrates or viable cells in the sample to be able to do all these cellular phenotyping and reactivity studies. My only one suggestion would be, when you hypothesize chronic inflammation post anti-TB drugs, to be autoreactive to IRBP, could I suggest that why don't you take samples from intermediate uveitis patients, subject them to vitreous surgery, and see how many of them who had chronic inflammation in the eye also show autoreactivity to IRBP. So if you find in a long-standing intermediate uveitis, which is of non-tubercular origin, no response to IRBP, then I think your data would be far more convincing to suggest this mechanism. I think I hope you take this suggestion in the kind of spirit I said.
Certainly, I think that's a great idea, because intermediate uveitis per se, if it's not involving the retina or the choroid, you will expect that the blood retinal barriers are relatively, spared compared to where posterior uveitis is there.
Yeah. Thanks.
Well, excellent work. What can I say more, It's a pity that it's not in competition,
Yeah, that's right.
Would have made things easier for me.
But I really appreciate all the three judges, sitting from 10 o'clock onwards, more than 3 hours, 4 hours now. And giving such productive comments to each of the papers. It's fantastic.
Well, I can only say that it was worthwhile.
Thank you. With this, I would like to thank all the judges on behalf of Uveitis Society of India, Monsev, Paul, Professor Gupta, for devoting so much of time and so much effort and dedication. We are truly honored and truly blessed to have you with us. Thank you so much for your...
Vishali, to make me get up at 6 in the morning.
Was it that?
This is really an on a Sunday morning.
And Carl, you got ready with the bow and the matching glasses. Thank you.
Okay, thank you very much for having asked me,
Thank you. Thank you, Monse. Thank you so much, despite all the time differences and everything. Thanks a ton, all of you.
Thank you, Vishal. It was my pleasure, and I learned a lot from this very nice presentation. And
I'm
thank you.
sure our next generation of uveitis experts in India learned a lot today. And as Soumya said, thank you for your guidance and personal attention to each one of the projects that were presented. Since it was after 2 years, the session was a bit longer, and we decided not to stop or adhere to the time for you guys. because we really wanted them to interact with you. Thank you very much.
Thank you.
Thank you so much. And thank you, Rima, for moderating the session so well.
Thank you, Manisha, and thank you, Dr. Vishali. And special thanks to all the judges. I mean, the fine nuances that were picked up from every presentation were so good. And I felt personally that, it was more of a teaching session by all of you, all the three judges, Dr. Herbert, Dr. Khairala, and Dr. Gupta. And I think you all presenters learned a lot from your comments, and you made us all very comfortable. Thank you so much.
And I think we made Dr. Gupta stay away from his lunch for quite late.
Yes, it's already true.
Yes, an early morning for Dr.
Gupta is a part of Uveitis Society, so we don't have to thank him. He is the host.
Well, I'm an honorary member also,
Yeah. So when we started the session, I was a bit nervous because I had a dual role of being the moderator and the presenter. But once I finished my presentation, I was more comfortable being the moderator.
Well, so we are all.
Thank you very much.
Thank you.
Rima, we have been watching presentations for the last 20 years now. And I think the standards have gone up, and Monsef and Carl would agree with my point of view, because they're watching it after a long time. And, I think things have changed and much better documented cases. And as was pointed out repeatedly, most of these appear to be little raw presentations. Many a time they could have been improved substantially for, so maybe by next time, when we come to this forum, people would have more mature presentation that way, as was pointed out by Carl and Monsef repeatedly. And, free use of certain terminologies without, rationalizing them. I think we best avoid those.
Well, Ahmad, I'm absolutely not surprised with this very positive evolution of uveitis practice and study in India. I was absolutely sure about it when I was at the first meeting in Chennai in Hotel Connemara already.
Right. That was exactly 20 years ago.
Exactly.
So, thank you very much.
Thank you.
Now I think we'll move on to the validatory function.
Judges can log off anytime. We really appreciate
it. When do we need to bring in the scores?
You can email them within the next 3 days.
Okay. Because I have to think about it a very long time,
I think 3 days would be enough, Dr. Herbert, for you.
Okay, yes. Yes, I think so.
Dr. Vishali, do I move on to the validatory function now?
Go ahead. Go ahead.
Thank you, ma'am. So very good afternoon to all of you. And I think we've had very wonderful last 3 days where we have in and out discussed all aspects of uveitis. And even though the last 2 days were working days for many of us, we made sure that we joined the meeting on time and made the best use of all the presentations. So I take this opportunity to thank each one of you, especially the faculty members, both national and international. With all their time differences, they made it a point to join their respective sessions, and they made some beautiful presentations, which probably we would have lost the opportunity if we did not have this virtual conference. I also thank each and every delegate and attendee who joined the meeting and made very active participation in all kinds of discussions that we had. I have been bothering all the reviewers, all our senior faculty members, by reviewing various free papers, posters, the cases which were submitted, and also we had some excellent photos for the photo competition. I'm sure it's quite an effort to go through each one of them and to mark them and then to come up with results. This time we had the Young Researchers Award in name of Professor Amod Gupta, and we had a panel of an expert committee who went through all the applications And with their vast experience in uveitis, they decided upon the award for this particular year. A very big thanks to our core committee members, Dr. Vishali, Dr. Kalpana, Dr. Sudarshan, and Dr. Bala, for having put in all their efforts to make this conference a success. I take this opportunity to specially thank Dr. Vishali. She is the president of Uveitis Society of India, but she was always there for constant guidance, and she was just a call away whenever I needed her help. I also want to thank Dr. Biswas. You see him sitting with us right through all the days of the meeting, and even on a Sunday afternoon, he is there. So thank you very much, sir. And many a times we were very confused what to do and how to do it. And he, with his, suggestions, really helped us solve the problems we were facing. So a very big thank you to you, sir.
Thank you.
I also want to thank all the supporters who helped in managing the finances, the Elargan India Limited, Intas Pharma, Novartis, and the Bayer Company, who wholeheartedly supported this particular conference. I also thank Cipla Pharma for helping us come up with the first member directory for our society. It has all the contact details of each and every member of the society. And I'm sure it's going to be a big help to all the members to stay connected with each other when especially we are not able to meet physically. I also want to specially thank Ms. Vedehi, Mr. Sheshadri, and the entire Hallmark team. They have been working tirelessly to put everything together, and they have been conducting the USI meeting for last so many years, and they are thorough with each and every functioning. And without their help and support, probably we would not have been able to put this conference together. So a big thanks to you, Ms. Vedehi. Now, I think the most awaited part is the awards for this time meeting. So I'll move on to the first award, and that is the photo contest winners. So the first prize of the photo contest goes to Dr. Ghazal Patnaik. She's from Shankar Nethralaya, Calcutta, and she had a very interesting photo on ocular pearls. The second prize goes to Dr. Mayur Morekar, who had a photo on progressive outer retinal necrosis, and he's from Bombay Hospital Institute of Medical Sciences, Mumbai. Dr. Subina Narang, she's again a well-known figure in our society, and she had a beautiful photo on SLE presenting as bilateral combined vascular occlusion, and she's from Government Medical College Hospital, Panchkula. And congratulations to all the three winners. We really enjoyed going through each and every photograph, but these were very interesting photographs. And for those of whom have not really seen these photographs, please visit the virtual platform and see the photo gallery over there. This time we also introduced some tokens of appreciation for the winners. And this is basically to encourage our young participants. So we have three more winners. And I just wanted to, forgot to announce one thing, that Dr. Ghazal, along with the certificate of her award, she has also won a 5,000 cash prize, and so has Dr. Mayur and Dr. Subina. And as far as Dr. Samira Nayak, Dr. Lekha T, and Dr. Anamika Patel, they have won 3 tokens of appreciation for their beautiful photographs that they submitted for the competition. Along with the certificate, they would be winning a cash prize of 2,500 rupees. Now coming to the e-posters, the first prize has been won by Dr. Satabdi Nanda. She had a poster on unilateral CRVO with frosted branchitis in a young male post-recovery from COVID-19. She's from Prabha Eye Clinic and Research Center, Bangalore. The second prize has been won by Dr. Bhavna Vasudev, and she had a poster on post-pyrexil neuroretinitis, a type 3 hypersensitivity immune complex mediated ocular manifestation. She's from Narayan Nethralaya, Bangalore. A very hearty congratulations to both of you. And you both have won a certificate along with a 5,000 cash prize. The third prize has been won by Dr. Vivek Dave, who had a poster on application and validation of a novel inflammatory score in the clinical grading of infectious endophthalmitis, and he's from LV Prasad Eye Institute, Hyderabad. So very hearty congratulations to all the three winners. We also have 3 tokens of appreciation this year for, again, 3 more e-posters, which have been won by Dr. Kavaljit Madan. He's from Thind Eye Hospital. Dr. Amit Nene from Isha Netralay, Kalyan, Maharashtra. And Dr. Kajri Gupta, she is from PGI MER, Chandigarh. A very hearty congratulations. You all win a certificate and for your wonderful e-posters. And you also win a cash prize of 2,500 rupees. Coming to the challenging cases, I think we had some very good cases being presented yesterday in the meeting. The first prize has been won by Dr. Raji. We remember that she initially had some hiccups in getting connected and presenting, and I think it was one of the last cases which was presented yesterday. But I think all the judges really appreciated the case that she presented, which was on disseminated histoplasmosis, how an environmental fungi caused the havoc in an immunocompromised patient. And she is from Command Hospital, Central Command Hospital, Lucknow. A very hearty congratulations to you, Dr. Raji. The second prize has been won by Dr. Nikita Ayadurai. She presented a case on relentlessly progressive hereditary vascular dystrophy. She is from Advanced Eye Center, PGI, Chandigarh. And Dr. Sabia Handa, she presented a case on CMV retinitis in a patient with Good syndrome. And again, she is from Advanced Eye Care Center, Chandigarh. So Dr. Raji, she wins a certificate along with a 10,000 cash prize. And Dr. Nikita, she again wins a certificate with 8,000 cash prize. And the third prize by Dr. Sabia, she wins 5,000 along with a certificate. We also introduced some tokens of appreciation. So the next 3 best cases by Dr. Shrishti Agarwal. She, along with Dr. Saurabh Luthra and Dr. Shalin Shah, they have a token of appreciation. And they win a certificate along with a cash prize of 2,500. So these all tokens of appreciation have been introduced in place of travel grants that we have been giving in the past. Since this time we did not have anything like that. So I just have a hearty congratulations for all of you, and I hope your Sunday is made with the awards that you have won. As far as the free paper session that we've had today, I think it was a very lengthy session, but it was, beautifully taken over by the judges and some excellent comments we had. We had around 18 free papers being presented in the last 3 hours, or maybe I would say touching 4 hours. And we have various awards in the name of Dr. Carl Herbert and Dr. Narsingh Rao, but we have also added again 3 tokens of appreciation for the next 3 best free papers. And I'm sure, as Dr. Herbert was just mentioning, that he needs time to come up with the results. So maybe we will be getting the results back with us in about 3 days' time from all the judges. And through email, we are going to be informing that who are the winners for the best free paper presentation. So I just thank each one of you for joining us. Namaskar to all of you, and look forward to seeing all of you in person next year for our annual conference. Over to you, Dr. Vishali, for any concluding remarks.
Thank you, everybody, for your unconditional support for Uveitis Society of India. Thank you, Carl, once again, for evaluating the award that is in your name. That's not every day that it happens. Thank you, Professor Gupta, for being there. Dr. Ratinam, Dr. Biswas is 24/7 available to us, and all the past presidents, and of course, my executive committee, Kalpana, and ever smiling Sudarshan, besides Manisha, who has been very stressed because of the meeting, and our team, Hallmark, and sponsors. Thank you, everyone. Thank you.
Thank you.
Thank you.
And thank you. Thank you, and have a great year, and see all of you next year.
In person.
In person.
Thank you. Thank you, everyone.
Thank you. Good job. Good job. Thank you.
Congratulations. Very nice meeting.
Thank you.
So is my screen visible?
Yes.
Right. So just a few updates on the working of the society in the last 2 years. As I updated earlier also, that a uniform name has been put in order in the society's registration, and we have now a common name being shared of the society, whether it's the bank account, the PAN card, and the letterhead, which is now as Uveitis Society. But since the society, it also is more well known as Uveitis Society of India, we had to put the India in brackets because we did not really want to create a confusion and bring in a drastic change. The registered office of the society still remains at Bangalore, as was earlier. As far as the website is concerned, we have an update, and the website page has been all updated recently. And now we also have the details of all the webinars which are being conducted by the society. They are all being added there, and they are available and accessible to any of the members. A payment portal is there. So now if anybody in future hosts the meeting, you really don't need to create a separate, a website for the conference, and you can use the USI website itself for doing the registration, and there would be a payment portal available. All the annual conference details are also going to be made available at the website. As far as the new members are concerned, in the last 1 year, we had about 72 new members who joined the society in the year 18-19, which dropped down to about 45 in the year 19-20. And now it's very encouraging to see that in the last 1 year, we've had approximately 50 new members. So now we have a big number and a big family of 579 members in Uveitis Society of India. So I think the credit goes to all of you. The current membership fees is about 5,000. And as Dr. Vishali just mentioned, that we should all encourage more of our colleagues and students to become a member of the society. The scientific committee of the USI, as was decided in a Bangalore meeting, the chairperson is Dr. Padma Malini. It is co-chaired by Dr. Rima. The members are Dr. Salin and Dr. Bala. And we have 2 new members who have joined the scientific committee in the form of Dr. Soumya Basu and Dr. Parthu Pratim Majumdar from Shankar Nethralaya. And it was also decided that in future, whenever we are having a conference, there would be a representative from the local organizing committee also. As far as the executive committee is concerned, it comprises of Dr. Amla, Dr. Shishir, Dr. Padma, and a new member being added to the executive committee in the form of Dr. Somshila Murthy. We had announced and invited applications for the post of Joint Secretary of Uveitis Society of India. And this was decided in Bangalore meeting that we will be having this new post launched. So we invited applications, but we received only 1 application from Dr. Rima Bansal. So I would request somebody to propose and second her name.
Seconded.
I propose Dr. Rima. Okay.
Yeah, seconded.
Dr. Padma?
Yeah.
Okay.
I propose Dr. Rima.
So it is proposed by Dr. Padma and seconded by Dr. Shishir. So congratulations, Dr. Rima. So you would be joining us as the Joint Secretary of the Society. Now coming to an update on CMEs conducted under the aegis of our society. We had 11 CMEs conducted, and these were all physical meetings which were done from the year 2019 January till about January 2020 last year. And these are a few of the moments which were captured during these physical meetings. And we had a very interesting and a very well-attended session of our society in the year 2020 February during the AIOS conference. And I think it had an attendance of more than 100 delegates. I'm sure all of you would remember that we had to get in some more additional chairs where we had an ever-larging attendance for this particular session. Then we were badly hit by the pandemic in March last year, and all the activities apparently came to a standstill because of a complete lockdown. But we did not stop our activities of the society, and we published these guidelines for managing uveitis patients during COVID-19 era. And this was again contributed by many of the members of our own society. We also had a uveitis dedicated issue of IGO, which was published last year. It had around 11 review articles, 30 case reports, 15 original articles, ophthalmic images, and many other sections. And the issue editors for this particular issue was Dr. Vishali, Dr. Bala, Dr. Padma, Dr. Anirudh Agarwal, and myself. And I think, again, it was for the first time that we had an IGO issue which was dedicated to uveitis. So that was another thing which we felt very proud of. We had to change our way of conducting CMEs, and we shifted our guests to virtual webinars. And we did several of them right from June to September 2020 last year. The first one being on toxoplasma retinochoroiditis, which was in June last year. And then we did one on anterior viral uveitis. Then another one was on imaging, where we covered both OCT and OCTA, and followed by FFA and ICG. And subsequent to that, we shifted and joined hands with IUSG, and now we have a good series of about 10 webinars which have been conducted in the last 10 months, with one webinar happening every month. And as you see, there's a good amount of attendance, both of national and international attendees, and they are all very much well appreciated. This year, again, in AIOS 21, which was a virtual meeting, we had a national symposium by the members of our society, which was very well attended. And there were several instruction courses, again, on uveitis with chief instructors. Again, the members of our society, they were the chief instructors with several participants. Now, this time it was a surprise that we had this uveitis subspecialty day in the DOS annual conference, which was held last month on 28th of September. We had two sessions of 90 minutes each. One was on a basic uveitis course and an advanced course. And this was again very much appreciated. I got a personal message from Dr. Dadia that all the students who attended this two sessions, they were very much, they found them extremely useful. We also have an invite by AIOS to formulate certain guidelines, and I think we still need to work on this. But this is something we are all looking forward to, and I'm waiting to hear from the AIOS office. As far as the editorial board, which is again editor-in-chief, we have Dr. Bala, and senior advisors as Dr. Biswas and Dr. Ratnam. And he's supported by Dr. Ankush and Dr. Mamta, and I'm sure we'll be having a detailed report by him. We've had 3 newsletters in the past, and the first one being on toxo, followed by viral uveitis, and then on parasitic uveitis is the new one, which is going to be soon released. And I'm sure Dr. Bala is also going to be discussing about a compilation that he has worked on top 10 articles on uveitis in the last 1 year. Our members have been extremely active, and we've had several publications coming up from our society in the last 1 year during the pandemic. And you see there's a whole gamut of various uveitic publications related to COVID. And I think this is something very nice that all the members have been very active, even while during the pandemic and during the lockdown. And I think we well utilized the time by publishing a lot of articles. As far as coming to the recognition and awards of our members, I think last year, Dr. Padma, she won the Best IGO Award. And this was for her publication titled Berlin Nodule in Sarcoidosis. I just happened to get this FIFA runner-up award for a best video. And Professor Narsingh Rao, we congratulated him for becoming the interim dean of Keck School of Medicine, University of South California. And of course, I think Dr. Rupesh has been quite in news. He has won the first award, VSY Biotechnology Ophthalmology Award 2020 for his work on ocular tuberculosis in the form of COT study. It was again a great teamwork where many of our members had contributed to the whole publications and series of COTS. Dr. Rupesh has recently won the NHG Research Mentor Award of the Year also, and a very hearty congratulations, Rupesh, for having won this prestigious award. The virtual annual conference that we are right now attending, we are having a national faculty of around 43 and international faculty of 8. We had an overwhelming response where we received about 126 abstracts. We have had a very good number of oral presentations of about 18 papers, challenging cases around 9 presentations we had today evening. We had 69 e-poster presentations and about 30 photo contest participation is what we had. Now, as far as the awards during the USICON is concerned, since we won't be having any travel grants, we have introduced some new awards. Of course, the first Professor Amod Gupta Young Researcher Award was given during this conference, and it was given to Dr. Anirudh Agarwal for his excellent work. We've also increased the number of awards in each category of presentation, and this is just to encourage our young budding uveitis specialists. And we have added awards of appreciation in each category, right from free paper, case presentation, posters, and photo contests. I'm happy to also release the members directory of the society. It is all an updated compilation of the contact details of all the members of the USI. And this has been very kindly supported by the Cipla Pharma. And you will soon be receiving a copy of this particular directory. And I'm sure all of you are going to find it extremely useful to stay in touch with each other. So this is all from my side. And this is the directory. So I'm sure you're going to be happy to receive a copy of this. So moving on to Dr. Sudarshan, I think, for the Treasurer's report. Sudarshan, are you there?
Yeah, hi, thanks, Manisha. Seen? Slide is seen?
Yes.
Yeah. So, coming to talking about money after academics and other activities. So, something that is more interesting probably to see what is there in even in COVID period. So basically the amount of money which we received during this period has been predominantly with the membership fee and the webinar money which we got for from Allergan, and the sponsorship money for the USA newsletter, which was about 40,000. So the main money which we've got, we've been getting consistently every year has been because of the interest which has been accrued from the SB account, which is actually relatively less nowadays with savings bank account, and the term deposits, which is relatively better. So summing up all that, the balance at bank now is about 47, not exactly now, it is on 31st March, is about 47 lakhs and 83,000. Currently, today's message which I have received from the bank is about 52 lakhs. Okay. So the total amount in fixed deposits has been about 47 lakhs. So effectively put together, we had about 98 lakhs around that time. So the fixed deposits, when you have a breakup, we've not changed any of the fixed deposits which was there before the last few years. And whenever it has got over, we had put it on auto renew. We were thinking of accumulating and planning up in a different bank or in the same one put together during the pre-COVID times. But because of travel restrictions and other practical difficulties, we've not been able to do it. So, but it's continuing to be in the fixed deposit, and we've not changed any of that. Mainly the expenses have been, one expense has been one of the CME grant, but otherwise we have not had any of the grants which we have given up for any other CMEs. Webinar expenses, as Manisha just mentioned now, has been about 46,000, and Hallmark Secretariat fee is about 84,000. The other predominant, other main expense is the auditor's professional fee, Mr. Amol, whose fee is about 41,000. So this we usually circulate during the GBM. This is the signed copy of the auditor statement, which the B&L and the income and expenses. Since we are doing a virtual conference, I have added the same statements in the slides. So this is the auditor report. We'll actually send a mail of the PDF to all of you. This is the income and expenditure balanced this way, ending on 31st March 2021. Liabilities and assets, predominantly the assets have been the FDs, and the cash prices relatively the money which has gone out of us because of expenses has always been for good cause the last year. because the cash prices has been increased this year to support and encourage more participation from the younger fellows. Since the travel grants have been lesser, the cash prices have been relatively more, and that's actually helped the academic growth. So the next year budget depends on the programs and meetings. We don't know how it's going to be in 2022. It will be decided based on the COVID situation, physical or virtual. Thank you.
So just to add to that, Sudarshan, even for this virtual conference, we've been able to get sponsorship from 4 companies. So hopefully that is going to add to your bank account and bank balance.
Yeah, actually, that's what, there is quite an amount of added money from March 31st. So this was the details up till 31st March 2021. So now this comes in the next financial year. This will come. Hopefully it should be better.
Any comment from Kalpana?
No comment.
Okay, so I'll request now Dr. Bala to present his editorial report.
Thank you. I thank USI for having faith in me to present this activities on the USA newsletter and the website. A big thanks to the scientific committee, my teacher, Dr. Ratnam, who has been guiding me, and Dr. J.B. sir, who is always a pillar of support at any time. You can call him to get going the activities. Without the help of these scientific committee members, my activity would have been really difficult. I really salute them from the bottom of my heart. So the previous editions of this newsletter, we all know the first one was on tuberculosis, then we went on toxo, viral, and currently we are working on parasitic uveitis. Because now the lockdown has been lifted, a lot of the contributors got little become hectic, and we hope to finish it in the next few months before this year ends. So a small update on how this website revamping has started. This is how our Uveitis revamped website looks like, and there are multiple headings with membership details, the different resources available, all the meetings conducted, awards, and we have all the galleries, and we are planning to start the blog on the USA and the contact details. So when you scroll down the website, you go and see a list of publications which we are planning to add of all the Uveitis members, and the meeting details and the annual conferences upcoming, and what is going to be the recent one. So the basic details are also updated as you scroll down, and there is also a contact us details where members who have some queries regarding the challenging cases can post and get it answered by our elegant scientific committee members. And I request all the members to kindly post their queries so that we get multidimensional views from the different scientific committee members. So we are also having a YouTube page where all the early recordings are available. We are also planning to all have this other contacts through the Facebook and the WhatsApp link, and all those things are in the process. And currently, all of us can use the YouTube link where all the recordings are available. So to make this website interesting, we thought that we should start somewhere, and this thought process of compilation of the top 10 interesting articles of the year flashed us, and I have been trying to contact all the scientific members. I thank Dr. Padma Malini madam very much for getting the process started, and she has compiled the list. First one on the genetics in uveitis, second one on the newer SUN2, which most of us are aware and we all need to know about it. Third one, how the ocular drug delivery platforms are by Conrad et al., and few others are going to be there. But when they contacted all the scientific committee members, and they asked a very, very basic relevant question. What is the criteria to be employed? So actually, since we didn't formulate any criteria, I request all the scientific committee members to help to give their suggestion what they propose should be the proposed criteria to get this process done. So basically, the idea of this compilation is to make the reader get interested in the process of reading the latest updates of the recent happenings in the field of uveitis. So I have few other suggestions to be incorporated in the website. We have a link for podcasts frequently, like to be updated every 3 months or 6 months. So topic wise, a person can give his opinion on the diagnostics or management of a particular disease entity. And we can also plan to have a Q&A session on the challenging cases. We can also propose to have a registry of challenging cases. All our members' recent publication can be archived in our website as well. And last but not the least, for a beginner who is trying to get an interest, say tuberculosis or toxoplasma, what is the set of articles which this candidate must know on a particular topic, say chosen 10 or whatever particular number, they can suggest so that we can display them so that the website viewership increases and it is really useful for the uveitis community. Thank you so much. All your suggestions are received. I'm ready to accept at any point of time. Please feel free to contact me at any point. Any suggestions are always welcome at this time.
Thank you so much, Ala. I think we have a few questions being posted in the chat box. One is from Dr. Shahana. Shahana, could you unmute yourself and...
Yeah, Manisha, I was wondering, can we restart the subscription to the journal Ocular Immunology and Inflammation that we had for a while?
Yeah, so if you remember, I think this was very extensively discussed during the Bangalore meeting. And the amount that was being paid was a huge amount in comparison to the number of members who were actually accessing it. So that is why I decided that, and a lot of members also complained that they were not able to access the journal. So that is why
maybe that was the reason why people did not access it. There was a technical glitch.
Yeah, but I think the amount was too exorbitant because it was being charged for a minimum number of the members, and even that many number of members were not accessing it.
Okay.
I think I'll just add on to this. Actually, there was extensive discussions on this for the last 4 or 5 years, 4 years, I think. And we were paying close to around 20 euros, I think, if I'm not mistaken.
Per member.
I think, yeah, per member. So it comes up as a big cost for the society. And many of the institutes had an access already. So they volunteered to, help, those who cannot access this. So that's the reason I think generally a call was taken to stop the subscription.
So whom can I approach? Sorry. Who can be approached if we want to get the full text from any of the members?
Yeah, please contact the USA website or me, Dr. Balamurugan, so we can help you.
Okay. Thank you.
Dr. Biswas, I think you had written a mail to me, sir, regarding some collaborative research work being done or to be done by the members. If you want to take up that issue, sir, right now.
Yeah, I think I'm impressed by the Japanese Ophthalmological Society. They do a lot of collaborative research work like ARN, lymphoma, primary vitreoretinal lymphoma. I want to know that whether we can take up some of the rare cases and like Azure or primary vitreoretinal lymphoma so that we can get a very large collection of big data, and with the universal form fill up, and then we can be an international publication in the good standard. And this can be an asset to our understanding also. So this is my proposal, to choose some subject, some disease, and all the members, as many possible, can contribute to that one, and try to get some good big data publication. What is the opinion from others? Bishali?
Yeah, I totally agree. We should have the youngsters getting involved, helping in designing the protocol, working with senior people, getting the data, and then what?
Publication is the showcasing our strength. Even the before the more our so presentation would be forgotten after a year or so, or so publication will remain the gold standard.
That's right, sir.
So the youngsters can take up and we can join.
Anybody volunteering it to start the first project, which should be a kind of a pilot, and once we know how it goes, it will become easy to follow other topics. So Dr. Biswas wants to do, but he needs somebody with him. So anybody who will be volunteering to do work.
So the junior people can coordinate.
Somebody is saying. So maybe from your team only, Dr. Biswas, you will have.
Yeah, I'll just try to see that Partho can get.
Perfect.
Yeah. He's computer savvy person.
So whatever topic you tell us, we will all contribute.
Yeah.
I think if there are no other points for discussion, I think we can conclude the GBM.
Manisha, can I just, sorry, I'm traveling, so I'm not so sure how clear my voice is. So we had quite a number of young members who wanted to contribute and to get into the committee at various points. So, for example, Minija had reached out to me. So I think it's great that the younger members would like to contribute. Moving forward, my proposal for the entire USI is to look at it now as a more organized body. We're quite, we have gone through several years now, and it's high time I think we move to the next level of starting on with having an elected executive committee with all the posts, just like any other seasoned society. So that can have more youngsters, and it won't be. So, for example, when you announced about Rima being, I don't know if I'm connected.
Yes, you are.
Okay, sorry. So when you announced about Rima, so I didn't have a recollection at all about any email. So luckily you clarified saying that it was decided at the Bangalore meeting. But a lot has happened since the Bangalore meeting. So I think this application could have been sent out to more members, and you could have had more applications. If you had only one,
I'm sorry to say that it was a mail which was sent out to me to all the members of the society.
Okay.
And not only one mail, I sent out even 2 reminders subsequent to my original mail because I had not received any applications. And to the extent even Rima's application had gone to my spam box. So when I sent out a reminder to everybody that I have not received any application, that is the time when Rima told me that she had already applied and it had been lying in my spam box. So I'm surprised when you say that you did not receive the mail.
No, I'm not saying it did not receive the mail. I'm saying that it may not have reached my attention. Same problem going to the spam. The institute email boxes, it just goes to spam very, very easily. So unless we keep on retrieving, the same problem. I may have missed it. I admit that. So my point is not that at all. It's great that having Rima as joint secretary will only add value. My point is that the younger generation coming in, how to get them to be interested and how to get more youngsters would be to have them join at various stages into the committee that decides, that makes decisions, because they have a lot to contribute as well. and they're eager, like as Dr. Vishali said about new studies. So we should really have somebody with new energy to take it up, to run this research, because it's not going to be easy for anyone already very well entrenched in their careers at institutes to take it up as a new project. So that was my point. So my item for the GBM is, if it can be recorded, is that we should start looking at having a more organized society. So that will mean that even the bylaws and everything, we'll have to look at changes there. It's a proposal, and have a elected committee sometime down the line. I think we're reaching there.
You know, Somshila, I think we do have a very well organized society. And for the last few years, we have been working very, very hard to sort out all the financial and the issues with the ID and the PAN card and lot other issues which have now been sorted, streamlined. We have been involving all the youngsters in the webinar being done. Young Researcher Award was one such move to bring out our young researchers in the field. And now that Dr. Biswas has floated the idea, it will all go to young, and the only person who volunteered among the young people who are here is Bala. So naturally it goes to Bala. So I think society is very well organized. I don't think, I mean, of course, we will improve it, but to say that we need to organize it, I think it's a well-organized society. The second part, which you said is most welcome, I think Manisha said the mails got missed. So probably as far as elections are concerned, so Michelle, that is when there are more than one competitor for the same post, then you have elections. But if you have only one person applying for the post, it is for the executive committee to decide whether that person meets the criteria. And if the person meets the criteria, he or she takes up the post. Then there is no question of holding any elections. And we have chosen very young people as our zonal representatives, you know, who will be representing USI. And because of COVID, you know, that did not take off, but we are all for involving young people in it as much as we can.
I'm very satisfied the way the scientific program has been organized. A lot of, I just don't know the name earlier, and a lot of the new people are presenting, and they're presenting so well. And that, like, you know, that you have been kept, the senior people has been kept to the chairperson very rightly. And so it's very heartening to see that the new people are getting encouraged.
Yes,
So
program
that's the way to go.
We all have stepped aside for the program also.
Yeah, sure. That's the correct approach.
No, there's no doubt. I think when I use the word organized, I did not mean it the way that Dr. Vishali, you considered it. I apologize if I said organized in a way which suggested that it's disorganized. Not at all. Far from it. I think I have to congratulate Manisha first. That should have been my opening statement, because not only during COVID times, but even just before that also, she had been doing a great job in organizing it, as you said, with our PAN card issue and setting things right. And I think she's got the website really up to a much better stage, and with getting in Bala to run the newsletter. So and of course the webinars that she's been managing and conducting so well. And I think the icing or the cherry on the cake is with the USI meeting this year. So that organization is fantastic. My point was exactly what all of you have already agreed. And I think I rest my case that we just have to, as you said, have the newcomers come in and give them more visibility in the society leadership. That is probably my point. And it need not be elections. And as you said, that if there are more than one people wanting a particular post, so then that's when that we need to have an election or something like that. So maybe for the future, there's a plan for the future. Being COVID year, I don't think we should change anything.
I think Dr. Salil wants to make a point. Please go ahead. Yes, Dr.
I think one way out of this would be to simply create one post on the executive committee or on some other committee and reserve that for somebody who's below the age of 40?
Salil, you will have to look at the laws, that we have set for ourselves. There's a minimum number of years a member has to be there before they become a member of the executive committee. It's exactly
or any
the
of the
reason.
committees for that matter.
Yeah, so you could have but the executive committee requires a minimum number of years to be a member.
So you
Like
can put them on any committee. You can simply have them as a ex officio, as honorary advisor, something.
Dr. Shishir, please go ahead. You wanted to make some.
Manisha, I must compliment you for making this webinar meeting fantastic. And let me tell you, I've attended a large number of USI meetings, but I'm learning a lot more by, concentrated time that I'm giving in front of the screen. I wonder if in the future meetings, we can have a hybrid meeting. We had discussed this in the past. And it's not just because of COVID, but people may not be able to travel. And can we have a hybrid meeting in future? Is that a possibility? Vishali, Manisha, what do you think?
Should have it. It will make the international participation much more easier, and probably we will be doing some service to Mother Earth also.
Correct.
Absolutely. Absolutely. Agreed. So I think when is the next meeting? Generally in a GBM, we decide the next year's meeting, but I think maybe it's
coming to that. First of all, Shishir, thank you for, appreciating the meeting, because this was our first experience also of conducting a virtual meeting. And thanks to Dr. Vishali for all her expert guidance, because we were all very confused how to be going about conducting the meeting. As far as the next year is concerned, even this year, actually, I was thinking and looking into the possibility of a hybrid meeting, but because everybody was saying that there's a possibility of a third wave, it would have been very difficult to do a booking and then, call it off at the last minute. So that's why it was decided that let's play safe and have a virtual meeting. Next year, again, it was decided that it's going to be in the first week of October. So that is when it's going to be planned next year. But I think it's too early right now for us to take a decision. Maybe a better time would be somewhere in January or February.
In February, we will write to all the members inviting. And my personal opinion is, till the time things are turbulent, it's best to organize it in a institute that has auditorium, where you are not stressed about paying advance and number of people, commitments. So instead of hotel, we can book any institute depending on the location or wherever. So that might be a more practical approach. We are doing the same for IFU also in Brussels. We have moved it from Singapore to, not Brussels, Netherlands. So even there, I told them, you follow the approach, do it in the university, whether 50 people attend or 200 attend, you are not committed to, paying the minimum for minimum number of people. So something that we will need for us also.
Yes, Dr. Ajay, you wanted to make a
comment.
Yeah,
I am an old young member of USI, because I'm old, but I've joined USI. I've been active in USI only recently. So I just wanted to congratulate Manisha for the wonderful thing. I've not, some of us have not been able to attend the USI meetings for last 2 days for some part of it. Just wanted to ask you, will it be available in the YouTube for the members?
So Dr. Ajay, since this is a paid meeting, if I make the recording immediately available, then I think the members are not going to be very happy who have paid for the meeting. Subsequently, yes, we do plan to, upload the recordings on the website, but it's going to be a few months later.
And those who are paid, will it be available for them?
I haven't really thought of it. Maybe we can think and take a decision.
All right.
We did not think about it, but maybe we can figure it out.
No, just a suggestion, and congratulations. Fantastic, superb meeting, and wanted to congratulate you. Learning a lot.
So thank you, everyone, and thank you for joining so late. And I'm sure everybody is looking forward to their dinner and a good sleep.
They are going to fight.
Want to say something, Manisha? Please join. Sorry, ma'am?
Dr. JB saying they are going to fight. Who's fighting?
Shubhra is telling that going to fight internet, WhatsApp and Facebook, and then there's a fight. So I have just, she's coming in front of me. So
I thought you.
That's overheard.
I just want to.
My wife is asking me to quit the meeting.
Sir, listen
the next meeting will be, where will be the next meeting?
So we'll decide it in around January or February.
Yeah.
We can come to internet rally, sir.
Yes.
We can take a voting kind of thing. That option you can take.
Right.
You can just send a mail and then we can see how many people want what.
Anybody?
Yeah, ma'am, I want to thank USI, Dr. Vishali ma'am, Dr. Manisha, Dr. Shishri, Dr. Padma for seconding my name, and the entire USI board members for electing me as the joint secretary. Thank you very much.
It will give you a lot of work.
Very good night to all of you, and see you at night tomorrow morning.
Good night.
Okay, bye-bye. Good night.